കോർത്തു ഞാൻ ഇന്ന് പാടാം.
All the scientific deliberations today will be broadcasted live on YouTube Live.
Respected senior members of IMA, my dear friends and colleagues, at the outset, let me thank the organizing team of this prestigious event of IMA, AMSCON 2022, for giving me this opportunity, especially Chairman Dr. Shanawaz, Dr. Shaji, Dr. Qasim, and all the organizing team members. And also the President of IMA PERINTHALMANNA, Dr. Nasser sir, Dr. Jalil, and the office bearers of the branch PERINTHALMANNA. The senior most ENT surgeons of the state, Dr. Mohiddin sir is here, Dr. Seedi sir is here. As in every other specialty, ENT also has expanded and extended its wings and horizons to different areas and even the subspecialties, and even encroached the neighboring specialties. And as we all know, all this was possible because of the better understanding of the disease process and the better understanding of the pathophysiology, and of course the newer advancements in the investigation modalities, especially the imaging. And also for us, actually the endoscope was a real game changer in ENT, because as we all know, the ENT area has very hidden corridors. The nose, meatae, turbinates, even we found very difficult to learn ENT anatomy during your MBBS curriculum, even during our post-graduation curriculum. The microscopes and the micro drills, and especially the powered instruments and the navigation system, as in other specialties also, but in ENT, even millimeters of errors can land up in disasters and severe complications and very bad patient morbidity. To add to this armamentarium, the laser and the coagulation technology also had changed the face of this specialty. So the specialty has grown to subspecialties like otology, otoneurotology, rhinology, facial plastic surgery, head and neck surgery, especially head and neck onco surgery, then the laryngology and phonosurgery, and the skull-base surgeries, including the lateral and the anterior skull-base surgeries. So this was the scenario we used to see and witness, at least in some of our patients. They were communicating. പോയല്ലോ എന്തോ പറ്റി ഒന്നോ Unfortunately, they were born deaf, and this was the way of their communication. This changed too. This little girl was also born deaf. Actually, she had a lot of comorbidity, disabilities, core disabilities, like she was physically challenged, she couldn't walk, even now she can't walk. Girish is
ചെവിയിട്ട് വെച്ച് തന്നു. അപ്പൊ സുഖായിട്ട് വർത്താനം പറഞ്ഞു, കേട്ടു, വീഡിയോ പറഞ്ഞു. Thank you, Dr.
This was the message she sent to me during the last World Hearing Day. See the confidence and the way she speaks, the language she got. So pediatric hearing loss was a big problem in the past. Even now, almost 6 out of 1,000 children are born with disabling hearing loss, which need some supportive measures. Now the things are totally changed to some extent because most of the preventable hearing loss are taken care now. And the pediatric hearing loss, the issue is that often we undiagnose or misdiagnose, or even we diagnose very late, so that the crucial period of language acquisition is lost and the language become very bad. So here, I thought I will skip some text. I will show some pictures and videos which may be very useful. So that is why there is not much text in my presentation. This small boy was brought with a speech defect. So the parents were very confident he is singing good songs. But you can see the legibility is poor. The language is also not good. But the parents thought that he wants some speech support. But actually he had a mild to moderate bilateral sensory neural hearing loss. Then he was supported by hearing aids. So he got better hearing. But his speech is poor. You can hear that. So that cannot be cleared to a greater extent since the age is little more. Here, see this child, this boy. He is using a hearing aid. You can see that he is using a hearing aid in the right ear. But still his speech is not legible. Sound കുറച്ച് So here what happened is that he had a severe hearing loss and he was using hearing aid. If he had implanted, his speech was good. So that was maybe a mismanagement. So according to the degree of hearing loss, the age of hearing loss, all the treatment options differ. So now, fortunately, our state has autoacoustic emission as a screening tool in almost every hospitals. And this is not the scenario in the entire country, unfortunately. And we have additional investigation tools to detect pediatric hearing loss, like brainstem evoked response audiometry and the auditory steady state response audiometry, and even cortical response audiometry. So these were another addition to the investigation tool to diagnose the hearing loss in very early age and to intervene at the earliest. According to WHO, in adults, the most dreaded or the most feared issue is the hearing loss due to recreational noise, chronic loud noise exposure because of environmental, occupational and even the recreational noise. So I just wanted to, because every World Hearing Day, the WHO warns about this and advises the professionals to take the precautions needed for that, especially in patients, young adults, young youth, and also the people who work in occupational hazard, as an occupational hazard of hearing loss. The imaging, as I mentioned in the beginning, imaging actually has revolutionized to detect the etiology and also to detect the pathology of the issues. Now there are softwares available even to unroll the cochlea, and you can find the length of the cochlea, and you can find the diameter of the cochlea, and also you can detect the cochlear nerve thickness, whether the cochlear nerve is hypoplastic or aplastic. So even if the cochlea is normal, if the nerve is hypoplastic, you won't get even a good result by cochlear implant surgery. So the imaging has a big role in the very commonly, but now the CBCT has special softwares for the temporal bones, for the sinuses. So here the radiation is about 79% less compared to the multi-slice conventional CTs. And also the exposure time is less compared to the conventional CT. And also the slice thickness is 0.075 millimeters. So you can study your disease or pathology in such a very minute cuts, minute sections. You will get axial, coronal, sagittal, and you can even reconstruct the CT. It's very not expensive also. So this is also very, even you can see the electrode position in the cochlea, whether it is scala tympani or scala media or scala vestibuli, like that. So this is also a additional tool came to the armamentarium of ENT recently. So initially, there was no team approach. But over the past decade, now when a child comes with, or a patient comes with hearing loss, we have a team approach like the audiologist, speech language pathologist, pediatrician, general practitioners, clinicians. Of course, the teamwork has changed the scenario to great extent. Then the other innovations happened in the otology, maybe the hearing aid innovations. You will get invisible hearing aids, completely in the canal hearing aids. Now even the AI is incorporated to the hearing aid. You will get a fall alerts, you can get a body and brain tracking facilities, and even you can transcribe your conversations into your smartphones as text. And even the language translations facilities also available in the latest hearing aids. Then the otology, of course, we mentioned the cochlear implant surgery. This was the real miracle in medical science. That was the sense organ replaced by an artificial implant. This was the first sense organ. So I will just show you how a cochlear implant is, because you may be hearing cochlear implant many times. So this is a simple small incision in the postoral area behind the ear. Then we open the skin. Then we take two flaps, one skin flap, one musculoperiosteal flap. Then we expose the bone. Then we use the microscope. We do the cortical mastoidectomy, which is a simple surgery in the mastoid, which we routinely do for our chronic otitis media. So that is the mastoidectomy. Then we drill another hole into the middle ear to find the cochlea and the round window membrane. That we call it as facial recess approach. Facial recess, through facial recess we go to the middle ear, and you can see the round window membrane here. This is the round window membrane. So we drill the overhanging of the round window. We expose the round window, because the round window, initially the cochlear implant was done through the cochlea. We drill the cochlea itself. So the acoustic trauma is more, and we were not sure whether it sits on in the scala tympani. So round window itself says that your electrode is in the correct position, curling the modulus and stimulating the spiral ganglion. This is the bed for the implant. We drill again behind the ear. So according to the company, there are different shaped beds. So this is the world leader company Cochlear. They have usually the most of the implants have a circular shape. So we drill the bed for the implant. Then we instill some steroids to prevent acoustic trauma. Then we incise the round window. Then we take the implant. This is the implant. You can see this is the cochlear implant. And we secure the implant. Then this is the round window. We open. The round window membrane is opened. Then you can see the electrode. This is the electrode which stimulates the cochlea. It stimulates the spiral ganglion and the residual nerve fibers, so that the deaf person gets the hearing back. And we make sure that all the electrode is inside. Then we plug the area with soft tissues. Then we check whether all the electrodes are inside on the table itself, and we check the impedance and the neuron response NRT telemetry with the software system. Then we confirm that all the electrodes are inside the cochlea. Then we extubate, and my anesthetist Dr. Shabir is also here. Nice to see you, because this pediatric surgery, because we have a bilateral implant freely available from the government. So in a 1 year, we had a surgery, 1-year-old child got bilateral implantation yesterday, 6-7 hours surgery. So the anesthesia part is also very important. So that was about the cochlear implant. Then the next addition to this hearing distortion surgeries was bone conduction devices. Initially, when a child comes with bilateral microtia, bilateral anotia, or bilateral EAC atresia, there was not much options. So all these patients will be having almost severe hearing loss, mixed hearing loss. So for them, the cochlea is normal. The nerve is normal, only the external passage is defective. So in these patients, initially there were some devices which help for bone conduction hearing, but with lot of wires, with boxes, they were not happy. Now bone conduction implants are available. This is surgically implanted inside, and you will get the hearing back. So this is one of our patients. You can see the implant here. It's only a small screw like this, and there is a small processor. So if you grow your hair, it is almost invisible also. So non-surgical options are also available. Like if the child is small, if the skull thickness is not adequate for a surgical implantation, we give non-surgical devices like the Baha other system, then the metal other system, Baha soft band system. Here you can see this is on a band. This promotes the bone hearing, and the sounds is carried to the cochlea, and the child can hear well. So till the child is attaining a adequate age for the bone thickness, till then you can use these devices, which is non-surgically implantable, and patient can get hearing, and the language acquisition will be definitely better compared to non-usage of these devices. So these are all available now. Here you can see this child is wearing this Baha soft band. Yes, the child has a bilateral microtia and anotia. You can see the child is not looking to the face of the parents, but the child is hearing through this implant.
Pink color, pink car.
So these are all available now. These are all newer addition to the patients or children born with microtia or anotia or conductive congenital anomalies. The journey of the implant surgery or this surgical career is always not happy. You will get a lot of complications because this is implanted till the life of the patient. So either till the death of the patient or till the death of the surgeons, they will be around you. So you have to face this challenge also. Lot of support programs are available. The Kerala government has a beautiful program called Sudhirangam program. Under this program, the children below 3 years will get free implant. And below 1.5 years, they will get bilateral free implant. And in the ADIP scheme, the central government scheme, below 5 years, they will get a free implant. They need not pay anything, even to the private hospital. So, and the V-Care program helps to support deaf people above 5 years in Kerala with a special committee, select the patients, and if they are if they are eligible, the government can support with Baha and other type of hearing devices, even surgeries. So the vertigo. Vertigo is another very common problem we come across every day in life. Not only ENT surgeons, physicians, general practitioners. Initially, we used to give a lot of vestibular sedatives as medicines for months and so on. But nowadays, better understanding of the disease, especially the peripheral vertigo, better understanding of the pathophysiology, and simple clinical tests also will help to differentiate whether it is a peripheral cause or it's a serious problem in the central part of the brain. So even simple clinical tests may be most of us, especially the older generation, even myself, was not much aware of this simple clinical test when we learned MS. But now you can see all this is very easy to diagnose. Even everyone can learn this simple clinical test to diagnose the peripheral vertigo, whether it is a peripheral or central. Even if it is peripheral, you can pinpoint which ear is affected to cause this vertigo, and even which canal of we know the posterior semicircular canal, lateral and superior semicircular, which semicircular canal is affected. According to that, there are some exercise or adaptation maneuvers by which you can correct the vertigo on the table by itself, so you need not give lot of medications. And this is VNG, vestibular histogram. This is also another additional tool to evaluate the nystagmus of the patient and also the vertigo of the patient. Then one innovation in the ENT was CP angle endoscopy and lateral skull base surgery. So either you can approach through the ear in lateral skull base surgery to the CP angle, to the internal acoustic meatus, and also you can go behind the sigmoid, retrosigmoid, to evaluate the disease and also to treat the disease. Like the vestibular nerve section, vascular compression syndromes. Of course, this is the CP angle endoscopy. You can see beautiful pictures in endoscopy, lower cranial nerves and the vessels. Of course, you need a extensive training for this, and also you should get your support and the presence of your neurosurgical colleague to proceed this type of surgeries. This is the small hole behind the sigmoid. This is the micro craniotomy, and you enter into the, I am just showing the, you reach the CP angle here, and you can see the vestibulocochlear nerve here. So there is a cleavage between the vestibulocochlear nerve. Then you identify that cleavage and divide the vestibular nerve. This is the last resort for intractable Meniere's disease, if the vertigo is not controlled by any sort of medication and you want to preserve the hearing. This is the anterior skull base surgery. You can see the CSF leak dripping. Initially it was done by a craniotomy. Now we do, of course, in some cases you may need the neurosurgical support also. So here you can see the large meningocele in the nose. The endonasal endoscopic approach, lot of advantages. We will get lot of vascularized flap like Haddad flap, and you will get lot of tissues like the cartilage bone from the nasal cavity. Here you can see this is a large defect, multiple dural defect. This was off, and here you can take the skin. Here you can take the cartilage for the support of the defect. This is another advantage of endonasal procedures we do. So this is the cartilage taken to support the defect. Here you can see the cartilage. Then you take the flap, then support with fat.
Dr. Sarfo,
Then
excuse me. Dr. Sarfo, here. 2 or 3 minutes more.
Yeah.
Time is over.
Yeah.
Thank you.
So as I told, the coablation. Coablation is a very useful, it's not very expensive instrument. You can see the most of our ENT surgeries now, especially the oral surgeries, oropharyngeal surgeries, adenoidectomies, tonsillectomies, you can do without much blood loss, maybe 1 or 2 ml blood loss. And it has suction, it has irrigation, it has coablation, coagulation, cutting, everything is one tool. That's the magic wand of the coablation. So the phonosurgery, I told the voice. Initially, there was a lot of limitation over voice surgeries, but this patient came with vocal cord palsy of unknown origin, and this I think the voice is not clear, so audio is not clear. She, after 3 months, this is without touching the larynx, you are altering the tension, length, and even the dimensions of the vocal cord by putting some implants outside. That is the phonosurgery, principle of phonosurgery. Then, of course, the facial plastic surgery I mentioned, because as the septum goes, the nose goes. most of the time there will be functional problems of the septum also. So ENT surgeons are now getting more specialized in facial plastic surgeries. So that's all. So as a specialty, ENT has evolved significantly over the past decades. This all happened because of the tremendous and enthusiastic work of lot of doctors and engineers, and also this keeps us, the innovations and the additions and the newer things keeps us more into the specialty. And as a doctor, we should be always have a fire in the belly to learn newer things and the newer innovations. Thank you for your patient listening.
Thank you, Sharfuddin. Dr. Sharfuddin, thank you very much. With the permission of the MC, may I acknowledge the presence of our national past presidents, the leader of leaders, Dr. Marthanda Pillai. Okay. And Dr. Alex sir also here, past state president. With the permission of the chair, past president Dr. Rashid. Okay. We are running short of time, so 2 or 3 questions. Over to my fellow chair.
Thanks, Sharaf, for a wonderful talk. I think still more has to come in ENT, since we are also ENT surgeons. I think still a long way to come out. Okay,
Any
if there is any questions, I think we can wind up this session.
Okay, thank you.
Okay. I think there is no questions. Okay, thank you, Sharaf.
Thank you.
Chairpersons, please stay on the stage. Please, to give a memento to the speaker, I request Devadas sir to kindly hand over a memento to Dr. Sharifuddin. Dr. Sharifuddin sir, please come on stage. And Dr. Shamsir will hand over a certificate of presentation. I request VOCD sir. I request Dr. VOCD sir to kindly give a token of our appreciation to Dr. Devadas sir. And also to our co-chair, Dr. Shamsir. Ladies and gentlemen, each talk of today's deliberations lasts about 20 minutes, and about 5 to 10 minutes is for discussions. The more your talk go beyond the 20 minutes, time for discussion will be less. And also please note that immediately before the lunch session, we have a quiz section for which fabulous prizes are awaiting you. So please pay good attention to the talks. The next talk is by Dr. Moinul Haq, who is a consultant neurologist at EMS Memorial Cooperative Hospital, PERINTHALMANNA. And the topic of discussion is acute stroke treatment. To chair the session, I invite Dr. Binish, neurologist from Maulana Hospital, and Dr. Rauf, who is the physician from MES Medical College.
Very warm good morning, everyone. Next few minutes, my team and myself will be talking to you regarding the current practices in the field of acute ischemic stroke. I am the co-director of Interventional Neurology Fellowship Program, and with me there are few of my colleagues and also the director, Professor Shakir Hussain. Our team, along with the organization called SNP, was based at Delhi and having operations at multiple places, including Ayerlanga University of Philippines, Dhaka University, and in India we are having a MOU with Nimans Bangalore also, besides few hospitals in Kerala. This is a non-charitable organization where we are planning to avail a high quality treatment which is not otherwise available or affordable to the common people, and also we are engaged in manpower training. With this, let me go to the topic. Let us see if a person is coming to us, a middle-aged male is coming to us with a aphasia. Voice on. I am asking him to put out the tongue. He cannot obey. Occasionally he is obeying to put out, opening the mouth only. But as you could see that his right side is completely weak. So what will happen to a middle-aged male coming to us who is aphasic and not moving on to the right side? And if he remains crippled for the rest of his life, who is responsible? And how to prevent him from becoming a crippled person for the rest of his life? Answering these three questions will be my talk of today. So for this, we should know that what is the patient having? Is it a stroke or not? And if so, what type of a stroke it is, and whether it is a large or a small vessel disease. So if it's a, is it a stroke or not is the first and most important question. Here comes history, clinical examination, and few of the biochemical examination to exclude the other possibilities also. So, but here in acute stroke, time is brain, and every 1 minute of large vessel occlusion, we are losing 1.9 millions of neurons. So we have to be having a very short and crisp history, which should be completed within less than 3 minutes when acute stroke is suspected. And what type of a stroke, whether it is a ischemic or hemorrhagic, both are treated separately. This has to be done by imaging, mostly MR or occasionally CT. Globally it is a CT, but in our department we normally follow with the MR, which has a lot of advantages also. And then comes whether it is a small vessel or a large vessel. That's again very important for the treatment aspect. Here we should know, we should do a MR angiography or a CT angiography, and in rare situation a cerebral DSA also. As we already said, 80% of the stroke are ischemic, that we all know, due to the occlusion of the vessel, and 20% are hemorrhagic. Even in the ischemic, the etiology of the stroke is again very important for the treatment. A treatment of atherosclerotic stroke is not treated by like a cardioembolic stroke. So is the hemodynamic stroke. In some of the hemodynamic stroke, it is better not treated even, which my team and colleagues will be explaining to you how we can keep away and from a costly treatment and keep the patient better also. And even in the ischemic stroke, treatment depends how large you have a core, how large you have a penumbra, and how large you have a benign oligemia. For an ischemic stroke, core is the area which is already lost. You can't do anything for that. But for every early onset stroke, there will be a large area of penumbra where the tissue can be salvaged with the appropriate treatment if given in adequate time. And our entire idea is to save the penumbra. And benign oligemia is normally will be improved with the treatment itself. So, as I already told you, one has to be very fast in recognizing the stroke, whether it is ischemic or hemorrhagic. And here comes the faster. One has to be faster in recognizing the stroke. F for face drooping or any deviation of the face. A for arm drift if there is any weakness of the arm. S for stability or ataxia. And talking or speech, whether you have comprehension or whether, as in the first patient, your speech is completely lost or like that. E for eye movement, again very important, and this is the time to recall or react immediately for medical help. So, if given the proper treatment, let us see how the patient will be behaving after intravenous thrombolysis. Voice on, video. Now you can see that he is answering. The person was not answering at the beginning. Now he is moving the right upper limb. So in less than 6 hours he has completely improved with intravenous thrombolysis. So this is done by two molecules, TPA and tenecteplase. So intravenous is to be given for every indicated patients who are coming to us within 4.5 hours from the onset. And if the patient is having a large vessel occlusion, which can be suspected clinically and confirmed by appropriate imaging, we have to do up to 6 to 8 hours. We need to do a revascularization by mechanical or intra-arterial thrombectomy, where we have to go through the vessel and suck out or take out the thrombus. If a person is not improving with intravenous thrombolysis, or if we suspect or if we confirm that he is having a occlusion of a large vessel, we can either go directly to mechanical thrombectomy, or we can do what is called bridge therapy, where we do intravenous thrombolysis at the beginning if the patient is in the window period for intravenous thrombolysis, and then immediately take up for a cerebral DSA and see whether the blockage has been opened. If not, go for the mechanical thrombectomy. And if the patient comes more than 6 hours, still we can do up to 24 hours for patients who have a large perfusion mismatch, which is confirmed by a perfusion scan, advanced tissue imaging, where you can see still, if you can see that the core is small and you have a large penumbra, again you can save the patient by doing a mechanical thrombectomy. So how the mechanical thrombectomy is being done is basically by two methods. One is by stent retriever. Yeah. Isn't the video playing? Yeah. Okay. Yeah. Somehow the video is playing in full. I wanted to play it only latter after the. Now you can see a thrombus. It's a cardioembolic stroke-like thing. Some emboli going all the way through the internal carotid artery. It's going to the middle cerebral, and at the bifurcation of the middle cerebral, it's getting occluded, and that causes a stroke. So here we use a retrievable stent like this. We go all the way there, and we put the stent across the lesion. I am not going into the full details of the procedure for a mixed group. Yeah, unfortunately, now we are deployed the stent, and now once the stent is engaged onto the clot, we'll remove the stent along with the clot. That's how we open the stent. This is the first and most important method. Second is actually aspiration. Here, instead of using a retrievable stent, we use a large bore aspiration catheter which goes very close to the thrombus, and then switch on a suction pump, and with the help of that active suction pump, you take away the thrombus. But quite often, we as a team are using both the method together actually. We use the retriever and also the suction pump in first go, because we believe that the first attempt is the best attempt. So to save time, we normally go with both the approaches if possible. So now we are going towards the thrombus. We are crossing the thrombus with a micro wire. Then following that, we will come with a micro guide wire. And along with these two support, we will come with a large aspiration catheter. Now the aspiration catheter is coming, and it is coming all the way proximal to the thrombus. And then you take away the inner two catheters, and with the suction on, you will be aspirating the thrombus into the pump actually. So this is how we do a aspiration. So for a real life example, this is one patient, you can see this is middle cerebral artery is completely occluded. This patient was actually had a stroke sometime in the afternoon, and he went to his primary physician and referred to the neurology, from where intravenous thrombolysis has been given. In spite of that, unlike the previous patient, he remained aphasic and hemiplegic. So we immediately took up the patient for thrombectomy. One can see the stent and also the aspiration. This is the stent retriever, and you can see the aspiration also. So here we use the combined method of aspiration as well as stent retriever. And this is how in first aspiration only. So he had a very good recanalization. And this is how when the patient came to us, it is after intravenous thrombolysis, and he improved on second day itself, got discharged on third day, and seventh day when he came, you cannot recognize that he was having such a devastating stroke a week before. With this, friends, I have completed 15 minutes of my talk, and rest of my talk will be with the prayer permission of scientific committee convener. I invite my colleagues to present a short 3 cases. Please come, and we will be completing within our stipulated time. Please come.
Okay. Very good morning, everyone. Today I'm going to present a short case of internal carotid artery dissection, which is a case for antithrombectomy therapy in the era of invasive procedure. So myself, I am Dr. Abhilash. I am a fellow in Stroke and Neurointervention Foundation at EMS PERINTHALMANNA. So here we have a 50-year-old male from Kannur. He is a non-hypertensive, and he presented with sudden onset left hemiparesis upon waking up, and he came around 2 days after the lesion. And on examination, he was conscious and obeyed commands, and there was a right human facial palsy, and the right upper and lower limb was having only grade 2 power. So this patient has come in the late window period. Now MRI was done from the peripheral hospital, and it was showing acute hemodynamic infarcts in the left MCA territory. Sorry, I couldn't get the MRI. This is the MR angio of the brain and neck of that patient. So for your knowledge, this would be the MRI of the brain, MR angio. This is the right internal carotid artery, and this is the basilar artery, the central one. And this would be the vertebral artery. You can see that the left internal carotid artery is not visible. And this is the MR angio of the neck. Now, since there was hemodynamic infarcts in MRI, we planned of doing a DSA, and DSA was done. So this is the lateral view of the right internal carotid artery neck of the right side. The patient was having of the normal side actually. And this is the intracranial view of the right internal carotid artery, angiogram wise. Now you can see the AP view, that is the anteroposterior view in the DSA of the right internal carotid artery. So you can see that this is the right ICA. It is continuing as the middle cerebral artery, and it is filling, and it is also going to the opposite side and filling the opposite MCA also. So this is the left internal carotid artery angiogram. Here you can see that there is this is the common carotid artery, which is splitting into external carotid artery, internal carotid artery, and there is almost complete blockage of flow into the internal carotid artery here. And this is the lateral view of the intracranial lateral view of the left ICA. You can see that this was the previous right ICA intracranial view, and this patient, you can see this is the left intracranial view. So here you can see that there is almost complete occlusion of the ICA. It is filling only up till here. These are the external carotid artery branches that you are seeing. So what happened is is you can see that there is a gradual tapering at the end of the occlusion. So this is typical appearing like a flame. So that is called as a flame sign in angio. So the flame sign is typical of internal carotid artery dissection. This is an artistic view of what happens in internal carotid artery dissection. So this is the internal carotid artery. We have the flow here. There is a rupture in the wall, and blood is flowing into the wall, creating another chamber there, which is gradually occluding the large vessel. So it's a case of internal carotid artery dissection. So this is the video. So you can see that it is appearing like a flame over here. That is complete occlusion thereafter. So this patient was treated with anticoagulants alone for a period of around 6 months. And after 6 months of oral anticoagulants and no invasive procedure was done, this was the left ICA. There is complete recanalization of flow of the left ICA. And this is a better view. And this is the intracranial view. You can see that left ICA has come back with just medical treatment alone. This is the video of the left ICA intracranial view of the neck view. So my take-home message is that long-term outcomes of intracranial atherosclerotic disease should be kept in mind, of internal carotid artery dissection should be kept in mind when assigning medical or endovascular management on a case-by-case basis. So suppose if this patient had presented in the window period, we might have gone for a stenting, but this patient already crossed the window period and he was stable. So we treated him with antithrombotic medical management alone, and there was complete recanalization of the artery in a period of 6 months. So exposing patients to potential unnecessary complications, which are more frequent in invasive or minimally invasive procedures, should not be the norm. The current case highlights conservative management using either antiplatelet or anticoagulant therapy as a prudent and effective strategy in patients with internal carotid artery dissection. Thank you.
Warm greetings, one and all. Myself, Dr. Jithin Binoy George. I am the current fellow at SNF at HIMS Al Shifa Hospital, PERINTHALMANNA, presenting the story of a 26-year-old male who is an IT professional who hailed from Chennai, who presented to us with weakness of left upper limb and upper and lower limb for the last 1 day. He was on a company tour to a nearby place where he had 3 pecks of vodka, and suddenly he felt some uneasiness of the left side of the body and slurring of speech. Anyway, he thought it was because of the influence of alcohol and he went to bed at 9. Next day morning, that is almost 12 hours from the onset, he was not able to move the left upper limb. He was able to move the left lower limb but cannot stand. There was slurring of speech. He came to ER, that is the next day, that is almost 14 hours after the onset. He had dysarthria, left human facial, left hemiparesis with an NIHS of 8. It was recognized as acute stroke. We proceeded with an MRI stroke protocol which confirmed there was an acute infarct in the M1 territory, the deep capsuloganglionic region, which was seen in, this is the abrupt cutoff of the first part of the MCA, that is M1 occlusion. So the NIHS was 8. We just did the RBS was 105, BP was 140/80. So the symptom to door time was 14 hours. And the total imaging time was 25 minutes. So we gave the revascular options, whether we could do the chemical, that is IV thrombolysis or mechanical thrombectomy or combined. But in this case, it was almost 14 hours. So we cannot give IV thrombolysis. So we gave the option of mechanical thrombectomy, which was the need of the hour because it was a large vessel occlusion, the M1 occlusion. The pros and cons were explained and the family members consented. Sooner the patient was shifted to cath lab. We took the DSA, which confirmed the M1 occlusion. This was done to assess the collaterals. This is the lateral view. You can see the very good PCOM and faint leptomeningeal collaterals filling up. So he was a very good candidate for mechanical thrombectomy. So again, reviewing the metrics, that is, we could achieve an door to puncture time of 45 minutes. And this is the first pass, we were not able to open, nor in the second, but in the third pass, which showed good recanalization of that is almost Tiki 3. For this mixed group, Tiki 3 means there is complete reperfusion. So this was the thrombus which was aspirated. It is a white fibrin-rich thrombus. So this is the final check angio. We can very well see the M1 which is recanalizing, and this is a capillary phase which shows good recanalization. So being a young stroke, we worked up, there was proteinase deficiency. The Holter 24 hours did not show any AF, echo did not show any clot. So this is a patient the very next day. The patient clinically improved.
Excuse me. Hello? Your time is up. Kindly hurry up.
Yes.
We can give you at the most 1 more minute.
Yes.
Thank you.
So to conclude, IV thrombolysis may not be effective in large vessel occlusion, and LVO comprises, that is large vessel comprises almost 24% of acute ischemic stroke. The mechanical thrombectomy has an amazing number needed rate of 2.6, and mechanical thrombectomy is effective even up to 24 hours, who has good penumbra on perfusion scan and good collaterals. Thank you.
Thank you. Please, Dr. Huck, please come on stage to receive the memento. And I request Dr. Binish to kindly hand over a memento to Dr. Huck. Any comments by the chairpersons, please?
Thank you.
Dr. Jalil and Dr. Binish, any comments? Dr. Rauf?
Almost all the part of acute stroke management is covered nicely. Very good talk, and a few cases are well demonstrated. As there is no much time to discuss, we will wind up this.
Thank you.
Thank
Dr.
you.
Rauf?
The stroke management is becoming entirely different, entirely this hopeful after coming this intravenous thrombolysis and all the interventions. It's very good. And my father had stroke, and as the first video shown, he has immediate recovery from mine leg, sir.
Thank you, Dr. Rauf. I request Dr. Binish to please hand over a memento to Dr. Moinul Haq. And Dr. Rauf, kindly hand over certificate of presentation to Dr. Haq, please. Your certificate, please. Thank you. We'll quickly move on to the next session. The next session is a talk. Please, Dr. Marthanda Pillai, sir, I request you to kindly come on stage and present a token of our appreciation to Dr. Binish for chairing the session. And to Dr. Rauf also. To Dr. Rauf. Thank you, Marthanda Pillai, sir. We'll quickly move on to the next session because we are already running behind time. The next session is a topic on robotic surgery, pushing frontiers in minimally invasive surgery. That speaker is Dr. Jaideep P., who is a general and laparoscopic surgeon at Daya General Hospital. To chair the session, we invite Dr. Shaju Matthews and Dr. Ranjit onto the stage. Thank you. We acknowledge the presence of the following dignitaries who have joined us for AMSCon 2022. Dr. Marthanda Pillai, who was the past national president of IMA. Dr. Alex Franklin, who is the past state president of IMA. Dr. P.K. Mohammed Rashid from Kodungalur, who was IMA past state president. Dr. K.V. Devadas, who was IMA past state president from Kundankulam. Dr. M.A. Sugathan, who is IMA past state president from Chalakudi. Dr. K.A. Pareed, who is IMA Malappuram headquarters branch. Dr. Ahmad Kuti, who have joined us from IMA Tirur branch and who is a patch president also at present. Dr. Abdul Salam, who was the IMA Malappuram headquarters branch member. Dr. P. Narayanan, who is the Joint Secretary of IMA North Zone. Dr. Ashok Valsala, IMA District Committee Chairperson. Over to the speaker, Dr. Jaideep, please.
Thank you. A warm good morning to one and all. I'm Dr. Jaideep P. I'm the consultant surgeon working in Daya Hospital, Thrissur. So first of all, I would like to thank IMA PERINTHALMANNA for giving me this opportunity to present this before this wonderful crowd. So I'm interested with the job of enlightening you people regarding the basics of robotic surgery. So without further delay, I would like to get on with my speech. So from time immemorial, we have all known about open surgery, and all of us know about the merits and the demerits of open surgery. The demerits of course being a prolonged hospital stay for the patient, larger wound and associated complications. But I would never discredit open surgery because it always remains a beauty to the surgeon. But as already mentioned, the large incision, the prolonged operating time and the prolonged recovery time produces some sort of discomfort for the patient. So keeping this in mind, the late 20th century, we came across what is called as the minimally invasive surgery or the laparoscopic surgery, which in fact was a great boon to the patient as far as the patient is concerned. It caused minimal surgical scars, relatively less pain and minimal hospital stay. As far as the patient is concerned, these things were of utmost importance. But as far as the surgeon is concerned, we do come across certain problems while doing laparoscopic surgery. One of the most important being the high learning curve associated with laparoscopic surgery for complex surgeries. And of course, the increased operating time causes fatigue to the patient, to the operating surgeon. And there is loss of dexterity because we operate using laparoscopic instruments which are predominantly not as compatible as our wrist, or we cannot perform such complex movements using our laparoscopic instruments. And the surgeon need to reconfigure his brain, because in laparoscopic surgery, when you have to operate or you have to move the instrument to the right, the surgeon has to move his hand to the left. So left is right, right is left, up is down and down is up. So it takes time for the surgeon to reconfigure his brain to perform these motions. And of course, it takes a much more prolonged learning curve to get accustomed to it. Now, there are of course 3D screens available to do your surgery in 3D while doing laparoscopy, but these are rare and few, and the cost is also an issue. Predominantly, most of the centers perform laparoscopic surgery using two-dimensional cameras. And of course, there is a problem of inaccessible areas, like pelvis especially, where the vision and the accessibility always remains a problem to the surgeon. And every now and then, every field, be it any field, all over the world, has to go through a revolution. And as far as surgery is concerned, or minimally invasive surgery is concerned, that revolution came in the form of robotic surgery. So, the most important question that everybody has in mind is regarding the name. What is robotic surgery? Everybody asks a question, who performs the surgery? Now you don't need the surgeon any longer, because there is robotic surgery, the robot is performing the surgery. But it's not true, because it is a misnomer actually, because the robotic surgery, the term actually means it is the surgeon who is operating using a robot. So the robot is just a medium. It is the surgeon who is performing each and every move of the, who controls each and every move of the robot. Now, and always the primary emphasis is always given to the safety of the patient. So we at Daya Hospital have brought this system called as Versius system. That is the name of a robotic system that is being developed by CMR Technologies, that is a UK based company. And of course there are many other robotic systems available, but we at Daya Hospital, we have using this Versius system. And you can see this picture actually just puts into perspective what is robotic surgery. You can see a surgeon who is performing this surgery sitting there comfortably, and the bed, you can see the operating bed, and the 4 arms are working, and certain screens. That is about robotic surgery. That is robotic surgery. So coming to the parts of a robotic system, it has got 3 main parts. The first is the robotic arm, and per se it is not the robotic arm which enters the patient body, but rather these working ports which can be connected to the robotic arms, and these gain entry into the patient's body. Second part is the monitor for you to visualize what's happening inside, and third is the surgeon console where the surgeon sits and performs the surgery. You can see the robotic arm. These are 4 in number generally, and 1 is always for the camera port. Now what we do is we connect these robotic instruments instruments to the robotic arm. The robotic arm remains constant, and it doesn't enter the body. Rather, these instruments does gain access into their body. As I've already mentioned, one of the arm is always for camera, and another 3 robotic arms are provided so that you can fit in 3 similar instruments with which you do the surgery. And similar to our laparoscopy, you make a small incision, a keyhole incision, through which these instruments gain access into the body. Here you can see, I've already mentioned the robotic arms, 4 in number, 1 for the camera, another 3 for the robotic instruments to gain access. And
The role of the assistant is just to guide this instrument into the body and remove it after the surgery is over. So apart from that, apart from these jobs, the assistant generally is sitting there ideally. Now coming to the second part of the robotic system, it's called as the vision console. Now vision console is basically a 2 or 3 screens or monitors which are 3D compatible, and 3D monitors which are kept in different parts of the operating theater so that the assistant can see. It is not for the surgeon to see, because the surgeon console is different. This is just for the assistants to see. And you can see in the monitor, this is taken in our hospital, in the hospital, when we are doing a surgery, and you can see that the monitor has, if you see the left and right top end, you can see 2 symbols. Now basically these means that the instrument is active. One is for the left, one is for the right. You can have, and you can see 2 emblems on the right side, on the left side. That means that you can toggle between these instruments. If you want one of these instruments to be active, you just need to shift from the bigger circle to the smaller circle, and on the right you can see a green circle, that is for the opposite, the next side instrument. And any malfunction, for example, sometimes the robotic arm can go and touch the abdomen wall, and which means it has no space to negotiate. It immediately sends a message on this monitor saying that you are running out of space. So that very moment you can rectify it and you can continue with the surgery. So it always emphasizes the safety first approach of this robotic system. Now coming to the third part, the most important part is the surgeon console, where the surgeon sits comfortably and performs the surgery. He is provided with 3D glasses, and it's just like as if you are inside the abdominal cavity and you are inside and you are very close to the operating organ. It is so precise that even each and every small blood vessel and nerve can be visualized and preserved. This again, just shows you the surgeon who is sitting there and operating using the surgeon console. This is inside the theater, but not close to the patient. Yeah. And this was one of our first experiences with robotic surgeries, and you can see that this was in fact taken during our first robotic surgery. And as I already mentioned, you don't need so many assistants, but because it was our first experience, there are so many assistants in fact. And we have done close to 45 surgeries over the robotic surgeries over the past 6 months. And when you do more surgeries, you become more streamlined. The staff becomes more streamlined and it becomes much less cumbersome. Again, this shows the patient, and you can see the robotic arms there. And this is the surgeon who's sitting. The table is over there. Now, very common question that we come across in amongst our patients is, how is it similar or how is it different from laparoscopy? To begin with, to an outsider, laparoscopy and robotic surgery would seem just the same, because you use keyhole surgeries for both, minor small incisions for both these surgeries. But the real difference, that I will be coming to you later, but the real difference as far as a surgeon is concerned is regarding these special features which the robotic surgery offers to you. The instruments has greater degrees of freedom. It can turn about 720 degrees. It can complete 360 degrees on each instrument. Even our wrist, the human wrist, can move about maximum 120-130 degrees. And even for laparoscopic instruments, there is this issue of degrees of freedom, which is rather less. But as far as the robotic arms are concerned, the degrees of freedom is more, and you are able to move the instrument at 720 degrees. And at the push of a button, the instrument just goes back to its neutral position. we can access and reach very difficult areas of the body, especially the areas of pelvis, where you do hysterectomies, you do anterior resections for carcinoma of the colon, of the rectum and all. So these areas, it's of utmost helpful. Of course, it gives you a 3D vision, which is much more better than the conventional 2D vision that you use in laparoscopy. And another important thing is the camera is not controlled by an assistant, but rather by the surgeon. So every now and then another problem that the laparoscopic surgeon faces the camera, because it's very difficult for you to get a capable or a similar minded camera person. But as far as robotic surgery is concerned, the camera itself is controlled by the surgeon. So that factor is removed, the factor of camera person. Yeah. Now, why would you have to suggest a robotic surgery for the patient? As far as a patient is concerned, a patient comes to you and asks, what are the advantages, or how is it different, or what can I gain more from robotic surgery than from a laparoscopic surgery? Now, just similar to laparoscopic surgery, it uses a keyhole. That is a very small scar. Usually we make a 0.5 centimeter incision for the robotic, for the instruments, and a 1 centimeter incision for the camera. And as I've already mentioned, it's very precise. Each and every minute structure can be seen in detail. It can be identified in detail, which requires less of tissue dissection. Now, less tissue destruction and dissection means there is less blood loss and there is less pain, which in fact turns to a faster recovery time, a shorter hospital stay, and patient getting discharged much earlier. And in the case of pelvic surgeries, immediate urinary continence is preserved. So that is also an advantage. Now, from the surgeon's point of view, here comes the main part. Why would I recommend robotic surgery? It means better ergonomics. You are sitting there, the surgeon is sitting there, he can take rest in between for prolonged surgeries, he's relaxed. So all of these things basically result in a much less surgeon fatigue. And for this very reason, you can say the patient is invariably improved in that aspect. And for certain areas of pelvis and inaccessible areas like pelvis, I think that there is better accessibility in surgically challenging areas. It of course offers you 3D vision, which is much better than a 2D vision, and it also overcomes the limitation of human wrist, because already mentioned about the endo wrist and the greater degrees of freedom and the angle, the 720 degree angulation that you can attain using robotic instruments. And there is no tremors, because increased fatigability of the surgeon can cause fine tremors, and while dissecting certain areas, it can produce invariably tissue damage. Now that is also removed using a robotic surgery, and it is possible in very obese patients. Now, what all surgeries can you perform using robotic surgery? In our hospital, in the hospital, we presently we are offering robotic surgery in the department of general and gastrosurgery, urology, gynecology, and bariatrics. And I wouldn't recommend robotic surgery for each and every abdominal surgery. That is not required. But certain surgeries, like you can say a complex hysterectomy, myomectomy, and complex cholecystectomies. Of course, malignancies are out of the question. These things are very much helpful for complex malignancy surgeries, especially anterior resections, hepatectomies, gastrectomies, and all. And urology, the gold standard for prostatectomy is now robotic prostatectomy. It's also helpful in nephrectomies, partial nephrectomies, and kidney surgeries. So this is just what do you say? It's not accurate to the point, but just to get you people understand what is the difference between open lap and robotic surgery. Suppose a open surgery causes a 10 centimeter incision. You can do the same using a laparoscopy and a robotic surgery using keyholes. Now coming to the pain factor, open surgeries can be considered on the one end of the spectrum, and on the other end you have got robotic surgeries where the pain is less even when compared to laparoscopic surgery. Blood loss, the same is the case with blood loss, because the surgery is so precise. Invariably, you needn't go and do unnecessary tissue dissection, which invariably causes less blood loss. Scar is also tiny because of a keyhole incision, and the hospital stay is also considerably reduced compared to laparoscopic surgery. Can I have the video, please? I'll just show you a small video. It just demonstrates in clarity about the movement of these robotic arms. And meanwhile, we at the hospital is actually conducting a small workshop for robotic surgery. Anybody interested can approach our stall. And we are offering you first-hand hands-on training on robotic surgery. We have a stimulator there. Robotic surgery stimulator is available. Those interested can approach our stall in front of the hall. And we can even recommend you to CMR, that is the robotic system that we bought for further advanced training. So if those interested can please approach them. Now can you please show the video? So you can see the surgeon is using the robotic arms below, and you can see the movement of the robotic arms above. It's just it rotates more than 360 degree. In fact, it can rotate 2 times, so it makes it 720 degree. This is how it would look like, and see, this is the same thing which I have in my hand. For those interested, we have similar many instruments available. It's available in our stall. You can come and you're welcome, more than welcome to come and see those. Thank you for your patient listening. Thank you.
Thank you, Dr. Jaydev, for completing the session in time.
Thank you, sir.
It was an excellent session. And as you have understood, robotic surgery has edge over laparoscopic surgery in terms of better precision, better control, and better flexibility. And we have 5 more minutes for discussion. If anybody wants to ask any questions, please.
Any questions, please, from the audience?
Sir.
Mic for the audience, please.
Sir, we have done out of the 45 surgeries, almost 20, close to 20 were done in the Department of Gynecology, and the rest combined gastro and general surgery. So far the outcomes are, the reviews that we got from our patients are very good, sir. No complications till date, and they're happy. The patients are very much happy.
Gastro surgeries, what exactly?
Sir, gastrectomies has been done, anterior resections has been done, then one case of esophagectomy was done, then I think a complex rectal prolapse was done, and difficult cholecystectomies were done. Mostly anterior resection, that is the most commonly done case from general surgery and gastro. And from gynecology, it's hysterectomies that are mostly done.
Thank you.
Thank you, sir.
Thank you. If there are no questions, we will wind up the session. Thank you, Dr. Jaydev.
Thank you, sir.
Thank you, Dr. Jaydev. Please remain on stage. I request Dr. Shaju Matthew sir to kindly hand over a memento to Dr. Jaideep. And I request Dr. Ranjit to kindly hand over the certificate of. Request Alex Franklin sir to kindly come on to the stage and present a token of our love to the chairpersons. To Dr. Shaju Matthews. And to Dr. Ranjit. Thank you, Alex Franklin, sir. We'll move on to the next session.
So the next session is on sonoembryology. The speaker is Dr. Sandosh Kumar M., who is HOD and Senior Consultant in Radiology and Imaging in Charge, Fetal Radiology and Interventions, KIMS Al-Shifa, PERINTHALMANNA. To chair this, we invite Dr. Praveen Ramanunni and Dr. Kochu S. Mani.
Ladies and gentlemen, there is no formal tea break for today's conference. Tea and snacks are available continuously in the snack counters. Thank you.
Respected seniors, dear friends. See, today actually, my topic is sonoembryology, and actually why I put this simple topic is our audience are general, and I think that many of my gyno colleagues are already to a good topic in Malappuram fetal medicine topic is there. I see very few of my gyno colleagues here. So actually I made this topic simple, and it is for beginners and who is just started doing juniors. So the main point I have to emphasize is that sonoembryology is the basic of initial, I think early scans. So anybody doing these basic scans should by heart this. These are the main points you should always keep in mind when you see a gestational sac-like structure in the uterus. That is, you have to differentiate whether it is viable or it is non-viable or ectopic. The word ectopic also obsolete now. We call it as a pregnancy of unknown location, PUL. Similarly, we don't use the term abortion, we use the term miscarriage, missed miscarriage, something like that. So everything is changed. Now, I am going to talk little about by 20 minutes around sonoembryology basic. Majority, it is embryology talk. I don't know how many of you like it. Anyway, then I will talk about or show some of the recent advances in the ultrasound machines and what I do in my department. So, I am doing these scans for 26 years, probably had done more than 3 lakhs, no counting OBG scans and everything. So what makes the difference that era to this era? Because that time also there were guidelines were there, but after 2012 onwards or 2011 onwards, there are a lot of precise protocols like ISWOG, FMFs, SFM, AM, ICRI, lot of guidelines. These are FMF guidelines, AM guidelines, Society of Fetal Medicine, ICRI. So there are a lot of guidelines. Why we need a guideline? That is a different topic actually. But if somebody, any legal or any other fellow, for example, a doctor sending to me only to do cervical scan, Sandosh, why you do that thing? Or somebody sending me only for a growth scan, why you, Sandosh, you are doing this one Doppler also. So it is, I decide it's a part of a protocol. I can show them any number of protocol that it is an integrated part of any growth scan is There is Doppler from day first scan to end, because there is a lot of difference, lot of changes came in the field of fetal medicine or fetal radiology. So what we do in that one, any fetal radiology or fetal medicine department, what they do, the dating scan, and 11 to 14 week scan, we call them NTNB scan, with early anomaly scan. That is, we usually spend lot of time in doing 12-week scan. Even though it is 11 to 14-week scan, I stick on to my experience is a 12-week scan or 12 weeks 1 or 2 day. I don't like more days, or I don't want to do scans 11 to 5. I stick to 12 weeks. And a lot of early, nearly 50% of your anomaly scans can be done transabdominal and transvaginal scan. We are confident about that. And the screening, there are a lot of protocols. It's a simple protocols. Screen for preeclampsia, fetal growth restriction risk calculations, cervical length, how you measure and which way. Not simple measurement of transabdominal scan, you are seeing a cervix and putting 35 millimeter. No, there are protocol. It should be done by a transvaginal scan. It should be relaxed mode. From where, how to put your indicators or your marks. It is all, everything is in protocol based. And a combined test with maternal serum biochemistry for aneuploidy calculation. What is the risk previously? What is the combined risk calculations? And how to proceed. And we have to talk with the referring doctor how to proceed these things. And most of the time, after these aneuploidy calculations, I see lot of patients, കൂടുതലായിട്ടും ടെൻഷൻ അടിച്ചു വരുന്ന പേഷ്യൻസിനെ ഞാനിപ്പോൾ കാണുന്നത്. പണ്ടത്ര ഇല്ലായിരുന്നു. ഇതെല്ലാം വന്നു കഴിഞ്ഞപ്പം മൊത്തം ടെൻസ്ഡ് പേഷ്യൻ്റാണ് കമ്മിങ് ഫോർ amniocentesis. And the early anomaly scan, it was 16 to 18, and the genetic sonogram 20 to 20 weeks. But previously, നമ്മുടെ MTP 20 weeks ആയിരുന്ന സമയത്ത് 19 weeks 3 days ആയിരുന്നു എനിക്ക് ഏറ്റവും ഇഷ്ടപ്പെട്ട ടൈം. But MTP വന്ന് 24 വരെ പോകാമെന്നാകുമ്പോഴത്തേക്ക് I will put it as 21 plus, 21 and 22 is the good time. Because അവിടെ ഒരു അനോമലി കണ്ടു കഴിഞ്ഞാൽ നമുക്കൊരു amniocentesis ചെയ്ത് കഴിഞ്ഞാൽ 24 weeks, 3 weeks are there. ഇപ്പോൾ ഫിഷ് ചെയ്യുകയാണെന്നുണ്ടെങ്കിൽ നമുക്ക് 1 വീക്കിനുള്ളിൽ നമുക്ക് ആ റിസൾട്ട് കിട്ടുമ്പോൾ നമുക്കൊരു ഐഡിയാസ് കിട്ടും. പക്ഷേ ചില കാരിയോടൈപ്പിംഗ് നമുക്ക് വേണമെങ്കിൽ 3 weeks ചിലപ്പോൾ ആ ഒരു ഇത് എന്നുള്ളതുകൊണ്ട് 24 weeks MTPയുടെ ടൈം നമുക്ക് തന്നിരിക്കുന്നത് കൊണ്ട് ഇറ്റ് ഈസ് എക്സലൻറ്റ് ടൈം ഫോർ ഡൂയിങ് early anomaly. So, okay. Now, growth scan 20 to 30 weeks. Any growth scan, why we go for a growth scan? Growth scan, this 30, before 32 weeks, IUGR is there. We never use the term IUGR. We use the term fetal growth restriction, that is FGR. That is before 38 to 32 weeks and after 32 weeks. Early versus late. So, we take the time 32 weeks. But some textbook literature say 28 weeks onwards. Okay, well and good. And dictation and evaluation of the early FGR, as I said you, then fetal echoes, and the special scans for FGR fetal anemias, and the 3D 4D scan. See, 3D 4D scan, it is for extended purpose, not just to show the face or make it fancy. It is a lot of use in fetal medicine or fetal medicine, but it is in extended version. And the procedures like amniocentesis, CVS, cord blood sampling, amnio infusion, amnio reduction, these are simple procedures. Amnio infusion, amnio reduction are simple procedures. Fetal pleural effusion tapping and decompression of fetal urinary bladder. There are more fetal therapies, but that dictum is that it can be, if you can avoid that, there is no other ways. Then you can for these fetal therapies, because it is costly, and other fetal therapies are, chance of fetal loss is more in that type. That is a different subject. Then extended scan for multiple pregnancy, that the complications, TAPS, TRAPS, TTS, selective FGR, etc. Then patient counseling is nowadays very important. Just to do a scan and sending the patient is not good this era. We have to talk to the patient, we have to talk and consult of the referring consultant. We have to tell the patient, same, me and my referring consultant, and convince them, okay, this is a no problem, you carry on. Or other surgeries, suppose there is a bad diagnosis of a fetal echo, how to proceed? Suppose they got a ventriculomegaly, lateral ventriculomegaly, how to produce? Instead of putting just ventriculomegaly, sending back. No, we have to inform the consultant, inform the referring consultant, discuss the consultant various factors and also with the patient, and how to proceed is the important thing now in fetal medicine. Just scanning and sending back the patient is not the correct time. And other ones are gynec 3D scans, endometrial volume assessment, 3D antral follicular counting, and the transperineal 3D scan for pelvic floor assessment. So, sonoembryology, normal development of the embryo, and the first trimester is now embryonic age and fetal age. We never say sonology 12 weeks, but we say embryonic age and fetal age. Now, this is the thing. First trimester is defined the 12 weeks of pregnancy following LMP. It has a 3 to 5 weeks conceptual phase, and there is an embryonic phase 6 to 9 weeks, and a fetal phase 10 to 12 weeks. So, why US gene early? So, this provides reassurance to the patient, charts normal development, identify females with high risk, and the TVS more reliable than transabdominal sonography, and transvaginal TVS help to observe the growing fetus in the screen, and depends on the expertise. And what are the indications? That is dating viability, chances of reaching viability unarmed, pregnancy failure before spontaneous passage, and the suspect fetal or genetic anomalies, and termination at the early phase, and the early diagnosis of molar pregnancy, and the diagnosis of, or suspicion of a ectopic pregnancy, and characterization of a multiple pregnancy. Whether that is important. In the first scan itself, we have to characterize the multiple pregnancy. Either it is a DCDA or MCADA twin, because the management totally different. If you come the patient at the 20 weeks and telling whether it is a chorionicity and amnionicity, sometimes it is difficult. If it is a dichorionic diamnionic DCDA twin, we have to follow up the case from 16 or even 20 weeks every 4 weeks. But if it is monoamnionic, the risk of a lot of complications are there. So from 16 week onwards, we have to go every 2 weeks. So we need that classification. And this is one of the important points for juniors. Just as like if you do a scan and if the serum beta HCG is more than 1,000, there should be a gestational sac in the uterus. So some literature is variable opinion, they are telling, some literature say it is 2,000. Anyway, the basic thing is 1,000. You are doing ultrasound scan and you not seeing a gestational sac, there are DDs. Whether it could be early, it could be loss, spontaneous abortion, we have to ask the patient, or it could be ectopic outside also. So we have to repeat doubling time, and the beta HCG ratios, everything, we have to go for that. And this product of conception, pure embryology, ovum, what happens to the ovum? It can get damaged, genetically determined, we are not doing anything to them. And the other one is continuous unarmed. So traditionally we divide the 3 phases, pre-ovulatory, oocyte migration, and zygote migration. That's everything embryology. This is the routine picture you see any textbooks. And what happened next? That cap, contact, adherence, and penetrate. So the first site we call chorionic frontosome, and it becomes placenta later. And what happens? Trophoblastic HCG enter the maternal blood at this stage. So we can start detecting beta HCG. And usually pregnancy test will be positive 3 to 5 days prior to first missed period. Even ultrasound we can detect ultrasound gestational sac by nearly 4.5 weeks. Better machines are there. So then little normal landmarks. Just seeing, you can see this is normal, this is abnormal. 4 weeks, this first change at 4 weeks, you cannot, difficult to detect sometimes at 4 weeks by ultrasound. But what happens? First change, residual changes the endometrium, thickened endometrium. So if you see a thickened endometrium, you are sending the patient very early. I will put the differential diagnosis. It could be early, before 4.5 weeks, or it could be ectopic also. Because the thickened endometrium, I cannot differentiate. And similarly, if you can see any adnexal mass. Commonly we say corpus luteum. So the other point the juniors to remember is that before 12 weeks, up to 12 weeks, you see a cystic area, you definitely it's corpus luteum. But after 12 weeks, if you see any cystic structure extending after 12 weeks, it is never corpus luteum. It could be cystadenoma or benign cystic teratoma. No question about that. No confusion about that. And implantation occurs within the uterine wall. Usually it is eccentric in position. That is, any gestational sac in the uterine cavity comes with the eccentric in position. If it is not eccentric, it is not a gestational sac, or if it's a gestational sac, is it going to abort or non-viable? Similarly, eccentric position, first definitive sign of pregnancy is gestational sac. That is outer residual reaction, inner fluid filled sac. And the gestational sac seen at 4.5 weeks by TVS. And when the beta HCG titer is more than 1000 units, you should see a gestational sac in the uterine cavity. This routinely seeing a gestational sac like. But we cannot say it's a gestational sac. It could be any cyst also. Usually the growth is roughly 1. This calculation is necessary. We are repeating a particular scans. We roughly have idea 1 millimeter per day. So patient came after 10 days. Oh, 10 millimeter should it grow? If it is not growing, what is it? So we got the idea. It is not, interval growth is very bad. So it is not going to be a viable pregnancy. And the differential diagnosis, as I mentioned, decidual cyst, pseudogestational sac, etc. And week 5. You see the double decidual sac side, that is inner coronary cavity, outer decidual lining of the uterus. And you see a secundum yolk sac. This is the first structure visualized in the gestational sac. It is the true landmark. Confirm the pregnancy. That I showed you cyst. It could be a cyst. It could be a gestational sac. But if you inside you has another cystic structure, if you see a yolk sac, definitely it is a intrauterine pregnancy. The first landmark. No confusion about that. And the other point to be mentioned is that by transvaginal scan, if the mean sac diameter 8 millimeter or above, a yolk sac should be seen. If it is not there, it is going to be non-viable. It is an important point. And by transabdominal scan, 20 millimeter or above, if you don't see a yolk sac, it is going to be non-viable. Similarly, other thing, abnormal yolk sacs, it could be a large, more than 6 millimeter, roughly 6 millimeter, some textbook up to 7 millimeter is normal. Anyway, if it is more than 7 millimeters, it is abnormal. If it is too small, less than 2 or less, it is very small. And if it is irregular appearance, going to be non-viable. And is freely floating in the cavity, going to be non-viable. This is the double decidual sac sign. That is your first ring is the chorionic, the other one is the decidual, this one. This is the first appearance in any pregnancy, whether it is TVS or TIS. This is their diagram, how it appears double decidual sac. And what they say, there is some literature, they say double decidual sac sign is a useful feature on early pregnancy ultrasound in distinguishing between the early intrauterine pregnancy, IUP, and the pseudogestational sac. And it consists of anatomies. Then there are, where the two adheres, decidua basalis, that is future placenta is coming. So this, by 14 to 16 weeks, yolk sac won't be seen. And the other thing is, number of yolk sac is equal to number of amniotic sac, not embryo. Number of yolk sac is equal to number of amniotic sacs. Okay. And early gestational sac, yolk sac, and you see an yolk sac and a extra coelomic cavity, difficult to distinguish by the TVS. Another important sign is you call the double bluff sign. Amniotic sac plus yolk sac, and in between you see a embryo, something like butterfly like embryonic disc, then double blub on either side. We call it a double blub sign. It should be mistaken for a double decidual sac sign. Week 6. By week 6, you should definitely be seeing embryo. So it's really small dot like diamond ring sign, signet ring sign, lot of things says, and heart rate you see. And by transvaginal scan, I told you 16 to 18 millimeter embryo must be visualized. And for practical purpose, if you measure a CRL, it's the most important. 6 weeks is a good for CRL, but if it is around 8 or 9 weeks, the best image you will get. This is the diamond ring sign. You see the one end the yolk sac and the other end a small dot, that is a developing embryo. And the double bulb sign, what is double bulb sign? One yolk sac is there, embryonic disc is there, then other side is chorionic sac is there. So it should not be confused with the double decidual sac sign. Two are different. Double decidual sac is early and double bulb sign then comes later. And then what is embryo? Means metamorphosis, period of organogenesis, morphogenesis, concerned with the teratogenesis, lot of things. Before 8 week of LMP, true CRL we won't get, we measure the long axis only. And what happens to the amniotic cavity around? Initially it is stick to the embryo, gradually from the urine from the embryo, it start amniotic sac, slowly comes to distant and you see the amniotic sac. And embryo usually seen in the amniotic cavity and the yolk sac seen in the chorionic cavity. That's the two difference. So these anatomical embryological landmarks are very much necessary when you see a sac, whether it is viable or non-viable. This is a CRL measurements. Every scans who is doing, they are very familiar with this CRLs. And cardiac pulsation can be seen by 6 weeks. The thing is that presence of a cardiac activity in embryo less than 5 millimeter, for practical purpose, you put it as 6 weeks. And what happened in 7 weeks? Nothing much. Only thing is that no important findings, just going this one. And 8 weeks is good time. You are seeing the limb bursts, placental sites, physiological midgut herniations, and embryonic movements. See, a normal 8-week fetus pole, one should see a definite head and body. The beginning of the limb buds, you can, with a good transvaginal machine, you can see the limb buds, all 4 limb buds by 8 weeks. And the fetal heart activity must be visualized. And subtle body movements can often be seen. By 9 weeks, nothing much. And by 10 weeks, this is an important landmark, 10 weeks. Because this is the best time for CRL by literature, best week. And the other thing is that what happens? Unfolding of head, regression of tail, regression of heart prominence, development of limbs and eyes, physiological herniation you can see by the time. And this shape from tadpole-like to human form it will come. And we start calling it a fetus by 10 week. This is the appearance. See, 2 sacs you can see, embryo, you can see the chorion and amnion sacs is there. And the pink color is the physiological herniation of this one. These are the oral appearance of around 10 weeks or something. And most accurate timing of pregnancy in the first trimester 10 weeks. And that accuracy is plus or minus 5 days up to that one. And the pregnancy loss might have already occurred prior to 10 weeks. 97% confidently we can tell the patient that it won't go. Because already 10 or it is crossed means nothing won't happen. That's the dictum. Still 97 only, still we can tell that nothing going to happen. Spontaneous loss chance korvana. 11 to 14 weeks, next few idana. The most important, you have to see transabdominal with high-end machines. You will definitely get lot of things by transabdominal large images, but at the same time you should also use transvaginal probe with 3D. You can see skull, face, orbits and interorbital distance, abdominal structures, limbs and the cardiac, even 4-chamber cardiac view you can see excellently by TVS if it is possible near the probe. And midgut, you can see the midgut returning. Usually around 11 weeks, the herniations goes back to the abdominal cavity. And normal pregnancy with confidence 97%. That is the dictum. A fetus reported normal at 10 to 11 weeks has only less than 2% chance of being abnormal. And around, I already told you, this 11 to 13 weeks, 6 days is there, but I use only 12 weeks I am sticking to that one, or 12 weeks 1 or 2 for doing NTNB exam. Because if you send the patient 13 week 3, 13 week 4, the child started moving. So very difficult to get a good section. Patient coming in the morning and leaving my department evening, or I have to call them back after 1 or 2 days. So by 12 weeks, it's settling in the dependent portion, very calm and quiet. You can get a good image. 12 week 1, 12 week 2, or even 12 week 3 is okay. But only thing, the advantage by if you're sending the 13 weeks or 13 weeks, 6 days, is I can do an early anomaly scan. Lot of time to me to get lot of things to see for me in that anomaly scan, transabdominal and transvaginal scan. Nearly 50% major anomalies I can see. If I poke the child, it will just start poke up. You can see the 5 fingers, and even you can count the phalanges, numbers. They stay like this only. Their foot are also like this only. Hence, vaginal scan, you can do a good neurosonogram by transvaginal scan if the head is near the internal os. Fetal anatomy, I said, these can be diagnosed. Anencephaly, encephalocele, spina bifida, holoprosencephaly, hydrocephalus, ventral wall defects, ectopia cordis, and some of the renal anomalies and conjoined twins can be diagnosed by these weeks if you spend time to do a good scan. Nearly 11 to 14 scan, I will take nearly 45 minutes, 1 hour to take a good image and including echo. So it is a different subject. How we do NTNB scan, the protocols and everything different. And chromosomal, how you see suspect chromosomal anomalies, that is increased density, generalized hydrops, pleural effusions, and cystic hygromas. That's 11 to 13. 14 weeks again, roller spina bifida, the banana sign in the brain, lemon sign in the brain, holoprosencephaly, ventriculomegaly, Dandy-Walker syndrome, omphalocene. But you cannot diagnose GAT abnormality, microcephaly, achondroplasia, until some of the corpus callosum anomalies, because it develops 18 weeks upward. So we cannot diagnose some of them. Still, we are happy that we can diagnose nearly 50% of this anomalies. So roughly, what are the order of appearance in the early pregnancy? Intradecidual sac sign, double decidual sac sign, yolk sac, embryonic pole, that is a diamond sign, cardiac pulsation, amniotic cavity, and fetus. This is the order of appearance. Then, please note, after gestation sac first, then yolk sac, then embryo, then amnion. So, if you embryo seen but no amnion, it is a normal. But embryo not seen, but you see amnion only, that is abnormal. That is a empty amnion sign, non-viable pregnancy. Then there are some of the pseudopathologies. Physiological bowel herniation between 7 to 12 weeks. If you see after that, you suspect gastroschisis or omphalocele. So both are different. If it is omphalocele, you have to go for amniocentesis and everything. Gastroschisis is a different variety. You need for genetical studies. And small umbilical cyst, not significant. And normal rhomboencephalous cyst in the brain, it is posterior fossa cyst. Very careful. Lateral ventricular prominence, not a ventriculomegaly. And amniotic maintenance behind the head should not be confused to cystic hyma. You just poke the fetus, it will jump. Then you can see both are in a separate this one. Then these few are very important for the years. MSD is useful up to 5 to 6 weeks, but not used for gestational age assessment.
Santosh sir, sorry to interrupt. We are running short of time. Can you wind up in 2 minutes?
2 minutes. Okay, I will just show a few pictures. These are some of the good images we are getting nowadays. Echo and diaphragm echoes, and again tomographic images and the neurosonograms, antral follicular counting, and this is a bone imaging and the 3D imaging, again anomalies, umbilical, again cardiac silhouette, again 3D silhouette. This is hypotelorism, nasal bone, nasal bridge sunken, and again corpus callosum silhouette sign. These are excellent images for nowadays 3 and 4D, and lot of softwares are available. Kidneys at 12 weeks, and the neurosonogram again. This tomographic imaging, again is sliced CT slice like you will get the images. You can anything you can take and make it big and see. And the superior mesenteric artery and the volume measurements of endometrium, it is endometrial carcinoma like helpful, and the 3Ds and the pericallosal arteries. These are 3D. Echo. This is the pelvic floor imaging 3D scan. This is a procedure: amniocentesis, corneal sampling, cord bladder sampling, pleural effusion tapping, urinary bladder decompression, and coronal 3D scans for anomalies, and glassy views. Thank you. Thank you very much for patient hearing.
Thank you, sir. Please remain on the dais. Now I kindly request Dr. Kochu S. Mani ma'am to hand over the memento to Dr. Santosh Kumar sir. Now I request Dr. Praveen Ramanuni sir to hand over the certificate to Dr. Santosh Kumar sir. Now I invite Dr. P.K. Mohammad Rashid to hand over the memento to the chairpersons.
Thank you, Rashid sir. We will quickly move on to the next session.
So the next session will be a misinterpretation of thyroid function test. I request the speaker, Dr. Anish Ahmad, consultant endocrinologist, Endodive Specialty Center, PERINTHALMANNA, to come to the dais. I also request the chairpersons for the session, Dr. Shyamala Dev madam and Dr. Vishnu Vasudevan, onto the dais.
So first of all, I thank the IMA MSCon, my parental branch, for giving me an opportunity. So respected senior IMA members, colleagues and my dear friends. So today I'll be discussing on thyroid function test. Is it often misinterpreted? So you all know that the prevalence of endocrine diseases in India, if you look, one of the most common is thyroid disorders. And as an endocrinologist, it's our bread and butter. Why we have thyroid misinterpretations? Why we do thyroid function tests so frequently? Thyroid dysfunction, as you all know, it's very common in our population. Second is non-specific symptoms with no explanation. Patient മുടി ഒഴിച്ചിൽ കല്യാണം കഴിഞ്ഞ് കുട്ടികൾ ഉണ്ടാവുന്നില്ല, എന്താണെങ്കിലും thyroid ആണ്. അപ്പോൾ almost thyroid has become a common test. Wide availability, every look and corner we have labs, so it's widely available. Then if we do the test without a clear clinical reason, we are going to have a discordant thyroid function test. It's a sensitive test, but still we have lot of loopholes. It's not being well validated for our population. The reference range which we use is the Western population standards. So we all know, for in good interpretation of thyroid function test, we should know what is the physiology of the thyroid gland. So from the hypothalamus, thyroid releasing hormone is released, which acts on the anterior pituitary to cause TSH, and TSH will come and acts on the thyroid gland to cause T4. And predominantly T3 is acquired by the peripheral conversion, and there are also in the blood we have thyroid carriers which enhance the transport of thyroid binding. So when you do a total T4, you know 99.98 is bound to thyroid binding globulin. So the free form, which is the active. So any factors which can increase or decrease the thyroid binding globulin can affect the total T4. So for example, pregnancy. pregnancy you have estrogen which increases the thyroid binding globulin. So the pregnancy total T4 cutoff is different. It is 1.5 times the upper limit of normal, like OC pills. So you need to take these points into consideration when you interpret a thyroid function test. Like decreased TBG, where you get a T4 decrease, like nephrotic syndrome, where protein is being lost in urine, then glucocorticoids, androgen. So in these, when the patient is on these drugs, you get a total T4 decreased. Then we have very theoretical, maybe free T4 is the gold standard, it is not being affected by drugs, then why can't we all do free T4? But free T4 also, the lab assay should be technically demanding, and I think Vishnu will totally agree with me. You should have a very quality lab with you where your assay should be perfect. Then T3 is mainly acquired by 80% conversion from T4 to T3. Only 20% is secreted by the gland. So if you look at the clinical utility of T3 alone, it is maybe a non-thyroidal illness and some drugs only have a function. And total T3 is not very helpful in differentiating the cause. Why I have put Kajol here is she's supposed to be the brand ambassador of thyroid disorders in India by the Indian Thyroid Society. So if you look at TSH, it is the most sensitive test. But alone, it is enough as a screening test if you're screening primary hypothyroidism alone. In hypothyroidism alone, TSH is needed if the patient is stable on T4. But you may miss few things if you do TSH alone. Like symptomatic patients being tested for the first time. You don't know whether it is central hypothyroidism or not. Then pregnancy, where you need to have both. Then pituitary thyroid axis is not intact or unstable. Then during anti-thyroid drugs, this is what commonly happens when a patient is with Graves on anti-thyroid drugs. We always do a TSH and we say TSH is suppressed, then we increase the dose. But if a patient is on anti-thyroid drugs, you have to adjust the dose based on T4 and T3. Then for optimizing new patients on T4 therapy. Then you may, unless you do a T4 and TSH, you may miss a central hypothyroidism, then TSHoma and few rare cases. So which test to use? TSH you can use along as a screening. High risk of thyroid disorders, you always do T4 and TSH. Follow-up of a toxic patient, T3 and T4. Free T3 very rarely needed. Free T4 is an option where you have some binding protein interferences are accepted. So based on this background, I'll show you some cases and I'll wind up the talk. So this is a 56-year-old man who had presented in the surgical ICU with an abnormal thyroid function test. He was admitted 3 bags for an elective CABG surgery. The thyroid function test done due to the altered mental status suspected by the cardiothoracic anesthetist. So you can see here, so the free T4 is normal, T3 is low, and TSH is normal. So he had sought an endocrine consult suspecting central hypothyroidism based on the low T3. Physical examination was normal. So in this condition, we have normal T3, normal TSH, low T3, so and normal T4. So what is it? It is non-thyroidal illness or thyroid function test alteration due to the chronic illness, or we normally call it as sick euthyroid. So in this patient, what will you do? You don't need to do any intervention. Repeat the thyroid function test once his acute illness is over. That is, repeat TFT in 4 to 6 weeks after the discharge. So non-thyroid illness is the body's adaptive response to stress. The typical thyroid function test, what you get? Low T3, low T4, or you can get any correlation. So it's very controversial that should we treat or not. So revalence of thyroid function test in non-thyroidal illness, you can have isolated TSH setting. So in non-thyroidal illness, you have clinical indication for treatment only if the TSH is suppressed or the TSH is more than 20, or otherwise you need to just follow up the patient. So in 2 months, you just repeat once the acute illness is over. If the TSH is more than 10, you can consider the treatment. If the TSH is between 5 and 10, you do an antibody positive and then consider the treatment. And in these patients, you need to repeat TFT annually, and if the TSH is more than 10, only you need to consider the treatment. Now coming to the second case, this patient is a 32-year-old postpartum woman seen in the OPD, came from Middle East. Husband is almost Googled and made a diagnosis of postpartum depression, presented to me. So she was previously treated from outside, no family history, eyes were normal, thyroid function test, as you can see here, this was her initial thyroid function test. So she was started on anti-thyroid drugs from outside, thinking of postpartum depression and hyperthyroidism. So in my hospital, after starting the thyroid function test, you can see here, she was overtly hypothyroid. So what is the diagnosis? That was postpartum thyroiditis, most probably iatrogenic induced hypothyroidism. I stopped the carbimazole. So this is what we should know. Postpartum thyroiditis is common with prevalence of 5%. Hashimoto's is the most common. Initially thyrotoxic, and most women are euthyroid by end of first year. You don't need to treat. It is basically the release toxicosis. You can see here, there will be release first, followed by overt hypothyroidism. So what we should do, TSH 3 monthly in high-risk patients. Who should we screen? Who has symptoms of thyroid function, who has goiter, type 1 diabetes, postpartum thyroiditis with the history prior pregnancy, and who has positive anti-TPO antibodies. Case 3, 45-year-old man came with frontal headache and visual disturbances on medical treatment for mild hyperthyroidism for 5 years, no proper follow-up. He had a small goiter, normal skin, no Graves' ophthalmopathy, normal BMI. He had high free T4 and free T3. So you can see here, free T4 is 2.2. Our normal lab limits, I have kept it 0.7 as 1.4. So his free T4 and free T3 was elevated, and you can look his TSH. So what you are expecting when you are getting a high T4 and high T3, you are expecting the TSH to be suppressed. So in this patient, the TSH is inappropriately elevated for the free T4 and T3. So when you get a picture like this, only two differential diagnoses. Either it should be a TSH secreting tumor, or it may be a rare case of thyroid hormone resistance. So what we did other pituitary hormones that were normal. TSH alpha subunit were elevated. This was the MRI pituitary. You can see a clear cut macroadenoma sitting there. So with a 450 rupees test, you can diagnose a TSH-oma. If you miss it, the patient is going to have an adverse outcome. So it was a case of TSH secreting pituitary adenoma. So it's a rare cause of hyperthyroidism. Majority will secrete TSH alone, but they can have a plurihormonal association also. So what is the main differential diagnosis with a elevated T4 and T3 with an almost elevated TSH? Only two differential diagnosis, either a TSH-oma or a thyroid hormone resistance. Now I'll show you one of the rare cases we had. She is a lady with weight loss, heat intolerance, and tremors of hands since 10 years. Long history. She was evaluated at multiple hospitals, not able to make a diagnosis. So you can see here the thyroid function test at the initial evaluation showed itself a high T4 and T3 with a non-suppressible TSH. So this was the investigations at our center, and this is what it turned out to be. This was a case of thyroid hormone resistance. We had sent the blood sample to Oxford, and it came to be a thyroid hormone resistance with a defect in the thyroid hormone resistant beta gene defect. So this is case 4, 72-year-old lady presented with chronic fatigue, malaise and weight loss. Physical examination was normal. So what is here? You can see free T4 is low and TSH is almost normal. So what it is? Her symptoms persist and she had nausea and vomiting. So she took a detailed history. She had pallor, absence of secondary sexual hair. So again, we repeated a thyroid function test which showed a central hypothyroidism. So we did an electrolytes because she was complaining of nausea, vomiting and other things to rule out an hypopituitarism. Baseline pituitary functions were normal. MRI, in electrolytes we found hyponatremia. We did a synactin test, rule out adrenal insufficiency. Cortisol was low. She had a diagnosis of pituitary macroadenoma with a pan-hypopituitarism. So now 5, this was a 21-year-old on OCP, was referred for evaluation of hyperthyroidism. Physical examination was normal. So you can see here, T4 was very much elevated. My lab normal value is up to 11, total T4 was 17. She was treated again with carbimazepine from outside because T4 was elevated. But what was missed? Then after what happens is 10 weeks later, she presented to me with weakness and fatigue and lump in her neck and a hoarseness. Non-tender thyroid that was twice the normal size, periorbital puffness. So at my center, the TSH was 88 and total T4 was 8.5. Again, misinterpreted thyroid function test, wrongly started on anti-thyroid drugs. So as you can see here, what was missed by the treating doctor was the oral contraceptive pills history. She was on an estrogen containing pills which increased her total thyroid binding globulin, and that was the reason for her elevated total T4. So misinterpretation of thyroid function test in women on oral contraceptives was the case. The estrogen in the oral contraceptive pills will increase the thyroid binding globulin, leading to an increase in total T4. So always in these cases we should suspect, and we can do a free T4 also. Now this is most important, the effect of drugs on thyroid. So you need to consider all these things. We can do a CME only on this topic, so I'm not going into detail. And now coming to the last case, the case 6, 22-year-old female, primary, 12 weeks of pregnancy, referred for suppressed TSH, asymptomatic, no goiter, how to manage further. So you need to think of this. There are physiological changes happening in the thyroid function test in pregnancy, and that needs to be excluded. So get something called gestational thyrotoxicosis, where you get where HCG peaks at 10 to 12 weeks and becomes nadir at 20 weeks. So you can get a normal physiological changes, which is normal free T4 and suppressed TSH without thyrotoxic symptoms in 18% of women. In extremities, you get hyperemesis gravidarium, leading to vomiting, weight loss, and other things. So I have shown you this. No anti-thyroid drugs is required. It is a self-limiting condition. But we need to rule out an hypothyroidism complicating pregnancy also, which is tricky. So whether in doubt, you can always seek our help. We endocrinologists have no intervention, so we treat it and we will refer back to you. So these are the physiological changes happening in pregnancy. As you know, total thyroid binding globulin increases, total T4, HCG. You can see when the HCG peaks up, the suppression of TSH happens. So this is what the physiological change. So in this lady, no treatment, monitor clinically, repeat thyroid function test after 1 month. If you have a persistently low TSH beyond 20 weeks, you need treatment. Now coming to the last case, 25-year-old primary, referred for deranged thyroid function test, TSH. This was done in an outside lab. 96 was the TSH level. But when I examined, this patient had no symptoms or no signs of overt hypothyroidism. What will you do in this case? Can you make any guess? No, absolutely non-symptomatic patient, you are getting a handwritten of TSH of 96. So what I did is I repeated a TSH I might send her. It came as 0.96. So what was the mistake? The lady had written it wrong. Instead of 0.96, she had written as 96. So I'm not sure that that lady need a typing lesson because she may have a fat finger. So it was a case of typing error. So these are the thyroid abnormalities and associated blood test. So as you all know, this is what we see in our common scenarios. So this is all happens. I know this typing errors are, rare with the modern labs where normally we incorporate automatically the results into our database. But things are common. So I'm concluding my talk. I know we have an inauguration going on, so I think I'll stick to my timings. You always interpret thyroid function test based on the clinical picture. History and physical examination are still the most efficient tools for diagnosis. Think of common things than making a rare possibility. If in doubt, you should repeat the test. And I know when I'm running a center, it is very difficult because when I tell the patient to repeat the test, they always think as a business marketing strategy, but these things we see commonly in clinical practice. If mild abnormalities, don't jump and start on treatment. So whether in doubt, you reconfirm and correlate with the history and clinical features. Common things are still common, and with this message I conclude, always treat the patient and not the paper. So we only jump to the paper diagnosis, but God has given us a clinical sense, always treat the patient and not the paper. And whether you have any doubt, we have network throughout in Kerala, we have in Calicut, Mangalore, Kannur, Perinthalmanna. So I'm taking care of Perinthalmanna unit. So you can seek our help. Don't worry, we will refer cases back to you. With this, I conclude and I thank you.
Thank you, sir. Please remain on the dais.
1 second. Congratulations, Anish sir, for the excellent talk. So I think people are little bit more acceptable now that thyroid function tests, not on TSH only should not be done, and so many things are there to be interpreted. And he has made the topic so complicated that I think many of us will feel that now thyroidology is a little difficult. But still, I would like to ask one or two controversial questions to Anish sir. One is, what is your opinion that the TSH as a test alone should not be done at all, and whole thyroid function test should be ordered by every doctor? And the second question is, what are the 2 or 3 specific scenarios where you suggest that the thyroid patient should be referred to an endocrinologist or a specialist in thyroidology?
Yeah, that's a very good question, Vishnu, because I think if you're suspecting, because you all know primary hypothyroidism constitute 80% of the cases, or 80 to 85% cases of hypothyroidism. In that case, TSH alone may be sufficient. But in pregnancy, or like cases where suspecting central hypothyroidism or a newly diagnosed hypothyroidism, we don't know whether it is an overt or a subclinical, because for that you require a T4 along with TSH. In these scenarios, or where the hypothalamic pituitary axis is being unstable, in that cases always it is better to go for a panel of thyroid function tests. At least include a free whatever you are confident with your lab. If you are very confident with your thyroid, normal T4, T3, TSH will be required. So, or if you are suspecting an thyroid binding globulin or maybe protein defects, then you can go for free T4. And you also agree with me, free T4 assay is always complicated, and the ideal method will be equilibrium dialysis, which we don't do in our routine labs. Second question is, when should be referred to an endocrinologist is when you are getting a discordant thyroid function test. Your clinical picture and your thyroid function test is not matching. Like in tricky situations like pregnancy complicating thyroid, or when we are given adequate thyroxine, still your TSH is not normal, or some cases which I had shown you, like thyroid hormone resistance or TSHomas, or such rare clinical occasions, or difficult to manage hyperthyroidism. In all this case, I think endocrinologist numbers are also increasing, and our state numbers are also increasing. When they have a facility, it is better to refer to us, and once that problem is solved, we can refer them back to the primary care.
Anish, congratulations, very
Thank you,
informative talk. Especially for gynecologist, you give a nice leading talk. Congratulations.
Thank you, ma'am.
Are there any questions from the audience? You can wind up.
Thank you, sir. Now I request Dr. Vishnu Vasudevan, sir, to hand over a memento to Dr. Anish Ahmed, sir. I request Dr. Shyamala ma'am to hand over a certificate to Dr. Anish Ahmed, sir. Now I request Dr. M.E. Sugadan, sir, to hand over memento to the chairpersons.
Ladies and gentlemen, there's a slight change in our schedule because Dr. Fazal Ghafoor sir is posted for a surgery in the afternoon. He has to finish off his talk and leave immediately for the operation. So the next session will be by Dr. Fazal Ghafoor sir.
Our next session is on queries in epilepsy, a medical practitioner's perspective. The speaker is Dr. Fazal Ghafoor, Professor and HOD of Neurology, MES Medical College, Perinthalmanna. As chairpersons, I invite Dr. K.A. Sethi and Dr. Saumya Satyan.
Ladies and gentlemen, this year's IMA State Conference is happening at Kundankulam on November 11th and 12th and 13th. The Kundankulam team has come here to for registration purposes. They have set up a table outside immediately after the hall. All are requested to kindly register for the state conference. Fasal Ghafoor sir, please.
President and members of the IMA PERINTHALMANNA, pardon me if there is some stuttering in my speech because I got surgery posted. I have surgery for myself. You have to be thinking whether neurologist is doing surgery. No. Neurosurgeons treat epilepsy, but neurologists don't operate on epilepsy. So, the title of my talk is My Approach to Idiopathic Seizures. No egoism meant. Why the title was kept like that is that there is no consensus in most of these matters. Even after probably 50 to 60 years since we have been tackling the issue. Worldwide there is no consensus, I'll come to that. So I've taken the title as idiopathic seizures, which means we are not going to investigate. We'll just tell you what to investigate probably. But we are not going to treat the secondary epilepsies in my talk. So what are the seizures? So let us say we face a seizure. The first seizure which you face is the neonatal seizure. So that is the order in which I am going. So once we come to the neonatal seizure, then we meet the febrile seizure. Then we meet various types of seizure types of childhood, like including the epileptic encephalopathies. Then we come to the idiopathic seizures, that is the first seizure. Let us say a girl is brought to you with the first seizure. So what do you do with that? Then we come to the person who comes with multiple seizures, probably the second seizure or the third seizure or multiple seizures. Then what do? We do the EEG, we do the MRI, we do all the ancillary tests. After all these come negative, we are left with the question of which drug to choose. After that, we are left with the riddle of how long to treat. Then we are asked how to stop the treatment and then assess the recurrence of the seizure and then how long to treat. Finally, we come to the question of the intractability. Nowadays they have changed that name. They say drug-resistant seizure because intractable means including surgery. So drug resistance. Then we come to special issues like marriage, pregnancy, etc. So first we are going to the neonatal seizure. These are the ominous signs. Once you have a neonatal seizure, I think everybody will be upset. Basically, the neurologist is most upset. In the first generation, neurologists are terribly upset because they are not trained to treat neonates. Let us be very frank about it. They are not trained to treat neonates. So then, of course, the neonatologists came in. After that, the pediatric neurologists came in. So a lot of changes have occurred in that. Then the second thing is that you have a child who has got myoclonus. That is an ominous sign. Third is, of course, the presentation as status epilepticus. And then we come to the refractory status and the super refractory status. All these things could occur in idiopathic seizures. Then we come to the prolonged post-ictal state. These are all the problems we face. For example, I had a person who was in a post-ictal state for nearly 5 days. Then we come to specific EEG abnormalities. So neonatal seizures, it is not as dreaded as we thought. I'll just take 1 or 2 points because you can't go on talking about a subject, such a vast subject, and you go on talking on a particular topic alone. Now, this is cause dependent because the main factor that determines outcome is the underlying cause and not the seizures themselves. Despite high mortality, this is the latest scientific data which says that approximately 15% mortality and 30% morbidity one half of neonates with seizures achieve a normal or near normal state. 1/3 of the seizure of the survivors develop long-term epilepsy. So long-term, 1/3 do develop. So this is what you have to tell the parents also. Next one is that if the EEG background is normal, of course the MRI is a different, you get something in the MRI, then straight away you go. If the MRI is normal and the EEG is abnormal, the prognosis is excellent for seizures to solve. Normal development is likely. Severe EEG background abnormalities indicate poor prognosis. Such patients frequently have cerebral palsy and epilepsy. Now, one more thing in neonatal seizures. The biggest question is which drug to choose. I am sure the pediatricians over here, all of them choose phenobarbital. Phenobarbital has been in the scene for the past 70-80 years as the first drug of choice. Now the whole problem in phenobarbital is the cognitive development. Second thing is the behavioral abnormality. So now the emphasis is they are trying to find out whether the latest drugs, especially some of the benzodiazepines like lonazepam or the latest drug, levetiracetam, etc., could be used in neonatal. We are not going into that. I am just leaving that question open. That phenobarbital followed by eptoin was the drug of the choice of that era. Now we are trying to switch over. Then we come to I told you about the myoclonus. I'll just tell you one incident to see how to explain how dangerous myoclonus is. A child was brought 6 months ago to my OP, and the only problem they had was that one twitch, probably once in an hour or so. Then probably we took the EEG and found out that the child had SSP, and the child was not vaccinated. Child did not survive. He died in our hospital itself within 6 months. So that, as you know, I need not emphasize the point that SSP is due because you don't vaccinate. And you know the propaganda which is going on against vaccination. So at least 4 of my children have died due to SSP because they did not get vaccinated in the past 5 or 6 years. Then of course, in the elderly, of course, it is the CJD. And then PME means progressive myoclonic encephalopathy. And others are the metabolic encephalopathy. And then there's epileptic encephalopathy. We are not going into all those details, but the point is that you see a child who twitches, be careful. It has to be thoroughly investigated. There will only be a very small twitching. For example, child takes something and it slips out of the hand. Okay, they may not notice it at all. The parents may not notice at all that there is a myoclonic jerk. This is the jerk which I showed you is a jerk. In addition, of course, there is the jerk which is named not after Dr. Salam of Calicut, but Salam attacks, which is a slow movement forward, so that the child goes and hits the head. So you have a myoclonus with the child hitting the head, then you are in trouble. So that is a clinical sign. So get it, and that means you are going in for some of the epileptic encephalopathies, including BEST or Lennox-Gastaut or Dravet or DUS or Ohtahara. Don't be frightened by these names. All these mean only one, epileptic encephalopathy at different the times of the development of the brain. So the manifestations would differ from neonatal seizures to the adolescent seizures. Okay. Then, are there benign epilepsies? Yes. There are benign epilepsies. There is benign myoclonic epilepsy of the infancy to the juvenile myoclonic epilepsy, which occurs in adolescence. Why are they called benign? They are called benign because they do not lead to any sort of, they are amenable to treatment. Some of them we can treat, and then probably over a period of time they completely go into remission. Some of them, like JME, easily treatable, but you have to give lifelong treatment as per today's thought process. Now, febrile seizure, we are coming to the febrile seizure. And then, of course, the other one, self-remitting one, that is petit mal epilepsy. I am using old terms so that people should not get confused. And petit mal epilepsy, you know, it usually presents as an attention deficit disorder. they come to you because saying that the child doesn't have attention in the class. They don't have any other symptom, but they just go in for very, very extremely brief, 1 second, not more than a second, loss of consciousness with just a stare. Nothing more than that, better brought out by hyperventilation. It is self-remitting by, let us say, 10 years or 12 years, no problem. Then benign Rolandic epilepsy also self-remitting, whereby the child has got just a focal epilepsy like this, a movement of the face or something like that. And the EEG will pick it up. So you have the benign episode. That means the child is brought to you with the first episode of febrile seizure. Now what do you do? This is where we don't have any sort of consensus. We don't have a consensus about this. The morbidity and mortality associated with febrile seizures is extremely low. Even in the case of febrile status epilepticus, several large series of febrile status epilepticus reported no death. So this was a question. My chief, G. Arjun Das, India's first neurologist probably, he told me, no, epilepsy is whether febrile or febrile, it will damage the brain. So you have to, that was the thinking in those days. It will damage the brain. Why can't it damage the brain? So they have to be treated. And of course, he made a very sarcastic comment. Anyhow, it will damage the brain more than phenobarbital. That is the comment he said at that time. And then we found that no new neurological deficit occurred following. There is not a single child who has developed any cognitive problem or a neurological deficit following febrile seizures untreated. All over. Untreated means only treated at the time of the seizure by giving frisium or. So there is no, so all this, I have taken 3 different large studies. We have found no differences in IQ scores, no difference in academic achievement. Probably the fellow is going to turn out to be a bigger genius than many of you sitting over here. And behavioral measures between the children in febrile seizures, either compared with the general population there or with the siblings, did not show any change. These favorable cognitive and behavioral outcomes included children with both simple and complex seizures and multiple seizures. The number doesn't count. Multiple. A child is having multiple febrile seizures, not the complex ones where there is status and all. But still, if you look at these children, and that is what we have found also. What we have found in our practice also, that nothing happens to these children. So then the question comes. There is no last word. Why there is no last word? The question, like Hamlet's, to be or not to be, is to treat or not to treat. The main conclusion is that treatment of recurrence of febrile seizures is still performed all over the world, including PERINTHALMANNA, in an empirical manner. And that more elaborate studies are warranted in order to establish evidence-based guidelines for children with febrile convulsions. This is the Cochrane review in 2013. I didn't get any new data for this. Now, what do I do? After telling all these things, what I do is that I do what I want. So what I do is I just wait for the child to have 4 seizures. First seizure, EEG. Then the data says that EEG is not necessary. The data says that MRI is not necessary. But that data is for a Western world which is highly literate and which has got a structured method of treatment. See, for example, somebody comes to me and then I say, no, you do that thing. Don't come here at all, nothing is going to happen. The 3rd time the seizure occurs, they will go to a quack. You understand? So what I do is that I tell them why I took this 4 is that statistically 4 or 5, the number of seizures come down. First seizure probably in 100% of febrile seizure children, by it becomes 4, probably it comes down to 20%. So what I do is that I wait for a minimum of 4 seizures. Tell them first antipyretics and frisium, etc. After the 4th seizure, whether the EEG is normal or abnormal. An abnormal EEG, I tell you, is a red flag. You won't get an abnormal EEG. Statistically, it is so low. But But we do take EEGs because there are new syndromes which are coming in which febrile seizures indicate epileptic encephalopathies, like Dravet or fires and all. I'm not going to that aspect. So this is a purely empirical approach which is catering to parent susceptibility and social problems in our country. You understood? It is not scientific that you should treat the fourth seizure or the fifth seizure. It is not scientific, but we do treat even if the EEG and the MRI are normal. Now we come to the first seizure. A person comes to you with the first seizure. What do you do? That is an adolescent or an elderly person. This is the major issue. Now, the adults with an unprovoked first seizure should be informed that their seizure recurrence risk is greatest. Now, the question is that, sir, EEG is normal. Don't treat. EEG is abnormal. Treat. MRI is normal. Don't treat. MRI is abnormal. Treat. So, any of these you have to treat. Now, let us say EEG and MRI are normal. What do you do? The problem is that the risk of the second seizure. What is the risk of the second seizure? The 2-year risk of the second seizure is around 50%. I am not putting this 21, 45. I will say 50% is the risk of the second seizure. So what do you do? Do you treat or not? I don't treat. Only thing is that, now assuming that he is a driver, assuming that he is a person, person who is all around, whose vocation makes him go near the fire, then we have to treat that patient. So there a person with a prior brain insult, an EEG with abnormalities, a significant brain imaging abnormality, nocturnal seizures, we have to treat. Even though scientifically they say that there is no difference in treating or not treating. But then there is this risk of a 50% chance. And what happens if the second episode happens to be a status? We don't know. So hence, we tell them, see, there is a possibility, 50% possibility of you are getting a seizure. And then we reassure them and say that we are not going to treat you. We are not treating. No, I am not treating. Now, what about the EEG? The EEG in idiopathic seizures is not a good tool actually, because the positivity of the EEG is only 60% in the best of centers, and that too including sleep-induced EEG, EEG taken in the sleep, etc. If we put together all over, it is only probably 60%. Only thing is that it picks up specific epilepsy syndromes. It picks up epileptic encephalopathy, it picks up encephalitis, encephalopathy, SSP, CGD. So it has got a role. But in the I was speaking about the idiopathic seizure. In the idiopathic seizure, we are not at all happy with the EEG. You get it, it's good. If you don't get it, it means nothing. Again, clinically, it has to be correlated. Then we come to the MRI. Other than in febrile seizures, it is essential according to me. Why is it essential? Because in children, you may pick up so many things. The MRI, especially when the 3 Tesla and 7 Tesla MRIs are being introduced, they are picking up a lot of latest signs as far as many named signs. As far as the metabolic encephalopathies are concerned, the mitochondrial encephalopathies are concerned, and the epileptic encephalopathies are concerned. More above that, it picks up what is known as the mesial temporal sclerosis, which is a marker for you to continue treatment, not the surgical one and intractable. Even the idiopathic first seizure, this is a big problem. An MRI shows normal EEG, but the EEG is normal, but the MRI shows mesial temporal sclerosis. What will you do? This is also an unanswered question. Then it may pick up all the other things like tuberculosis or cerebral neuronal migration defects, etc., etc. So I would advise you that you should do an MRI. See, you should do an MRI because you are going to pick up something which is heterotopias in the brain. So many things are there which are coming out now. So it is better that even in the first, you may do the MRI. Now, just inform, because I don't have a watch with me, tell me just how much time is left, okay. Now, you are being bombarded. This is something like this, the bombing of London by so many drugs. When my father started his practice, there were only 4 drugs. And he was so overjoyed when they introduced valparin. Okay, when they introduced valproic acid, because that was said to be the all-rounder, which would treat all sorts of epilepsies and all. But from there now we have come to at least 30 drugs which are available in Kerala and India. Now why should there be 30? The Perampanel people came to me, they said that, see, Perampanel is there. I put a question to them, why Perampanel? So the anti-seizure activity remains the same. It has not moved an inch. 70% is the number of people who are responding to the older drugs. That has not moved an inch to 75%. It remains 70%. The achievement of seizure remission is the same. The anti-seizure activity is also same. It is not that any of these drugs are more potent than Eptoin or more potent than valparin. Then what is the advantage? The advantage is that these are broad spectrum. Most of these are broad spectrum. Lesser side effects. Drug interactions are less. Maybe, they have said lamotrigine and levetiracetam are safer in pregnancy. So, and there are certain drugs which are specific for certain conditions like Lennox-Gastaut, in which vigabatrin, and Dravet, in which tiripentol is supposed to be specific according to the FDA. Now, is there a big hype by the drug companies? Yes. They bring levetiracetam, then they'll come back and say, no, brevitiracetam is better than levetiracetam. Then they'll turn up with Eptoin and then say, no, fosfentoin is better. Carbamazepine, no, oxcarbamazepine is better. So that is another issue which we are facing. Now, how long to treat epilepsy? Single episode, EEG, MRI, normal, no treatment. EEG it's abnormal, the treatment should be for 2 years. Now the question is that, will you wait for the EEG?
Sorry to interrupt.
Oh?
2 more minutes.
How much? 2 more minutes, okay. So drug-resistant epilepsy is lifelong. And secondary epilepsy depends on the etiology. How long should the drug? There are no published data to guide the length of treatment after first seizure in adults. Each case must be viewed individually, including consideration by the medical and social consequences of another seizure. Risk of seizure is thing already I have told you. In patients with epileptic form discharge is 83%. In patients with non-epileptic form abnormalities in EEG, it is 41%. In patients with normal EEG, it is 12%. So finally coming to the last one, the drug resistance. Again, we have a controversy. The ILA says the 2 drugs. Take each drug, give maximal dose, the optimal drug for the particular disease, type of epilepsy. For example, JME valproate. Give it up to maximum, fails, then give the next optimal drug, fails. Then you take a combination of 2 drugs. And then if it fails, then think of in terms of surgical management. Probably many of us don't believe in that. We go on changing the drugs to a maximum of 3 to 4. I have seen even the senior most neurologists going up to 3 to 4 drugs. So final slide, now pregnancy. Now the point which the gynecologist should note is that pregnancy increases the epilepsy, seizure increases. Valparin has now been banned by most countries. seizures increasing, spacing of drugs is to be done, and now the drugs which we prefer are lamotrigine and levetiracetam. Now, a question comes to us. Patient is on drug, on a particular valparin, and then he comes to you, and goes to a neurologist also. Slightly difficult to control epilepsy. Will you change the drug? The consensus is that you should not change the drug. Let us take a small risk. We will take a small risk of having some iatrogenic complications, but better not to change. Second question, controlled patient comes to you with repeated seizures. Do you want to investigate again? Yes, you have to investigate again. Because otherwise you will miss CVT, you will miss PRESS, you will miss RCVS, you will miss eclampsia, a lot of things. Secondary epilepsy would be missed. So with this, I think there are various studies, and I'm not going into all those studies. So these are because it's a very large topic. And with this, I conclude. From neonatal seizures, pregnancy, idiopathic seizures in the adults, idiopathic seizures in the adolescents, we have a lot of confusion, and it is left to the practicing neurologist to use his common sense, his experience, and of course, his analysis of the various studies going on in the world, update to come to a conclusion. Thank you.
Thank you, sir. Please remain on the dais. Now I kindly request Dr. K.A. Sethi, sir.
Dr. Fasal, thank you very much for your presence, because you have been scheduled for a surgery at 3 p.m. for an appendicectomy. So thank you very much.
Dr. Soumya, any comments? Dr. Soumya? Fasal sir, we really appreciate your commitment to IMA, coming to us with from your operation bed and speaking, and actually we could see that you are in actual pain. Thank you so much from the bottom of our hearts, sir.
Thank you, sir.
We request KSCD sir to kindly hand over a memento to Fasal sir, and Dr. Soumya to kindly hand over the certificate. I request Dr. Narayana sir to kindly come on stage and give a token of our love to Dr. K.A. Sethi. And to Dr. Soumya Satyan. Fasal sir, thank you once again and wish you a speedy recovery from your illness. Thank you, sir. Ladies and gentlemen, we are going on to the formal inauguration of AMSCon 2022. Please remain in the hall. The formal inauguration will be a short function lasting about 45 minutes only.
We acknowledge the presence of the following guests on this special day. Dr. Sri Kumar Vasudevan, Convener, IMA National Ethics Committee and Chairman PP Scheme. Dr. A.V. Babu, past State President IMA. Dr. M.N. Menon, Chairman IMA Act Force. Dr. Jayakrishnan B., Tirur IMA. Dr. Muhammad Ali N., IMA Valancheri.
For the inaugural function, we request the following distinguished guests to kindly come onto the stage. First, Dr. Shashidharan K., the State Chairman of IMA AMS Kerala.
Dr. Samuel Koshi, State President, IMA KSB.
Dr. R.V. Ashokan, IMA National President-elect.
Padma Shri Dr. A. Marthanda Pillai, past National President of IMA.
Dr. Joseph Mani, IMA National Vice President.
Dr. V.P. Surendra Babu, IMA State Vice President.
Dr. Joseph Benavan, State Secretary of IMA, Kerala State Branch.
Dr. Narayanan P., IMA State Joint Secretary.
Dr. Lalit Sundaram, State Secretary of AMS, Kerala.
Dr. V.U. Siddhi, IMA Past National Vice President.
Dr. Alex Franklin, IMA Past State President.
Dr. Jayakrishnan A.V., IMA Past State President.
Dr. K.A. Siddhi, Chairman, IMA Blood Bank Committee.
Dr. Sharafuddin K.P., State Secretary, Image IMA.
Dr. Ashok Valsala, Chairman, IMA District Committee.
Dr. Sajeev Kumar P., Convener, IMA District Committee.
Dr. Hema Shashidharan, Vice Chairperson, IMA Women Doctors Wing.
And Dr. Mohammad Abdul Nasser, Branch President, Perinthalmanna IMA.
Dr. Kochu Asmani, Immediate Past President of IMA Perinthalmanna Branch.
Dr. Shanavas KP, Organizing Chairman, AMS Con.
Dr. Kasim Kolakadan, the Organizing Secretary of AMS Con 2022.
And Dr. Jalil KB, Secretary, IMA Perinthalmanna.
Thank you all. We'll start off with the inaugural function. First, I call upon Dr. Jalil KB to kindly invoke. I'm sorry for the error. First, we'll have a silent prayer. All of you, please stand up for the silent prayer. Thank you. Ladies and gentlemen, please keep standing for flag salutation. I call upon Dr. Jalil KB for flag salutation, who is the Secretary of IMA Perinthalmanna Branch.
We, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it, and realizing our responsibilities as the accredited members of this national organization, we swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Jai Hind, Jai IMA.
Next, I welcome Dr. Shanavas KP, Organizing Chairman, AMS Con, for the welcome address.
Dr. Jayakrishnan sir. Jayakrishnan sir.
Yes.
Sir, please be on the dais. Please be on the dais.
With your permission, may I adorn the Presidential Medallion on Dr. Samuel Koshi, President, IMA Kerala State Branch.
The capacity to learn is a gift. The ability to learn is a skill. And the willingness to learn is a choice. Good morning. Respected State President, State AMS Chairman, National President-elect, National Vice President, and dignitaries on and off the dais, faculties, delegates, organizing committee members, and friends. Being a member of IMA Perinthalmanna branch, it gives us immense pleasure to host IMA AMS State Annual Conference for the second time in the same venue. Perinthalmanna, the city of hospitals and one among the vibrant branches of IMA Kerala State Branch, is well known for its hospitality and had contributed many leaders to IMA state and national level. We, the organizing team, have arranged a veritable scientific feast which helps the clinicians to update, to build confidence, to stay in tune with the time and trend. Being the organizing chairman of this mega event, I am here to welcome you all. On behalf of IMA Perinthalmanna and the organizing team, we welcome the State President, Dr. Samuel Koshi sir, State AMS Chairman, Dr. Shashidharan sir, Dr. R.V. Ashokan, National President-elect, the guest of honor, Padma Shri M. Marthandapilla sir, National Vice President Joseph Mani sir, Vice President Dr. Surendra Babu sir, State Secretary Dr. Joseph Benavan, AMS Secretary Dr. Lalit Sundaran, State Joint Secretary Dr. Narayanan, IMA Past National Vice President Dr. V.U. Sethi sir, and Dr. Alex Franklin sir, Dr. Jayakrishnan A.V., IMA Past State President, Dr. Sethi K.A., Dr. Sharafuddin K.P., Dr. Ashoka Valsala, Dr. Hema Sashidharan, Dr. Mohammad Abdul Nasser, Dr. Kochu S. Mani, Organizing Convener Dr. Qasim, and Dr. Jalil. I also welcome all the faculties, the delegates, the trade delegates, organizing committee members, press and media, audio-visual team, and all supporting staff for this academic event. Jai Hind and Jai IMA.
Thank you, sir. For presidential address, I invite Dr. Sashidharan K., State Chairman, IMA AMS.
Very respected State President of Indian Medical Association, Dr. Samuel Koshi sir, National Vice President Dr. Joseph Mani sir, National President-elect Dr. R.V. Ashokan sir, our leader and past National President Dr. Marthanda Pilla sir, North Zone Vice President Dr. Surendra Babu, other senior leaders, past presidents of Indian Medical Association, Kerala State Branch, leaders on the dais, off the dais, delegates for the conference, faculty members, my dear friends, ladies and gentlemen. A very warm good morning to all. At the outset, let me thank and congratulate the PERINTHALMANNA branch and PERINTHALMANNA AMS chapter for taking up the responsibility of holding this all-important state conference of IMA AMS. And all the arrangements are in a wonderful manner, and the reception and the love and affection shown by PERINTHALMANNA, it's still there. And we are so thankful to the leaders and the members of PERINTHALMANNA branch. As you all know, IMA Academy of Medical Specialties, that is AMS, and IMA CGP are the two main and important academic pillars of Indian Medical Association. And Kerala State, as in every year, we are on with all the academic activities under AMS. And we are so happy that many of the branches and AMS chapters are very much involved in conducting academic sessions under the banner of AMS. And PERINTHALMANNA, it's a special place for all of us. The branch PERINTHALMANNA is so close to our hearts because we have so many senior leaders like Dr. Sethi sir, two Sethi sirs, and Dr. Sharafuddin, our image secretary, Dr. Shanawaz, and all other senior leaders who are very active at the, and of course our past state president, Dr. A.V. Jayakrishnan, maybe he is away at Trivandrum, that's why. And our all-important state president also from the same branch, Samuel Koshi sir. It's a special occasion for me also because PERINTHALMANNA is so important for me because after a gap of almost 33 years, IMA Talasheri backed the SS Rao Shield when the state conference was held at PERINTHALMANNA way back in 2018, I remember, 2008 I remember, and incidentally I was the branch president at that time, and I remember accepting that all-important SS Rao Shield from PERINTHALMANNA. And I'm not taking much of your time because we are lagging. I think we are almost 1 hour back in schedule. And without going into any other details, I once again thank and congratulate all the organizing committee and all the members of PERINTHALMANNA branch and wish all the success for this all-important conference. And I'm sure all the speakers will take very little time to speak so that we can wind up this session as early as possible within the scheduled time. And once again, I wish all the success for this conference. Jai IMA, Jai Hind.
Thank you, sir. Next, I would like to invite and request all the dignitaries on the dais to join for the inaugural session with the lamp lighting.
I request the State President of IMA Kerala, Dr. Samuel Koshi sir, to kindly inaugurate AMS Con 2022 by lamp lighting. I request the other dignitaries to kindly join him in lamp lighting. Thank you. Audience are requested to kindly come forward and witness the function of inauguration. Thank you, respected seniors, for joining us for the inauguration of AMS Con 2022. Thank you, thank you, thank you. We request Dr. Samuel Koshi sir, the State President of IMA Kerala, to kindly deliver his inaugural address.
Chairman of the meeting, AMS Chair, Dr. Shashidaran, National Vice President, Dr. Joseph Mani, past National President, Madanullah sir, National President-elect for the year 23-24, Dr. R.V. Ashokan sir, State Secretary, Dr. Joseph Benavan, PUC sir, KSC sir, other dignitaries on and off the dais. Let me first congratulate the organizing team who has done a very wonderful job, because the way the conference is being organized deserves special appreciation. As usual, the PERINTHALMANNA has proved its elegance in organizing this wonderful conference. Nowadays, it's very difficult to get the delegates for the conference because most of our members are reluctant to come for physical meetings. But PERINTHALMANNA has managed that aspect also. And the audience is fairly good. The topics selected are so good. Also, the speakers are of excellent academic qualifications. So as such, this conference, the state conference of IMA AMS, has been wonderfully planned and executed. Once again, I congratulate my own home branch and especially the team who has organized this conference. Let me also congratulate and thank the state team led by Dr. Shashidhar and the AMS team, because they are doing a very wonderful job all over the state. As usual, we all know, it is through the academic wings of Indian Medical Association, the Academy of Medical Specialties and the College of General Practitioners. Through these two wings, we are updating the knowledge of each and every citizen, every member of Indian Medical Association. The only drawback I am finding this year is that we need more branches to have the wings of both the academic wings, that is the AMS and the CGP wings. So the state AMS chapter chairman and the secretary should take more interest to have branches, more new branches to have these wings of AMS also. Today, we are having a very important guest, Dr. R.V. Yashogan, who has been elected unanimously to the post of National President for the year 23-24. As far as Kerala State is concerned, it's a moment of prestige, because this is the fourth time we are getting a national president. We had Dr. Velayathan Pilla, followed by Dr. P.V. George. Then we have our Padma Shri Dr. Marthanda Pilla Sir in 2015. And now that we are having an elect for the national presidentship post. And this is the first branch he is visiting after being elected to the post of national president. So this branch being my own branch, I also feel proud to have our Ashokan sir in this stage on this auspicious occasion. So congratulations on behalf of the state IMA and on my own branch also, sir. As far as the state branch is concerned, we are, as promised, we have, when I took charge as the president, I have promised many things, and as our activities are concerned, first and foremost, activity that we were carrying out was to strengthen the association. As part of strengthening the association, we have visited 107 branches throughout the state. Also, we have gone to 30 medical colleges, all the medical colleges in the state except Amrita Institute of Medical Sciences. And also, we have conducted 13 district conferences, except for Pathanamthitta district, which will be conducted within 2 weeks. We have completed the district conferences also. This has been never happened in the previous years, and through these activities, we were able to add around 5,000 members to the Kerala State IMA. That we feel is an achievement we have made as far as the strengthening of the association is concerned. And again, as far as other activities are concerned, we were trying to address all the issues, major issues being faced by the medical fraternity. The first and foremost issue that we are facing was the attack against doctors and hospitals. We are trying our level best to take care of this situation, and we feel that the number of attacks has come down, but that's not enough. We are continuing our dialogues with the government. We are continuing our legal issues, legal things also. And we feel that, and we are confident that some amicable solution or some amicable settlement will be reached as far as the attacks against hospitals and doctors is concerned. Yet another major issue that we have taken is the Clinical Establishment Act. The dialogues with the government is going on. Again, we are fighting this issue legally also. The third major issue that we have taken this year is the Consumer Protection Act. We all feel that this is a major issue that is affecting each and every member of the Indian Medical Association, not only the IMA members, it's affecting all the doctors practicing modern medicine in this country. We have approached the Supreme Court, and we feel that Supreme Court will take up our issue, and some sort of an amicable settlement will be made in that aspect also. Yet another major issue that we have taken up this year is the insecurity of jobs among doctors, especially the young doctors. We have formed a confederation with all the private medical college owners associations of Kerala, and we are conducting dialogues with them, we are conducting talks with them, and there is an amicable solution reaching. They are agreeable for taking doctors on contract basis, so that during the contract period, their jobs will be secure like. Yet another issue that we are taking is unemployment that is being created among young doctors especially. We are moving forward in that direction also. So as far as we are concerned, we are trying to address all the major issues that are being faced by the medical fraternity. Hopefully, we feel that some sort of a settlement or some sort of movement can happen in all these aspects. These few words, let me conclude, and before concluding, let me declare that this AMS State Conference is being inaugurated. Thank you. Jai AMA, Jai.
Thank you, sir. Now, for the AMS report of activities, we invite Dr. Lalit Sundaram, State Secretary.
PERINTHALMANNA for the excellent way they have hosted and carrying out this academic fest. Going on to the reports of activity of Indian Medical Academy of Medical Specialties 21-22. The total membership stands at 2,904 and the new membership is 52. The total branch chapters formed is 51 and the new branch chapters are 4, that is Payanur, Kannur, Kuthuvaramba and Nedumbasheri. We have conducted 5 monthly webinars and all were very well attended with members from outside as well as out of the state as well as the country. And our leaders were part of the Tarangam in the North Zone for membership promotion. We had 3 zonal conferences. The first zonal conferences was held at Mid-Zone, hosted by IMA-MS chapter Madhya Kerala. It's an excellent academic feast, which was conducted on 19/6/22 at IMA Hall, Alva. It was conducted well by Dr. A.K. Rafiq, Dr. Saeed, Dr. Ashok Kumar, Dr. Jyotis, and led by Dr. M.N. Menon, sir. Then the second zonal conference was South Zone, hosted by IMA Kollam. It was also very well attended with a lot of postgraduate participation and JDN also. And it was on 14th August at Rotary Community Center Beach, Kollam. And it was organized by Dr. Alfred Samuel, Dr. Jinaraj, Dr. Anish, Dr. Vinod, and Dr. LX. It was also an excellent academic feast. And the last Sunday, we had the North Zone Conference Amalgam at 28th August 2022, hosted by IMA-MS chapter Talisheri, the host branch of IMA chairman. And the whole, the academic proceedings was led by the IMS chairman, with fairly supported by Dr. Mini Balakrishnan, Dr. Aravind, Dr. Sanjeev, and Dr. Srijit. It also was an excellent academic feast. So we had completed all the 3 zonal conferences by last Sunday. And now we are hosting the MS Con, that is the state conference of IMA-MS Kerala State Branch. The IMA-MS South Zone National Conference. The IMA-MS Kerala chapter will be a part of the South Zone National Conference of IMA-MS by hosting a webinar on 21/9/2022 from 7 to 9 p.m. along with IMA-MS Tamil Nadu. The theme of for Kerala is emerging infections, and we have our panelists already declared. There's emerging infections by Dr. Mohammad Riaz, infection control in the era of pandemic, Dr. Anup Warrior, and lab diagnosis and sample collection by Dr. Beena James. It is a IMA-MS South Zone National Conference and will be a part of the South Zone National Conference along with IMA-MS Tamil Nadu. These are the list of webinars we have conducted from January till May. The first webinar was on COVID-19 challenges by Dr. Chandriya, and the last webinar on May was on by work-life balance and mental health by Dr. Arun B. Nair, Professor of Psychiatry, Government Medical College, Trivandrum. These are the zone-wise distribution of branches without AMS. I request all the branch chapters, especially in the North Zone here, will be assembled here to kindly note that in the North Zone we have a lot of branches without an AMS, especially in Malappuram we have the Kondoti, Thirurangadi, Kottakkal, Ponnani and Valanjeri that don't have an AMS chapter. So I kindly request the branch leaders who are present here to kindly start the AMS chapters at the earliest. For starting an AMS chapter, we require only 10 life members, and with the 10 life members, we can start a branch chapter in your host branch. These are the major contributors to our activities in 2022. There's IMAMS Kozhikode, IMAMS Talisheri, IMAMS Nedumbasheri, IMAMS Kuthuvaramba, IMAMS Nemam, AMS Vadagara, and Payyanur. These were the major contributors of our AMS activity this year. This is the just a gentle reminder of the membership process. We have a life membership form, and please see that when you send the life membership form, it should be complete with all the certificates that is required. Otherwise, it will not be accepted by the national headquarters. So many of you will be waiting for AMS certificate they have not received just because the certificate process is not complete. So I request all the members, when you send the membership form, see that it's complete with the IMA life membership certificate, MBBS certificate, post-graduation certificate, and both MBBS and post-graduation registered with the State Medical Council. All these 5 documents should be there along with the application form. Otherwise, it will not be accepted by the state leadership, national leadership. Again, the membership fee is just ₹1,000. It's very minimal, and I request every specialist under IMA to be a part of AMS. These are the awards on the AMS will be declared today by our Honorable State Chairman. It is a Dr. A. Shankarapilla Memorial Award for the Best AMS Local Branch Chapter, Dr. Thomas Sebastian Memorial Award, the Best Supporting IMA Branch, Best New Chapter, and few Chairman Appreciation Awards. So if you are a branch where you are waiting for the state awards, you can easily bag the state awards from the AMS by conducting the CMEs and reporting it under the AMS pillar. And we have the individual awards, the Epen Samuel Memorial Award for the Best Research Paper, publication 2022 by AMS member, and Dr. P. Alexander Memorial Oration Award. So finally, my general request is every specialist who is a member of IMA to be brought under AMS. While forwarding membership form, please make sure that it's complete. Try to start AMS branches in your respective branch at the earliest, and conduct IMA AMS programs in your branch and properly report to the state secretary. The membership process is still ongoing, even though it is the national state conference year, and kindly see that all the specialists under your branch be a part of AMS. Thank you very much. Jai Hind, Jai IM.
Next we will have the declaration of IMA AMS awards.
Request Dr. Lalit Sundaram and Dr. Shashidharan sir to kindly declare the much awaited IMA AMS awards for 2022.
Friends, as our secretary has already told, we got awards for the branch chapters and also individual awards. And as declared branch awards for IMA-AMS activities, it is a all-important A. Shankarapilla Memorial Award for Best AMS Local Branch. And the award goes to IMA-AMS Kozhikode. Kozhikode was so particular that they conduct regular meetings under the banner of IMA-AMS, and their reporting was also excellent. And Dr. Thomas Sebastian Memorial Award for Best Supporting IMA Branch, that is IMA-AMS Talisheri, with all important activities and also the reporting. And Best New Branch Chapter, as you all know, we got one overseas branch chapter of IMA-AMS, that is Nedumbasheri, and the Best New Branch Chapter goes to IMA-AMS Nedumbasheri and also IMA-AMS Kuthuvaramba. And Chairman's Appreciation Award, as you all know, the wonderful way in which the Madhya Kerala conducted the mid-zone conference and IMA-AMS Kollam conducted the South Zone, and also the state conference being held today by IMA-AMS PERINTHALMANNA, and the Chairman's Appreciation Award goes to all these branches. And we got an award, to determine the awards, we get a committee for AMS awards. Dr. T.N. Babudevi, in the past national vice president, is the chairman, and we got 2 members, Dr. Shyam from Kollam and Dr. M.N. Menon from Madhya Kerala branch. They have decided the individual awards. And AMA, Dr. Epen Samuel Award for Best Paper Publication, we got 6 nominations from different branch chapters, and the award was declared to This is the details about Dr. Ibn Samuel, who was a eminent personality, who was the physician and associate professor of medicine, GMC Cotton. And this year, the Ibn Samuel Memorial Best Paper Award goes to Dr. P.N. Suresh Kumar, who is a psychiatrist working in the KMCT Medical College, Kozhikode. He is from the Kozhikode branch chapter. And Dr. P.A. Alexander Memorial, the all-important P.A. Alexander Memorial Oration Award. It's an individual award for the one of the best faculty members from the Kerala state, and also under different branch chapters in IMA Kerala state. And the award goes to this is the Desalto Dr. P.A. Alexander, who was the past president of Indian Medical Association Kerala state branch. And the award goes to Dr. Chantini Radhakrishnan, who is an eminent teacher and an eminent faculty working in Calicut Medical College. She is the head of the Department of Emergency Medicine and Professor of Medicine in Calicut Medical College. And the oration will be held in another important state function, or maybe along with the state conference of the Medical Association, to be held in the Kundankulam branch, Kundankulam, in the month of November. And we are eagerly waiting to hear from her on that oration, on the occasion of that oration. These are the details of Dr. Chandini ma'am. And I thank the award committee members, Dr. T.N. Babu Ravindran sir, Dr. M.N. Mena, and Dr. Shyam sir, and also our state president and secretary, who help us a lot in conducting all the activities and for forming the award committee, and also deciding on all the awards and all the conference venues. And I also thank all the senior leaders and past presidents for helping us in all activities. Thank you again.
Thank you, sir. Next, I would like to invite Dr. R.V. Ashokan, sir, IMA National President-elect, for delivering his address.
As a state president of Kerala State, I may declare that the individual and branch AMS awards declared by the chairman goes to the corresponding branches. Thank you.
Beloved State President of IMA Kerala State Branch, Dr. Samuel Koshi. IMA National Vice President, Dr. Joseph Mani. Our beloved leader, Padma Shri, Dr. A. Martandapla sir. And a senior leader at 80, still a role model and light of PERINTHALMANNA, Dr. V.U. Sethi sir. Dr. Shashidharan, State Chairman, IMA AMS. Dr. Joseph Benavan, State Secretary, IMA Kerala State Branch. Dr. Lalit Sundaram, State Secretary, IMA AMS. Let me first begin by congratulating the organizing team, the organizing committee chairman, Dr. Shanavas, Dr. Qasim Kolakadan, organizing secretary of the conference, Dr. Muhammad Abdul Nasser, branch president, Dr. Jalil, branch secretary. It has been a wonderful experience to be with the PERINTHALMANNA branch. Maybe it will be remembered, I have been to PERINTHALMANNA umpteen number of times. I have even forgotten the number of times I have been here. The hospitality of the PERINTHALMANNA branch, as well as in particular Dr. V.U. Sethi, I have enjoyed throughout my career in IMA.
Let me congratulate the PERINTHALMANNA branch, the wonderful IMA hall you have, one of the role model IMA halls in IMA Kerala as well as in India. And I am so happy that it was PERINTHALMANNA. I know, maybe they had an intuition that by the time the results will be out, and they foresaw and gave me an opportunity to address you in my first encounter with an IMA meeting after being a national president-elect. I am so happy that it happens in PERINTHALMANNA. I take this opportunity to thank Kerala State Branch, the leadership unique in Indian Medical Association, led by Dr. A. Marthandapillai, his sagacity, his patience, and the quality time that he gives to Indian Medical Association, and the senior leadership, including Dr. V.U. Sethi, Dr. Bhaskaran, who have been the architect of what Kerala has been recognized for. I take this opportunity to acknowledge the magnanimity and the sacrifice of Dr. Babu Ravindran, our senior leader, who forfeited his claim for the unity of Kerala State Branch. And the whole leadership of the past presidents were so constructive. And the amount of the contribution that they did to bring the national presidentship to Kerala is something marvelous. And the state president and the state secretary themselves, being in constitutional posts, they had to keep the dignity of the chair. But they did something very wonderful. Something like what nitrogen is in atmosphere. Nitrogen is supposed to be very innocent and innocuous, but it contains the oxygen doing damage elsewhere. They were like nitrogen protecting the Kerala State Branch, but their presence was ubiquitous and their silence was so loud. Thank you, Dr. Samuel Koshi and Dr. Joseph Benavan, for being there. And the national leadership, before 5 days, acknowledged by a comment saying that look at Kerala, their unity. There was only one candidate for all the 38 posts. For all the 38 posts. The political message was so clear and loud. Let me take this opportunity to also acknowledge the sacrifice and dedication of some of the senior leaders from IMA PERINTHALMANNA branch. Dr. V.U. Sethi, he himself the architect of Kerala's victory, has been a man of reconciliation and a man who has held the fort so very well. During very difficult days, he was a light of beacon. Thank you, sir. We've been together in this process for very long, and I appreciate your senior leadership in holding together the IMA Kerala State Branch. Thank you, sir. Dr. J.K., he is also known as J. Krishna. One of the biggest assets of Kerala State, pride of Kerala State, a man, for the past 10 years, I can say the secret that every single document that has gone from IMA headquarters has his seal. Is something like a sugar in milk, not seen, but he is there. From every single letter that goes away from IMA headquarters, his presence has been ubiquitous. Then our own president, Dr. Samuel Koshi, the man who, if you see from outside, perhaps you will be mistaken. This man is so serene, peaceful like Buddha. But I can tell you a tempest and a fire which is burning inside for the profession in this man. A man who sets bars for the meticulousness in every word he says, every document he produced, and a thankless job as all the posts he has held so far. A career of 20 to 25 years of dedicated life to Indian Medical Association. I acknowledge your service and pay tribute to sir. And the morning star and Venus of IMA Kerala State Branch is none other than Sharafuddin. And thank you for what you have done to image. It's something unbelievable. Perhaps we started a nucleus, and the force amplification was done by none other than our own State Secretary, Dr. Joseph Benavan. But what you have done right now is something of an international caliber. Of an international caliber. You have taken image to a height, unbelievable height. I acknowledge the leadership crucible that the PERINTHALMANNA branch is. There are a universe of leaders here. Because of time constraints, I pay my tribute to the entire leadership of PERINTHALMANNA. Keep on contributing, keep on training youngsters into our leadership. Thank you very much for inviting me on this very august occasion. Thank you so much.
Thank you, sir. Now we invite Padma Shri Dr. A. Marthanda Pillai, past National President of IMA, who is also the guest of honor today, to address the gathering.
Dr. Shashidharan, the chairman of this academic session, our state president, Dr. Samuel Koshi, national president-elect, Dr. R.V. Ashokan, other dignitaries on the dais, and my dear colleagues. At the outset itself, let me congratulate the PERINTHALMANNA branch for organizing a very excellent CME as part of the AMS annual conference. And I appreciate and congratulate Dr. V.U. Sethi, K.A. Sethi, and all the team who has put all effort to make it a success. In fact, the hall is full, and the topics are very good, and I again congratulate you. Then, of course, Dr. R.V. Ashokan, after being elected as the national president-elect, it is his first IMA meeting after the announcement. Of course, the final announcement is yet to come, but as far as Ashokan is concerned, it is an unanimous choice, and I take this opportunity to congratulate Dr. R.V. Ashokan on this occasion. It's not something which has been gifted to him. He earned to be the national president because of the continuous work he has put in for IMA and for the doctor community. Whatever responsibility we have given to him, he has done more than justice to that post, and naturally he reached a place of undeniability where nobody can refuse him the national presidentship of IMA at the national level. So my congratulations for that. Then of course AMS. Kerala State has always been the leader of AMS, right from Dr. Mohan Das of Calicut, Dr. Roy Abraham, and all the predecessors have done a very good job. And the best organized AMS chapter is that of Kerala. And every year, the best chapter award, Kerala State do get it, and many other sub-faculties also. But then even the Kerala performance, if you go by the number, it is not enough, because the academic activities definitely has to be rooted to IMA, AMS. Particularly the objective of national IMA is to prevent compartmentalization. So much so, all the specialists and even general practitioners has to come together, and AMS provides that opportunity. But then the membership of AMS, even at the national level, is very, very less, and something actively has to be done for that. The role of AMS becomes much more, because now that NMC has companies to sponsor the events. So we are allowed to see that there is the NMC or the health ministry itself create a corpus fund so that that amount can be utilized for conducting CMEs under the aegis of the AMS. Not only that, IMA has to be, even up to now, although the IMA is conducting the monthly meetings and CME programs at the local branch level, IMA still is not recognized as a body to conduct continuing medical education program, either by IMC or NMC or even the health ministry. I am sure that with Dr. Ashokan as our coming national president, this aspect has to be taken up with the government, and IMA has to be recognized as a body for conducting CME programs, and including the CME hours that is to be given by the state medical councils. So this has to be obtained, but then before we do that, we will have to have a sort of, the CMEs has to be conducted in such a way that the attendance is marked at the beginning and the end. The topics are to be selected which are to be useful to general practitioners and even specialists. And that way, a sort of a structured CME program has to be evolved so that the CME hours naturally will become eligible. I'm sure that the leadership will go ahead with these programs. And also at the national level, the medical education policy, they are thinking of a cadre of mid-level professionals, maybe 2-year postgraduate training for various specialties. Even this opportunity, IMA had to grab so that IMA itself or the AMS itself can be a body to conduct such programs with the help of the private sector. So these are the areas where in the academic area we had to take a lead, and with Dr. Ashokan at the national level, definitely these dreams will definitely become true. And once again, I wish all the best to the PERINTHALMANNA branch for arranging an excellent CME. Thank you.
Thank you, Marthanan. Thank you, Marthanan, sir. Before we proceed with the inaugural function, there's a small announcement. There's a car with the registration number KL53K2994, a Wagoner car which is blocking the other vehicles. We request the owner to please remove it from the present position. Moving on, we will move on to the official release of the conference souvenir named Academia. I invite Dr. Rama Krishnakumar onto the stage to give a brief introduction of Academia, the conference souvenir. Following which, Dr. Joseph Mani sir will officially release the conference souvenir.
Most respected State President, Dr. Samuel Koshi sir, our National President-elect, Dr. R.V. Ashokan sir, past National President and Guest of Honor, Dr. Marthandan Pillai sir, all other respected senior leaders on and off the dais, dear colleagues and friends. As Academia, the souvenir of AMSCon 2022 is set for release. As the editor, joy and satisfaction fills the heart. What started out as a small souvenir with a few messages and abstracts has become a 134-page book with creative inputs from many a pen statewide. I am a National President-elect Dr. R.V. Ashokan sir's message, and now his speech too, was nothing short of poetry. What wonderful craftsmanship with words and regards for us, the Perinthalmannites, he referred to IMA Perinthalmanna branch in his message as one of poise, equanimity, and reconciliation, and as the womb of leadership in IMA. Thank you, sir. Our State Secretary, Dr. Joseph Benevin's message reflects his elan and delightful way with words. Every message in the souvenir has been a testimony of the fact that how high a faith the leadership places on IMA Perinthalmanna. The abstracts of the talks form the core of this souvenir and succinctly summarizes the wisdom of this conference. No words to appreciate the creativity of all contributors. Our State President, Dr. Koshi, has drawn a lucid portrait of our branch from inception. Poems and short stories have flowed from many and completed this tapestry of Academia. Acknowledging with gratitude the leadership of our branch, Dr. V.U. Sidi, Dr. K.A. Sidi, Dr. M.A. Nasser, Dr. Jalil, Dr. Sharfuddin, Dr. Shah Nawaz, and Dr. Qasim, who enthused me on this journey, and my co-editors, Dr. Abir, Dr. Vishnu Vasudevan, and Dr. Aditya, who spent many painstaking hours with me editing this souvenir. Their dedication is exemplary. Thanking Mr. Shaju from Valluva Press and Mr. Razil from Maulana Hospital for the design and layout, as well as Mr. Amanullah and Mr. Murali. Wishing you all a joyous reading and hoping for your feedback. Dedicating Academia to the entire IMA fraternity of Kerala. Jai Hind, Jai IMA.
Thank you, ma'am. Now, we kindly request Dr. Joseph Mani, IMA National Vice President, to kindly release the conference souvenir, Academia. Thank you, sir. We request Dr. Joseph Mani, sir, to speak a few words.
Most respected President of IMA Kerala State, Dr. Samuel Koshi, Chairman AMS, Dr. Shashidharan, National President-elect, Dr. R.B. Ashokan, sir, Marthandan sir, C. sir, other dignitaries, on the dais and off the dais, my dear members. As already said, I congratulate the Perinthalmanna branch for organizing the state conference of Academy of Medical Specialities in a very wonderful and nice manner. I also join with you to congratulate Dr. R.V. Ashokan, the pride of Kerala State, for becoming the national president-elect. Friends, Indian Medical Association Kerala State branch has grown very big. As already we heard, I remember in 1994, we had conducted a mid-zone conference of Indian Medical Association at Kottayam. Now there is no zonal conferences of Indian Medical Association. At that conference, I was the branch secretary and the organizing secretary, and our leader, Dr. B.U. Sethi, was the state secretary. Sir came in the morning, attended the conference, and in the night, I dropped him to the transport bus station. There was a fast passenger bus coming from Trivandrum to Perinthalmanna. At the station at 12 midnight, the bus was full. Sir got a place in the bus, and the next day morning, I asked Sir, I want to know whether he got a seat in that bus and safely traveled to Perinthalmanna. I asked Sir whether you got a seat. No money, I was standing from Kottayam to Perinthalmanna in that bus. And you all remember, Madanula Sir has a old Maruti van, a small one. He traveled throughout the length and breadth of Kerala in that van. What I meant is that at that time the membership of Indian Medical Association was 5,000, of which KG members were 3,000. Now we are going to touch 40,000 members for IMA Kerala State branch. I wish to say that the pain taken by the leaders are very high. Nowadays you cannot imagine a office bearer of Indian Medical Association Kerala State branch standing in the bus and going to more than 125 kilometers. Am I right? Yes. So that much the Indian Medical Association Kerala State branch has gone, and we have the responsibility to see that the things will go smooth. And regarding AMS, as Madanvala Sir said, IMA Kerala State branch AMS chapter or state chapter is the best branch for many years in India. I was the AMS chairman at 1 year, and I know the reports coming from the other states comparing to our activities is very little. So this is a very important for IMA Kerala State branch, and the activities, as we said, the CME programs are very important because you know the technological explosion and innovation, as management mantra says, destructive innovation is taking place in this world. What I meant is that when the typewriters came, when the computers came, all the typewriters are gone. When the mobile phones came, all the telephones booths are gone. That is what is meant by destructive innovation. And in medical field also the things are shaping like that. And a cross-sectional view of the important changes, innovations taking place in other specialties is very important to a good doctor, so that the treatment outcomes will be more and good. I thank the AMS chapters for imparting such knowledge to the practicing doctors so that the public will be benefited. And the last point is that we are hearing about, and Dr. Koshi, our president, was very strict against the attack on doctors and hospital staffs. And I would like to point out that we don't worry about that, because you know the moral and ethical values of the society is coming down. The doctors coming into the field are part of that society. The people coming to us as patients, the bystanders, everywhere, everyone are part of that society. So, we should not worry too much about that, because it is part and parcel of the society. Violence, as one of the journalists said in our district conventions, violence is a fashion among the society, the people. So we can expect violence from our patients and bystanders, but as medical professionals, we have a place here. We proved that in this COVID pandemic. We fought for the patients, for the public, and we have almost won it. So you don't worry about your future. IMA is there to protect you. We are organizing programs, especially the state president is behind that, and we hope that we will have a peaceful atmosphere in future. Thank you. Jai Hind, Jai IMA.
Thank you, sir. Next, I would like to invite Dr. VP Surendra Babu, sir, IMA State Vice President, to address the audience.
Chairman Dr. Shashidharan, IMA State President Dr. Samuel Koshi, other luminary leaders of IMA national as well as state, my dear friends, colleagues, special invitees, it's a matter of great pleasure to be part of this IMA AMS State Conference, AMSCON, being splendidly organized by the PERINTHALMANNA branch on this bright day. As every one of us knows, IMA AMS involves itself in academic matters of multidisciplinary interest, thereby enabling each and every specialist to familiarize with topics of other specialties, as well as everyone to involve themselves in the programs of our wide, big umbrella organization, that is Indian Medical Association. I had the proud privilege of being the chairman of IMA AMS a few years back for 2 continuous years. And as Dr. Joseph Mani said, he was the national IMA AMS chairman at that time. And we could bring the national IMA AMS conference for the first time in the history in Kerala. It was conducted by the Kozhikode branch. And since then, I have been observing IMA AMS very curiously and very intensely. So with that experience, I think that I can very confidently profess this IMA AMS team, the very eminent team under Dr. Shashidharan and Dr. I'm sorry, Dr. Lalit Sundaram, to go ahead to continue the award-winning spree or the award-winning trait of IMA AMS Kerala State. I envision the PERINTHALMANNA branch maintaining its excellence, and I wish this conference all the very best. Jai IMA, Jai Hind.
Thank you, sir. Now we request Dr. Joseph Benavan, State Secretary, IMA KSB, to address the gathering.
Chair of the meeting, Dr. Shashidharan, AIMS Chairman, State President, Dr. Samuel Koshi, National Vice President, Dr. Joseph Mani, President-elect, National, Dr. R.V. Ashokan, Marthandapilla sir, BUCD sir, other senior leaders on the dais. I've always been intrigued by the fact, whenever I come to PERINTHALMANNA, I always wonder what makes PERINTHALMANNA very different from the other branches. And there is always a positive vibe. There's a lot of energy in PERINTHALMANNA branch. Much has been spoken about all the leaders that represent and that are the face of PERINTHALMANNA. I'm not going into them because if I say more about them, all of them will hit the roof. But I always have a lot of admiration for one person in Perinthalmanna who actually holds the fort here. Maybe I'm wrong, but it's my judgment. I've made around 6-7 visits to Perinthalmanna branch. There is one person I've always seen who holds the fort and he turns the wheel, he spins leaders out, but he is always in the background. A big round of applause to Dr. K.A. Sethi. I think he is the man. He is the man who churns out leaders here, because as far as a leader is concerned, Dr. Samuel Koshi was in the forefront, so he was neglecting his branch. He was in the forefront of Kerala State IMA. But all the leaders, when they go out, but there has to be someone to hold the fort, and that is this one particular gentleman. Hats off to you, sir. So you are the reason for Perinthalmanna being what Perinthalmanna is all about today. Well, and another thing about Perinthalmanna is, everybody here is so talented, they are so committed. This one commitment, this is something that you don't see in the other branches across the state. See, because let's take Dr. Sashidharan, ELS. ELS has become a household name today. Everybody wants to be a part of ELS. You go to any forum, you talk about ELS, they'll say, can we get trained in that? So I think, and then Dr. Jnanadas. See, for the first time we had a complete sports meet. That was incomplete, but still we made a good beginning. So every activity that Perinthalmanna leaders take up, they take it to a higher level. And one thing about Perinthalmanna is they set their own benchmarks, and what I personally feel is only they can break it. The bars they set can be broken, can be overcome only by leaders from Perinthalmanna. So that's Perinthalmanna. Like, I'm sure all of us in the older generation, we've heard of the Onida advertisement, neighbors envy, owners pride. So Perinthalmanna remains the pride of IMA Kerala State Branch. And I really don't, you know, I can only pity the people who envy Perinthalmanna, because Perinthalmanna is Perinthalmanna and Perinthalmanna will always remain unique. Now coming to AMS, I must really congratulate Dr. Sashidharan and Dr. Lalit for the great job. We've had 3 zonal meetings. All the 3 zonal meetings were well conducted, and then Perinthalmanna has come forward to host the state annual conference as well. So the organizing committee chairman, Dr. Shanawaz, the secretary, Dr. Qasim, the branch president, Dr. Nasser, the secretary, Dr. Jalil, and all the leaders. Everybody here is a leader. And of course, Dr. Rema for the wonderful souvenir. So everything that Perinthalmanna, you know, they turn it to gold. That is one specialty, and I think that's what we all need to learn. And as for me, every time I come to Perinthalmanna and I go back, I'm a totally different man, because I've got more energy in me, you know, and I always want to emulate Perinthalmanna the way they do things. Thank you, and thank you for setting the stage for everyone. Thank you.
Thank you, sir. Next, I would like to invite Dr. Narayanan P., IMA State Joint Secretary, to address the audience.
Respected IMA State President Dr. Shashi, our esteemed State President Dr. Samuel Koshi, our beloved Ashokan sir, the National President-elect, Marthanapalla sir, Sethi sir, other senior leaders, past presidents, on and off the dais, and my dear friends and colleagues. Today I am very happy to be here as the State Joint Secretary to witness this wonderful program. And I congratulate our this organizing team headed by Dr. Shanawaz and Dr. Qasim Kolakadan and whole the entire Perinthalmanna team. Our Nasser, Dr. Jalil, as our State Secretary has told, our Shashidharan Sari sir, Jnanadas Sari sir, our Rama is there, so many leaders of Perinthalmanna. And I once again am telling to our beloved National President-elect, sir is visiting for the first time. And the first branch visiting as a National President-elect, that is Perinthalmanna. Don't worry, sir. Sir, you reached the first step in the right path. That Perinthalmanna is one of the most vibrant branches in Kerala itself. അപ്പോൾ ഒരിക്കലും ആ കൈനീട്ടം ഒരിക്കലും മോശമാവില്ല സർ. അപ്പോൾ എന്തായാലും all the best and all the best to entire Perinthalmanna team for the wonderful program. Thank you.
Thank you, sir. Next, we invite Dr. V.U. Sethi, sir, IMA past National Vice President, to address the gathering.
ഒരു മിനിറ്റ് തന്നിട്ടുള്ളേ, സമയം കുറേ വൈകിയതുകൊണ്ട്. അപ്പോൾ എല്ലാവരും ഇവിടെ വന്ന്, പ്രത്യേകിച്ച് നമ്മുടെ നാഷണൽ പ്രസിഡൻറ്റ് എലക്റ്റ് ഇവിടെ വന്ന് നമുക്ക് ധന്യമാക്കി തന്നു. പഴയ ഡോക്ടർ മാർത്താണ്ഡപിള്ളയുണ്ട്, പാസ്റ്റ് പ്രസിഡൻസ് കുറേ പേരുണ്ട്. ഇവിടുത്തെ ഓർഗനൈസിങ് കമ്മിറ്റി ഡോക്ടർ ഷാനവാസിൻ്റെ നേതൃത്വത്തിലുള്ള, കാസിമിൻ്റെ നേതൃത്വത്തിലുള്ളതിനും, അതുകൂടാതെ മറ്റെല്ലാ കമ്മിറ്റി മെമ്പർമാർക്കും ബ്രാഞ്ച് പ്രസിഡന്റ് സെക്രട്ടറിക്കും ഇവിടെ വന്ന എല്ലാ ഡെലിഗേറ്റ്സും പ്രത്യേകമായി നന്ദി രേഖപ്പെടുത്തിക്കൊള്ളുന്നു. അതുകൂടാതെ ഇന്നത്തെ ഇത് ഒരു മെമ്മറബിൾ ആവട്ടെ എന്ന് ആഗ്രഹിച്ചു വെച്ചുകൊണ്ട് പെരുന്നാളിനെ പറ്റി കുറേ കാര്യം എല്ലാവരും പറഞ്ഞു കഴിഞ്ഞു. അതുകൊണ്ട് ഞാൻ സമയം തീർക്കുന്നു. എല്ലാവർക്കും നമസ്കാരം.
Thank you, sir. Next, I'd like to invite Dr. Alex Franklin S., IMA past State President, to address the audience.
Respected Chair, Dr. Shashidharan, State President, Dr. R.V. Ashokan, President-elect, Marthana Pillai and senior leaders, my dear friends and fellow members. ഇന്ന് AMSൻ്റെ സ്റ്റേറ്റ് കോൺഫറൻസ് ഇവിടെ പെരുന്തൽമണ്ണയിൽ നടത്തുന്നു. നല്ല രീതിയിലുള്ള ഒരു കോൺഫറൻസ് ആയിരുന്നു, യാതൊരു സംശയമൊന്നുമില്ല. അതുമാത്രമല്ല, ടോപ്പിക്സ് സെലക്റ്റഡ് ഫോർ ദി CME പ്രോഗ്രാമിനും അത് വളരെ കൺസേർഡായിട്ടും നല്ല രീതിയിലുള്ള നല്ല ടോപ്പിക്സ് സെലക്ട് ചെയ്തതിന് പെരുന്തൽമണ്ണ ബ്രാഞ്ചിനെ പ്രത്യേകം ഞാൻ അഭിനന്ദിക്കുന്നു. അതുപോലെ തന്നെ AMSൻ്റെ അദ്ദേഹത്തിന് ചെയർമാനും സെക്രട്ടറിയും നല്ല രീതിയിൽ പ്രവർത്തിക്കുന്നുണ്ട്. സൗത്ത് സോൺ കോൺഫറൻസും നോർത്ത് സോൺ കോൺഫറൻസും അതുപോലെ സ്റ്റേറ്റ് കോൺഫറൻസുകളും പല രീതിയിൽ നടത്തുകയും ഒക്കെ ചെയ്യുന്നുണ്ട്. അവരുടെ പെർഫോമൻസ് കൊണ്ട് അവർക്ക് ഒരു ആസ് യൂഷ്വൽ, കാരണം വെച്ചാൽ അവാർഡ് നാഷണൽ ലെവൽ കിട്ടട്ടെ എന്ന് ഞാൻ ആശംസിക്കുകയാണ്. കാരണം വെച്ചാൽ AMS കേരള ചാപ്റ്ററിന് എപ്പോഴും ഒരു അവാർഡ് ഏത് രീതിയിലെങ്കിലും വാങ്ങിയിട്ട് മാത്രമേ വരുള്ളൂ. പക്ഷേ ഇതിനെല്ലാം കാരണഭൂതനായിട്ടുള്ള ഈ പെരിന്തൽമണ്ണ ബ്രാഞ്ചിനെ പ്രത്യേകം അഭിനന്ദിച്ചാലേ പറ്റുള്ളൂ. കാരണം എന്ന് വെച്ചാൽ അതൊരു അതിശയോക്തിയായിട്ട് എനിക്ക് തോന്നുന്നില്ല. കാരണം വെച്ചാൽ ഇവിടെ ലീഡർ ഓഫ് ലീഡേഴ്സാണ് ഉള്ളത്. സ്റ്റേറ്റ് പ്രസിഡൻറ്റുമാരും നാഷണൽ വൈസ് പ്രസിഡൻറ്റുമാരും ഒരു ക്രൗഡ് ഓഫ് ഉള്ള ഒരു ബ്രാഞ്ചാണ് പെരിന്തൽമണ്ണ. അപ്പോൾ അവർ നടത്തുന്ന കോൺഫറൻസ് ഒരിക്കലും മോശമായിട്ടില്ല, ഒരിക്കലും മോശമാകാൻ പറ്റുകയില്ല. കാരണം വെച്ചാൽ ഇത്രയധികം ലീഡർമാർ കോൺസെൻട്രേറ്റ് ചെയ്തിരിക്കുന്ന ഒരു ബ്രാഞ്ചിൽ ഒരിക്കലും നല്ല രീതിയിലാകാതിരിക്കാൻ സാധിക്കില്ല. അതുകൊണ്ട് എല്ലാ ആശംസകളും പെരിന്തൽമണ്ണയ്ക്ക് ഞാൻ അറിയിക്കുന്നു. അതോടൊപ്പം തന്നെ പെരിന്തൽമണ്ണയുടെ റോൾ ഇൻ നാഷണൽ പ്രസിഡൻ്റ് ആകാനുള്ള ആ റോളും ഞാൻ എടുത്ത് പറയുന്നുണ്ട്. ഡെഫിനറ്റായിരുന്നു ഇവിടെ 2 കാൻഡിഡേറ്റ് കേരളത്തിൽ നിന്ന് ഉണ്ടായിരുന്നുവെങ്കിൽ നാഷണൽ പ്രസിഡൻഷിപ്പ് നമുക്ക് കിട്ടുകയില്ല. അത് കിട്ടിയത് തന്നെ ഔട്ട് ഓഫ് ദ ടേൺ ആണ്. സാധാരണ രീതിയിൽ 10 വർഷം കഴിയാതെ നമുക്കൊരു നാഷണൽ പ്രസിഡൻറ്റിനെ കിട്ടാറില്ല. അപ്പോൾ ഇവിടെ യുനാനിമസ് ആയിട്ട് ഒരു കാൻഡിഡേറ്റിനെ തിരഞ്ഞെടുക്കാൻ അതിൻ്റെ പുറകിൽ പ്രവർത്തിച്ച മാർത്താണ്ഡപിള്ളയും BUCDയെയും ബാബുരവീന്ദ്രനെയും പ്രത്യേകം അഭിനന്ദിച്ചേ കഴിയുള്ളൂ. അപ്പോൾ അതിവിടെയും ഇതാണ് നമ്മുടെ പെരിന്തൽമണ്ണയുടെ റോള് ഉണ്ട് എന്നുള്ളതാണ് ഞാൻ എടുത്തു പറയുന്നത്. അപ്പോൾ അതുകൊണ്ട് എല്ലാ രീതിയിലും നല്ല രീതിയിൽ പ്രവർത്തിക്കുന്ന ഈ പെരിന്തൽമണ്ണ ബ്രാഞ്ചിനെ അഭിനന്ദിക്കുകയും അതോടൊപ്പം തന്നെ AMSൻ്റെ ഈ കോൺഫറൻസിന് എല്ലാ ആശംസകളും നേരുന്നു. താങ്ക് യു വെരി മച്ച്.
Thank you, sir. Now we invite Dr. Jayakrishnan AV, IMA past State President, to address the gathering.
Respected President Chair, സമയം വൈകിയതുകൊണ്ട് ഞാൻ കൂടുതൽ ദീർഘിപ്പിക്കുന്നില്ല. ഇവിടെ ഈ കോൺഫറൻസിൽ നമ്മുടെ ആതിഥേയരായി പങ്കെടുത്ത എല്ലാ വിശിഷ്ട വ്യക്തികളെയും അവർക്ക് ഞാൻ നന്ദി പറയുന്നു. ഇവിടെ ദേശീയ പ്രസിഡൻ്റായി തിരഞ്ഞെടുക്കപ്പെട്ട അശോകൻ സാറിന് എൻ്റെ പ്രത്യേക അഭിവാദ്യങ്ങൾ. അതുപോലെ ഈ കോൺഫറൻസ് ഏറ്റവും ഭംഗിയായി ഓർഗനൈസ് ചെയ്യാനായി നേതൃത്വം നൽകിയ ഷാനവാസ്, ഡോക്ടർ കാസിം, അതുപോലെ ഈ ബ്രാഞ്ചിലുള്ള മറ്റ് ഇതുമായി ബന്ധപ്പെട്ട് പ്രവർത്തിച്ച പ്രസിഡന്റ്, സെക്രട്ടറി ഉൾപ്പെടെ എല്ലാവരെയും അഭിനന്ദിക്കുന്നു. ജയ് ഹിന്ദ്.
Thank you, JK sir. Because we are running short of time, several of our leaders have expressed their unwillingness to speak as felicitation today. They include Dr. KACT sir, Dr. Sharifuddin KP, Dr. Ashok Valsala madam from Malappuram, Dr. Hema Shashidharan madam. All these people are told that they are not speaking. Next, we invite Dr. Mohammad Abdul Nazar sir, the branch president of IMA Perinthalmanna, to speak a few words.
And Dr. Shashidharan, national and state leaders, and dear members of Indian Medical Association, good afternoon and greetings from IMA Perinthalmanna, led by Dr. Samuel Kosi and Dr. Joseph Benavan, and the AMS State Office led by Dr. Shashidharan and Dr. Lalit for giving us this opportunity to host this wonderful academic event of the Kerala State Branch. We consider it as an honor to the branch of Perinthalmanna and an honor to the present team, and we think that it's definitely a milestone during our period. There's one thing which I must mention this meeting is that the wonderful work done by the organizing team led by Dr. Shanavas as the chairman and Dr. Kasim Kolakadan as the secretary. Another point which I must definitely remark at this moment is the work done by the Sovani committee led by Dr. Ramakrishna Kumar, Dr. Abir, Dr. Vishnu and Dr. Aditya. When I have gone through that souvenir, I was really proud that they did a wonderful combination of the academics, and they brought out the talent of the members and the family, and they did a wonderful and beautiful designing. Congratulations to the team of Sovani committee. And I hope that our leaders, the members from other branches and officials, you really enjoyed our hospitality, and whatever success we gained is a combination of the guidance from our senior leader.
22 for the vote of thanks.
Good morning to all. Nasser sir already, it's good afternoon then. Nasser sir already gave a vote of thanks briefly, so I am not going very detail. Our beloved Samuel Koshi sir, Dr. Shashidharan sir, A.V. Ashokan sir, Marthan Pilla sir, and other dignitaries of and on the dais. On behalf of IMA Perinthalmanna and the organizing committee, I thank the state leaders and IMA AMS leaders to give us this opportunity to host this wonderful program in Perinthalmanna. I thank all our senior leaders, VU sir, KS sir, JK, Sharafuddin, for guiding us in this program. KS sir used to haunt me every day in the veranda whenever we meet about the progress of the program. Our Nasser sir and Jalil sir, Dr. Jalil did a wonderful job in helping us to make this program a success. Thank to our chairman, Dr. Shanavas, and all the committee members to make this event a big success in a very short time. Thanks to all the faculties, delegates, media, audio-visual team, company partners, hospitals in Perinthalmanna, IMA Perinthalmanna staff and members for making this event a wonderful success. Thanks to all those whom I missed unintentionally. Thank you. Jai Hind. Thank Jai IMA.
Thank you. We'll conclude the formal inauguration session with the national anthem. Janagana mana adhinayaka jaya he.
Janagana mana adhinayaka jaya he. Bharat bhagya vidhata. Punjab Sindh Gujarat Maratha. Dravida Utkala Vanga. Vindhya Himachala Yamuna Ganga. Uchala Jaladhi Taranga. Tava Shubha Name Jage. Tava Shubha Ashish Mage. Gahe Tava Jaya Gatha. जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you all. We'll continue with the scientific deliberations. The next in line in our talks today is a talk by Dr. Srikumar Vasudevan, who is the convener of IMA National Ethics Committee. And delegates are requested to kindly stay back. The talks are continuing. Please don't go away. Dr. Srikumar Vasudevan will be talking on litigations in medical practice, current scenario. To chair the session, we invite Dr. Shamila A. and Dr. Jnanada sir to kindly come onto the stage.
Check 1, 2, 3, check.
All of you please be seated. The talks are going on.
So we are going to start resuming the academic activities. The litigations in medical practice is a very important topic in our clinical practice. To discuss about the topic, we have a very eminent person, Dr. Srikumar Vasudevan. He is a doyen in this field of medical ethics. And he was past State Secretary of PP scheme, past President of IMA Kerala State, and national leader. So I invite Dr. Srikumar Vasudevan to go ahead with the talk.
Respected Chair and all delegates, my topic is litigations in medical practice, the current scenario. Medical profession is always considered to be a noble profession. However, it's not immune to negligence due to lack of care and skill, which causes injury and sometimes even death of patients. Unfortunately, the interpretation of the law to deal with medical negligence by various courts and the law enforcing agencies have sometimes been misleading, leading to wrong conviction and punishment. So doctors are always apprehensive while practicing their profession. At the outset, I think let's pay homage to a colleague who departed, who left us for a heavenly abode on the 29th of March 2022. Her parting words were, "Perhaps my death might prove my innocence." My dear colleague, your innocence could have been easily proved without you taking such a drastic step. As far as the various avenues for people to go and give complaint against doctors, you see so many avenues are there: the criminal courts, the consumer courts, the civil courts, the Human Rights Commission, the Lok Adalat, the medical councils, the Women's Commission, the Child Rights Commission. All these are avenues where people can go and file a complaint against a doctor. And nowadays people have become more and more aware of these avenues, and they are become more aware of their rights. Hence, but unfortunately, doctors ordinarily think of law only when they have to defend a case of medical negligence. But there are many aspects of law which govern the practice of a medical practitioner, which he should be familiar with. Moreover, and hence a basic knowledge of how medical negligence is adjudicated by the various courts of India will help a doctor to practice his profession without undue worry. I sincerely hope that people, members, are aware about this landmark judgment that Jacob Matthew was the state of Punjab, which was given out by the Honorable Supreme Court by none other than the then Chief Justice, Justice R.C. Lahoti, Justice G.P. Mathur, and Justice P.K. Balasubramaniam. They were of the view that there is an increase in the number of cases of criminal negligence against the doctors on a mere complaint by a person. And they were of the opinion that neither the complainant nor the investigating officer had requisite knowledge about medical science to know whether actually there is a criminal negligence and whether they should be arrested or they should be FIR should be filed against them under section IPC 304A. So they felt that once a case, a criminal case is charged against a doctor, naturally, there is a lot of harassment, there is a lot of embarrassment, and he has to seek bail, which he may or may not get. And at the end of the day, when he is, most of the time, he will be exonerated. But by then, the damage caused to his reputation, to him mentally, will be irreparable. So they said that there should be some sort of protection for doctors, and they exhorted the state governments, the central government, to frame a guidelines on how doctors can be prosecuted for criminal negligence. But till then, they set a few guidelines. They were of the view that they said that to prosecute a doctor for criminal negligence, a doctor should have he has done something which no ordinary doctor in his no medical professional's ordinary senses and prudence would have done, or he failed to do something which no medical practitioner in his ordinary senses and prudence would have failed to do. That was the first line of protection. The second line of protection was a complainant, if he has to give a complaint of criminal negligence against a doctor, he has to have a credible opinion from another medical practitioner who says, yes, this doctor has done criminal negligence. That was the second line of defense. The third line of defense is, having got this complaint, the investigative officer cannot just proceed. He has to take another opinion from a credible opinion from a doctor in government service, qualified in that branch of medical practice. And having got all this, even then, the investigating officer just cannot go and arrest him. He should prove that there is a situation where he has to be arrested. Not only he can investigate further, or sometimes the doctor may go missing. Only then can he be arrested. These are the structural framework which the Supreme Court made. And thankfully, as far as Kerala is concerned, we have a circular memorandum thanks to the efforts of Indian Medical Association Kerala State Branch. Here, if there is a complaint against a doctor for criminal negligence, the investigating officer, DYSP, then has to contact a DMO who forms a district expert panel. The DMO will be the convener. The other members of this committee will be the public prosecutor and a forensic expert from the nearest medical college. And they can incorporate a specialist of the same branches which is being involved. And then they will call for the records, look into it, and then decide whether there is a criminal negligence or prima facie. There are three options. Either all the committee members will unanimously say that there is criminal negligence, prima facie, then the doctor has the right or the option of going and appealing to the apex committee. The other two possibilities are, there will be a unanimous opinion by all the committee members that there is no criminal negligence, or there will be a conflict of opinions between the committee members to say that there different opinion. In those two cases, the DYSP, the investigating officer, has the option of going to the apex committee. As far as the apex committee is concerned, it is formed by the DHS, who is the convener. The other members are the DME, the Additional Director of Health Service Vigilance, and the Director General of Prosecution. Here again, they can incorporate specialists of that branch, whichever is involved. they can call for the records. Here, the doctor concerned also can be called and his opinion can be taken. But what I wanted to highlight in both the instances is that the importance of the case records. Friends, my only request is be careful about your documentation. Documentation is the most important thing. Because today, on the 4th of September 2022, if there is an unfortunate incident occurring, and you have done everything possible under the sun for the patient, what will be taken, your case will be taken up probably 6 months or 8 months later. At that moment of time, the only proof that you have done something is your case records. So, my friends, I repeatedly say that just as you try to improve your skills, your knowledge about medical science, also try to improve your case sheet writing. Because I believe that the more you write, the better you write. And very often I have seen people telling, problem case no, you cannot write that time. So make it a habit to write your case sheets properly. I'll just see, documentation is a whole topic to be discussed for a full day. I'll just put it in one slide. One of the most important things is consent. You have to note all the details, and whenever, each time you visit, you write a few sentences about it. The doctor's orders and the nurse's record should be tallying, especially the time. And the patient's rights, you should maintain a record for 3 years. That is according to the MCI, and the new draft which has come out by the NMC is also say. But I would request you to keep it for at least 5 years. Because the civil courts you can give a case within 3 years. Sometimes they condone if there is further delay. So if you have the case records, keep it for 5 years. And one important thing is, if you feel that there is some probability of a litigation coming against you, that particular case sheet, keep it in safe custody. Because usually these case sheets go to the medical records department. And there is no guarantee that it will not be tampered with. There is no guarantee that it will not be lost. Because if you can't provide your case sheet, the court will say that you are manipulating. So request, whenever it is, see that it is kept in safe custody. And whenever a patient asks for, or a relative asks for the case sheet, you are supposed to give it as per the MCI guidelines. It is 72 hours, but the new draft NMC which has come, it says 5 working days. And these are few acts which I request all of you should be knowing. The PCPNDT Act is involving those who use ultrasound machines. It is not only radiologists today who use. You have cardiologists, you have neurologists, you have anesthesiologists, you have orthopedic surgeons, you have the emergency medicine doctors. A wide range of specialty doctors have been using these ultrasound machines, and all of you should be aware of the PCPNDT Act. I still know there are doctors who use these portable machines going from one hospital to another. That is against law. A criminal offense can be taken against you. So friends, I request you to be careful. I request radiologists, because the radiologists also, that the certificate given is in the name of the radiologist for an institution. But if someone brings into that institution a portable machine, and the certification of that institution will be lost. So there are so many other things. MTP Act, those who are doing MTP, you should know. POXO Act. I think this is one act which every medical graduate should be knowing. Because when there is a patient who has been child who has been sexually assaulted comes to you, you have seen the patient, and if you don't report to the police or to the child line, and later it comes to know that you were the first doctor to have seen this patient, you had it. A non-bailable criminal offense can be charged against you. So friends, I request you to know what is POXO Act. And as far as consumer courts are concerned, consumer courts came into existence in 1986, but medical profession came under the ambit of consumer protection in 1992, and we have a new act in 2019. Now there's a $1 million question whether we do come under the consumer protection. There are two schools of thought. One says that we do come, another school of thought says we don't. So let us, it is going to be decided shortly. It's already in the Supreme Court. They will decide once and for all whether we do come under the CPA or not. But then it's always safe to know. If once we are not there, it's okay, fine, good. So there are three at the district level. You have a state level, and the national level you have consumer courts. And what you should remember, the new act says that in a district court, up to 1 crore of compensation can be asked. Actually, it's not compensation, goods for service. I just say compensation. It was 20 lakhs at the district level. That has been raised to 1 crore. And in the state commission, you can give a complaint for a compensation between 1 crore to 10 crores. And the national commission, it is above 10 crores. That is unlimited. So that is what you should be careful about. And if you lose a case in the district court and you go for appeal to the state commission, you have to pay, initially it was half the amount awarded against you, or 25,000. Now that 25,000 has been taken away, it is only half the amount of the verdict against you. If it is from state to the national, it was half the amount, or 35,000, that has gone, 35,000 has gone, it is again half the amount. And from the National Commission to the Supreme Court, it was half the amount of 50 is gone off. So today, the bird, so 50% of the amount awarded. So they have been awarding 10, 20 lakhs nowadays against doctors. PP schemes has got a huge burden because of this. Even with this 25, 35 and 50, we have a deposit of nearly 22 crores in various courts. Now imagine the burden, financial burden on PP scheme if it is going to be half. So we should be very careful in our practice. And territorial jurisdiction, till now it was a case could be given against a doctor in a place where he resides or where the treatment has been given. But now a new place has been added, in the place where the complainant resides. So we have a lot of migrant laborers or guest laborers, whichever way you want to say. He comes from Assam, he comes from Bengal, he comes from Karnataka, he comes from UP, he comes from Bihar. And you will be, if there are cases against you, you will have to be traveling to all these states to fight your case, to see that we are not included in CPA. And there is another new method of dispute redressal, where there is a mediation cell. There will be empaneled mediators. They will look into it, your thing, and try to clear the dispute. So 3 options can again be there. A dispute can be fully settled. If it is fully settled, whichever, in the 3, the consumer courts, they can go back and say that it has been settled, and they will implement it. If it's partially settled, all those points which have been settled in the mediation will be implemented. The rest will continue as a litigation. And if there is no settlement, then the case will continue in the respective court. But there is one important thing which you should know. This mediation cell will not take up cases of medical negligence resulting in grievous injury and death. And I added this slide, is the Central Consumer Protection Authority, which deals with false and misleading advertisements. So friends, there are hospitals who put up false and misleading advertisement. Till now, when you ask a doctor, he says, I don't know, I am just an employee, just the management was there. You can't just escape nowadays with that. If you are part of the advertisement, you are going to be prosecuted also. So you should be aware of what the hospital is giving advertisement. You just can't say, I don't know. So I request you to make sure, talk with the management whenever you join, that there should not be false and misleading advertisements. And if you do that, you will have a fine of 10 lakhs, and if you repeat it, it can go up to 50 lakhs. There was a clause where frivolous complaints would be taken against the complainant and 10,000 used to be fined. That clause has been taken away now. And if you don't comply with the orders of the commission, you can get imprisonment of 3 years or 25,000 to 1 lakh. That was as part of the the medical councils. The case can go even to the medical councils. And the medical councils, abuse of professional position by committing adultery or improper conduct is one case. If you are being convicted by a court of law for offences involving moral turpitude or criminal acts, your name can be struck off, violating the provisions of the 3 acts which I mentioned. Soliciting patients, that is cuts and commissions. I don't have to go in depth of it, you know that. Cuts and commissions, getting from scan centers, getting from labs, all this. Don't think that it is, you cannot be caught. There are ways and methods which you can get caught. If there a complaint goes, and if it is proved that you are taking cuts and commission, your name could be struck off from the medical council's list. So be careful of when you do all such unethical or illegal activities is my personal request. And as far as the pharma industry is concerned, they have set the guidelines. It's the gifts you have to, below 1,000 rupees you can take. That is what they say. Between 1,000 to 5,000, you will be censured. Between 5,000 to 10,000, 3 months. Or you could be removed from 10,000 to 50,000 for 6 months. And above 50,000 to 1 lakh, 1 year. And above 1 lakh, it is more than a year. So you could face any of these points if you take gifts. And travel facilities, you're going for conferences, and if they are going to sponsor your flight tickets, the same criteria is there for that also. Hospitality, you stay in the 5-star hotels, thanks to at the courtesy of pharma companies, and if you get caught, the same principle applies. The same punishment applies, or not principle, I would say. And cash, it's very sad that doctors do accept cash and monetary gifts from pharma companies. The same thing. I have heard many, because as an ethics committee chairman of the state and of the national ethics committee, many reps come and tell me, doctor, they have been asking me cash. I tell them that you are the people who are bribing our doctors. He said, we are not, they are asking. So I see they have, and they told me, they collect in, they give in checks. There is evidence to prove that you have taken. So I sincerely request doctors, if you find doctors who are doing this, I'm sure none of these doctors seated here are doing it, but if you know there are doctors who are doing it, please tell them not to do it. It's your bound and responsibility to inform them. If they are not responding, you can inform the IMA, who will look into it and take necessary action or give them the proper advice. Even despite that, if they get caught, God forbid them. And a Lok Adalat is another way where which accept cases, and it will be settled by conciliation or compromise. Even those cases which are in the various courts can be taken up by the Lok Adalat, or it can go directly to the Lok Adalat. If you are not satisfied with this the verdict, you can go for an appeal to the High Court. One important thing is there is no court fee. So it's free of cost for a complainant to give a case against a doctor. As far as the human rights, the Women's Rights Commission and the Child Rights Commission, these are commissions who can say whenever there is a violation, they will say, that is all. But they cannot give any monetary compensation. Well, this is one of the biggest problems being faced by doctors today, and that is the cyberbullying. And that is why I have said it is the new age Ravan. And it's a virtual bullying with real consequences. It's aggressive, intentional act carried by group or individuals using electronic forms of contact repeatedly and over time against a victim, that is a poor doctor who cannot easily defend himself or herself. And the criteria, they have an intent to harm. They want to destroy your reputation. They want to destroy your practice. That is the intent they have. There is an imbalance of power. You are a poor guy, and they have a battery of people who are working in the social media against you. It's very difficult. They are very powerful, and they are trained for that. And there's a repetition of the act. You react in two ways. One is the non-legal reproach. The other one is the legal reproach. The non-legal approach is ignore it, respond to it, try to get it deleted, suppress it. And as far as the legal is, when you are going for or you keep always the records of all the defaming statements, don't delete photos or emails or any other information. Take screenshots of the various posts. Sometimes they withdraw it and hold on to evidence that indicates the user's identity. And legal approaches, unfortunately, you can file a case, and the 66A was there, which has been removed by the Supreme Court thanks to the voters, those who are preaching about freedom of expression. They have succeeded in removing 66A. That was a very good weapon in the hands of people like us. But now you can go and give 69 and 79 of the IT Act. And the way you go for legally is the advocate notice or the defamation. But defamation suit is time consuming and expensive. And let me tell you one thing, my dear friends, it is not as simple or is not as structured as you go and give in the consumer code or deal with. There's no protocol. It varies from case to case. Each individual's case is different. How you handle cyberbullying, it's not very easy. Whether you can't say for that doctor you have gone to the court, for me you are not going, why I want compensation, why you're not. It is not that very simple. It is very difficult. And Mark Twain, a famous writer, entrepreneur, publisher, had said, a lie can travel halfway around the world while the truth is putting on its shoes. By the time we get ready to fight a case against them, it is already spread to a large extent. And then when you go for that case, it has the cobra effect. What is cobra effect? Is simple, that when you sometimes, as soon as the people come to know that you are going to go legally against it, this also is spread among the social media, and that fellow who is the actually fellow who is doing all this thing, he becomes a victim, and people start sympathizing with him. And moreover than that, those who are ignoring this starts looking into it. What is happening? Why is he being charged legally? And that is the cobra effect. Cobra effect is an anecdote. Actually, what happened was during the British rule, before we got independence, in Delhi there were a lot of venomous snakes. The British government said that those who bring dead snakes to us, we will be giving him some money, remuneration. And Indians are very enterprising. They started breeding cobras. And they used to kill it and go and take money. The British government understood that they are doing this. So what they one fine morning they said, we have stopped this. They are having a lot of cobras which they are breeding. They left it onto the streets. So the problem became much more intensive than what it was initially. So that is cobra effect. So the general principle is be calm, you have ethical, compassionate. During negotiation, the mobile phones are used, cautious while talking over the phone. And to conclude, let us accept the fact that medical services are being subjected to various forms of litigations. But there is nothing to apprehend or fear. Let us treat patients with respect for their rights, give them accepted evidence-based treatment, standard and compassionate care, maintenance of proper records, and above all, take them in confidence as partners in care of the health. Thank you. Stay strong. Stay safe.
So congratulations, sir. It was an excellent talk. And you have almost beautifully told about how we can escape from a litigation. And this, I think, our co-chair has to.
Thank you, sir. It was very... I don't have any questions. I all looks clear.
Thank you.
Thanks a lot, sir.
Any point to be raised?
Any questions?
Dr. Santosh.
Just I want to add for that PNDT Act. The PNDT Act, ഞാനിപ്പോൾ വയനാട് മലപ്പുറം ആൻഡ് പാലക്കാട് ഞാൻ ട്രെയിനിങ്ങിന് പോകാറുണ്ട് DMO വിളിച്ചിട്ട്. അപ്പോൾ ഈ രസം എന്താണെന്ന് വെച്ച് കഴിഞ്ഞാൽ നമ്മളൊരു 300-350 സ്കാൻ ഉള്ള സ്ഥലങ്ങളിൽ വിളിച്ചു കഴിഞ്ഞാൽ 50 പേരോളെ വരുള്ളൂ. 300 മുതൽ 500 വരെയുള്ള സ്കാൻ സെൻറ്ററിന് ഇൻവിറ്റേഷൻ വരണമെന്ന് പറഞ്ഞ് ഭീഷണിയുള്ളൊരു ലെറ്റർ അയച്ചാൽ പോലും നമ്മുടെ അവിടെ മീറ്റിംഗ് ട്രെയിനിങ് അറ്റൻഡ് ചെയ്യാൻ വരുന്നത് ഒരു 50ഓളം പേരെ കാണത്തുള്ളൂ. അതിൽ ഡോക്ടേഴ്സ്, അത് സ്കാൻ സെൻറ്ററിൻ്റെ ഓണേഴ്സ് ആയിട്ടുള്ള ഡോക്ടേഴ്സ് കാണത്തില്ല. മിക്കവാറും ഒരു മാനേജർ അല്ലെങ്കിൽ അവിടെ എടുത്തു കൊടുത്ത് എഴുതുന്ന ഒരാളെ വിടത്തുള്ളൂ. പിന്നെ വേറൊരു കാര്യം ഇതിനകത്ത് പോയിൻ്റായിട്ട് പറയുന്നത് പോക്സോ കേസ് പോലെ തന്നെ വളരെ ഭീകരമായൊരു കേസ് തന്നെയാണ്. ഇപ്പോൾ ഈയിടെ വന്ന കാര്യം, ഞാൻ ഈയിടെ ഒരു 2 മാസം മുമ്പ് ഒരു സെൻട്രലിൽ നിന്ന് വന്നിരുന്നു. അതിനകത്തൊരു റേഡിയോളജിസ്റ്റ് ഉണ്ട്, അതിനകത്തൊരു ഗൈനക്കോളജിസ്റ്റ് ഉണ്ട്. ഈ റേഡിയോളജിസ്റ്റും ഗൈനക്കോളജിസ്റ്റും ഈ സ്കാൻ ചെയ്യുന്ന റേഡിയോളജിസ്റ്റിനെയോ ഗൈനക്കോളജിസ്റ്റിനെയോ ഒരു വിധത്തിൽ ഹെൽപ്പ് ചെയ്യത്തില്ല. അവിടുത്തെയുള്ള മെയിൻ ചീഫ് ജസ്റ്റിസിന് പവറുള്ള ഒരാൾ ചോദിക്കുന്നു, ഇപ്പോൾ റേഡിയോളജിസ്റ്റ് ഞാനൊരു കാര്യം പറഞ്ഞാൽ ചോദിക്കുന്നത് ഈ ആൾ പറയുന്നത് ശരിയാണോ ഇല്ലെന്ന് പറയാനുള്ളൂ, രക്ഷപ്പെടുത്താനൊന്നുമല്ല. അപ്പോൾ അങ്ങനത്തെ ഒരു വർത്താനം പറഞ്ഞിട്ട് അവർ നേരെ വന്ന കോന്നിയിലെ 2 ഹോസ്പിറ്റൽ അടപ്പിച്ചു, പിന്നെ നേരെ പോകുന്ന ഇടുക്കിയിൽ 2 അടപ്പിച്ചു, പാലക്കാട് 2 അടപ്പിച്ചു, പിന്നെ അവരങ്ങ് പോവുകയാണ്. അപ്പോൾ പ്രോബ്ലം എന്ന് വെച്ചാൽ എല്ലാവരും വിചാരിക്കും നമുക്കൊന്നും ഈ കുഴപ്പം വരികയില്ലെന്നും, ഇത് നമ്മുടെ DMO സക്കീന മാഡവും രേണുക മാഡവും ഒക്കെ അല്ലേ ഉള്ളൂ എന്ന് വിചാരിക്കും. ഒരു ഹെൽപ്പ് ഇവർക്ക് ചെയ്യാൻ പറ്റില്ല.
Thank you, Santosh sir. Any more questions? If there are no more questions, we'll close the session.
Sir, this record keeping actually, the bodies like NABH should really ensure that medical recording we do properly. But we see that in so many NABH accredited hospital, medical recording is not properly done. In any other country, insurance and these accreditation bodies make sure that the doctors record everything.
See, that is entirely different. Insurance it is not like NABH, the NHI, that is the National Health Insurance Companies of UK and all. That is entirely different thing. In India, it is not there. The coverage of, or the penetration, I would not say coverage, the penetration of the insurance sector into the private medical practice is very limited. Whether it is the state or the private insurance company, it is very limited. And very often the rates quoted is very low. So many of the hospitals do not come are not among the empanel thing. So all this is very difficult, because when there is a law, you just can't say that NABH is. But NABH has done a very important thing as far as consent forms are required. There is a case record, is how case documentation. Documentation, a very important thing they have been doing. They have been doing the right thing. So that in a way is improved the documentation in many of the hospitals which come under NABH. The document, because as a secretary and as the chairman of PP scheme, I have seen the case sheet. Unfortunately, I'll just take this opportunity to tell, there will be a complaint. As a secretary, I used to get a complaint which was about 10 pages. Of the complaint would be 10 pages. But and when I would ask the doctor to give his reply, in a small OP sheet, the reply was be there. It's very unfortunate. It is very unfortunate. Then I used to make the story, entire story. I used to call them up and then write the story. So I think that is not the way, and the case sheet will not have anything. And the sad part is that despite repeatedly telling all this, the number of people coming and attending meetings are very low. And those who attend are usually those who come to IMA and they are aware. But those who are making these mistakes never come to IMA hall or never attend such meetings to listen to what it is. That lies the problem. Unless these doctors come and listen, they will. I had attended, I will not say which specialty. I was called for a meeting or a specialty, and I had studied 100 cases and gone. The entire, that hall was full. I was extremely excited, thrilled. When I unfortunately made the mistake of asking how many of that specialty, you will not believe only 4 people were there. So that is the attitude. So we find it very difficult. It's not that they're not bothered, because once they get into problem, as I said, they come rushing, they call, they keep repeating, Dr. Srimar, that is what they do. But the fact is that we have been telling these things repeatedly in different forums, but they don't come.
Yeah, just like to add to the substance mentioned by Srimar sir regarding documentation. For all those people who are attending the casualty or the wards for any calls, I'm citing a true incident where one of our doctors had a call from the post-operative ward, and the patient, the doctor, the senior surgeon attended the call at 2:10 p.m.
Excuse me. See, we have passed the time. The next speaker is waiting.
Okay. So I just wanted to add, whenever you get a call, go to the ward and write down the time that you saw the patient. And documentation can come later. Because this doctor was taken up to the court of law because he started writing at 3:15 p.m. and the patient died at 4 p.m. He had attended the patient at 2:10 p.m. So the court asked, what did you do? Why did you not attend the case from 2 o'clock to 3 p.m.? He was there, but there was no documentation.
That is why I said timing is very important.
No further questions. So, sir, it's an excellent topic and excellent discussion. Thank you.
I request Jnanada sir to kindly hand over a memento to Dr. Srikumar sir for that most excellent talk of the day. Thank you, sir. And Dr. Shamila, kindly hand over the certificate to Srikumar sir. Delegates, please don't leave the hall. Immediately after the next talk, that is just before we break for lunch, there is a short 15 minutes quiz session And there are fabulous prizes waiting you for the winners. The next session is by Dr. Renoy. Please, Dr. Shamila and Dr. Knyadas, please remain on stage. I request Dr. Ajit Bhaskar sir to kindly hand over. Ajit Bhaskar sir, kindly hand over a token of our love to Dr. Knyadas and Dr. Shamila. And to Dr. Shamila. Thank you, Ajit sir. Thank you so much. For the next session, I call upon Dr. Inoy R. Anand to talk on possibilities of interventional radiology from head to toe. Dr. Inoy is a neuro and vascular interventional radiologist at Maulana Hospital, PERINTHALMANNA. To chair the session, we call Dr. Santosh Kumar, who is a radiologist, and Dr. Alex Baby, who is a neurologist from Maulana Hospital. Dr. Inoy, please. Let the chairpersons take their seat. Yes, Dr. Inoy.
A very good afternoon to all. My name is Dr. Inoy R. Anand. I am consultant neuro and vascular interventional radiologist at Maulana Hospital. And I am extremely sorry to keep you all waiting at this point of time. I know that you're all very hungry and you're all hypoglycemic. So actually this talk is actually nearly for 2 hours, but I have crunched this topic to 30 minutes. So I'll be going really fast, and I take an anticipatory bail, and because my talk will be in hyper speed. And because I have to talk on each and every organ except heart. So I'll be showing you cases mostly which we have done at Maulana since the past 2 years since I joined. Only 1 or 2 cases have been borrowed from the internet. So whenever those cases comes, I'll be mentioning that. So before going, what is an interventional radiologist? An interventional radiologist is a mixture of everything. Like I'm a radiologist, I'm a surgeon, I'm a plumber, I'm a mag giver. So why does we call ourselves as plumber? Because we closes leaking tubes and opens blocked tubes. These tubes can be arteries, it can be veins, it can be biliary tract, and we do often sometimes do targeted therapies for treatment of certain tumors. So how did it start? It started in 1964 when this doctor, he is a radiologist, his name is Charles Dotter. He did the first angioplasty in the world in 1964 at Oregon University. This video of the first angioplasty is still available in YouTube. He has trained many eminent personalities, including Melvin P. Judkins, who is a famous cardiologist, and Andreas Grutzig, who is the first cardiologist to do first coronary angioplasty in the world back in 1970s and 80s. So he was nominated for Nobel Prize in 1973. And coming to cases, we divide ourselves into peripheral body intervention specialists and neuro intervention specialists. But in Maulana, we do both simultaneously. And for the sake of this talk, I have divided into embolization procedures and revascularization procedures. Embolization procedures can be done in the body and also in the neuro territory, and revascularization also is divided into neuro and peripheral or body revascularizations. So before going into the cases, I want you to remember 3 terms. One is, what is an aneurysm? Aneurysm is a true bulge in the blood vessel. It is formed, it has got endothelium, adventitia and intima. So aneurysm has got a true wall. A pseudoaneurysm is an extremely, if you find a report mentioning pseudoaneurysm, it should be treated as early as possible, because any rupture in this pseudoaneurysm wall is actually formed by clot. This clot can get lysed in the next 24 to 48 hours, and patient will have torrential bleed, and most of them will die immediately. So if you find a report, whether it's an ultrasound or CT or an MRI, showing that there is a pseudoaneurysm in any part of the body, it should be treated as early as possible. And what does an embolization means? Embolization means deliberate therapeutic occlusion of a blood vessel. So coming to the cases, so what are the elective embolizations which we do in the body? We commonly do it for uterine fibroids and for benign prostatic hypertrophy, And sometimes we do it for liver tumors, especially the hepatocellular carcinoma. And bronchial artery is another territory which is very underutilized in this part of the country, especially where TB is so common and hemoptysis is very rampant because of the fibrosis. And we all, to our armamentarium, we recently have added bariatric embolization, genicular artery embolizations, and also thyroid embolizations, and also percutaneous direct puncture of the thyroid nodule and ablation of the thyroid nodule. Without surgery, we can treat some of these thyroid nodules. So coming to uterine artery embolization, how do we do a uterine artery embolization? We do it under local anesthesia. We puncture the radial artery or the femoral artery, go into the internal iliac artery, and identify the uterine vessels and inject specific particles called PVA particles. They induce ischemia to the uterine fibroids, and selectively these fibroids will get necrosed, and over due course of time these fibroids will get disappeared. So what are the indications for a uterine fibroid? A uterine fibroid, any fibroids which are less than 15 centimeter can be treated with a uterine fibroid embolization. Multiple fibroids can be treated. It can be done for infertility. Only one thing, one contraindication for uterine fibroid embolization is that it should not be a pedungulated small stalk. That means if the stalk of the peduncle is less than 2 centimeter, then it should not be embolized. What are the advantages of uterine fibroid embolization in comparison to other surgical modalities? It is very easy to do. Actually, one of the easiest procedure an interventional radiologist can do, and short hospital stay. Most of the patients will get discharged in 24 hours, and they can return into normal life soon. So this is a case of uterine fibroid embolization where both uterine arteries are selectively cannulated and embolized with this particle, and this is how that fibroid was pre-procedure. This was a fibroid with hemorrhagic transformation, and after embolization 6 months later when we take an MRI, you can see that fibroid has completely disappeared and only the uterus is remaining. So that is the beauty of this procedure. The normal uterus will be preserved, but the fibroid will get disappeared. So this is a case of a 9 centimeter fibroid. Similarly, you can see the fibroid has completely disappeared. Only the uterus is remaining 6 months after the procedure. Now this is a case of multiple fibroids. You can see the size of the fibroid, which is 7.2 centimeter, has come down to 4.8 centimeter. And you can see the color of the fibroid, which has been gray color, has become black in color. That black in color means that fibroid has completely necrosed. Once it's necrosed, it will disappear over due course of time. So what are the other indications for uterine artery embolization? It can be done for postpartum hemorrhage. In postpartum hemorrhage, it is a life-saving and a uterus-saving procedure. It is done under local anesthesia. It can be done within 15 to 20 minutes, and hence you can avoid a hysterectomy or an internal iliac artery ligation, and thus save the patient's life, and you save the uterus also. Recently, we have been doing it for hydatidiform mold where there is massive bleeding PV. Just before DNC, we will embolize the uterine artery and then give it to the gynecologist. So during DNC, there will be less bleeding. And sometimes we do it for adenomyosis also in patients who does not want surgery and whom those medical management has failed. But the success rate for adenomyosis in uterine artery embolization is nearly 80 to 85%. But whereas for the uterine fibroid, the success rate is nearly 95 to 99%. So this is a case of a 38-year-old female which we have done. She was suffering from adenomyosis with severe dysmenorrhea, and after embolization her symptoms have completely disappeared. She is awaiting her follow-up MRI in the next week. So this is a case of a 23-year-old female who came with massive bleeding PV, and she had an invasive mole. She was already on methotrexate therapy, but still she had massive bleeding PV. She was nearly in a shock, and after embolization she was stabilized and discharged home after a few days. So this is another case of a postpartum hemorrhage with massive bleeding PV in a 23-year-old female with single child, and embolization was done immediately, and patient was revived from shock and discharged after 1 week. She was kept in hospital just because she was COVID positive. That's why she was kept in hospital. Otherwise, she was stable in 24 hours. Similarly, when we enter the prostate artery and inject these particles, what will happen? This prostatic ischemia will cause softening of the prostate, and prostatic urethra will become more wider, and urinary symptoms will improve. So this is a recent treatment which has been introduced for benign prostatic hypertrophy. So this is a case of a 74-year-old male who was catheter dependent for 6 months. He was on Foley's for the past 6 months. We could not remove, a TURP could not be done for him because he was a case of a coronary artery stenting for myocardial infarction. So his antiplatelets could not be stopped. So he underwent a prostatic artery embolization, and within 1 week his Foley's could be removed, and he is very happy. Actually, he has started referring lot of his relatives to me because his result was so good. And recently we have, this is not my case, this was a case from internet, and this is a recent article in Journal of Vascular Intervention Radiology where thyroid embolization can be done for thyroid artery. This is the pre and post 6 months images of the thyroid artery embolization for goiter. And coming to the tumor, as I already told, the most common tumor which we embolize right and left is the hepatocellular carcinoma, and sometimes we do it for symptomatic liver hemangiomas also, and also for hypervascular tumors like paragangliomas, and also colorectal carcinoma metastasis. So for hepatocellular carcinoma, what should be the indication? The indication, the main indication should be limited within the liver. Out of the liver, there is no point in doing this embolization, because even if you take out the primary tumor, the metastasis will grow. So if there is no extrahepatic metastasis, then it is indicated. The size of the tumor should be less than 7 centimeter, but even right now we are doing it for even larger tumors. We will divide the session of embolization into multiple sessions and then take each part of the tumor in separate sessions. So size of the tumor in general we will take less than 7 centimeter, and less than 3 nodules is ideal for an embolization. So what are the treatment modalities which we have for hepatocellular carcinoma? There are multiple treatments. The most common thing is called a TACE or TARE. TACE is nothing but transarterial chemoembolization, where we go into the hepatic artery feeder from the femoral artery or the radial artery under local anesthesia. Then we identify the tumor branch and inject our chemotherapeutic agent in specified dose. So what is the advantage of this is you can percolate the ideal dose which is necessary for tumoricidal effect, and there will be no systemic effects. The drug will get deposited only in the tumor, and it gives more chance for the tumor to die. And there will be no systemic side effects like hair loss or tiredness. Patient can be discharged in 48 hours. And instead of doxorubicin or cisplatin, if you are using a radioactive particle, then it is called a TARE procedure. And smaller lesions, which what we can do is we can directly puncture the tumor under ultrasound guidance and give them microwave energy to burn the tumor right then and there, and tumor will die there itself. So this is the case of a 69-year-old female. You can see this MRI which is showing a single lesion, hepatocellular carcinoma. So we entered that segment 5 branch super selectively and then embolized, and 1 month after you can see the tumor has become black. That means the tumor is necrosed. This patient is cancer free. She is cured for cancer. She will be in follow-up for next 5 years at least yearly, because whenever there is a CLD, she has additional chances of developing newer lesions anywhere else. So whenever these newer lesions appear, we will treat like this. So this is another case of cirrhotic 58-year-old male with a small lesion, subcapsular lesion. This was easily accessible under ultrasound guidance. We directly punctured the tumor and gave microwave energy, and tumor is burned off. This CT was taken immediately after procedure. Within the next 15 minutes, you can see there is complete necrosis of the tumor. And this patient also will be in follow-up with imaging every 6 months to see if there are any new lesions are developing. So he is actually a cirrhotic on 29 for the past 29 years, and this was detected by our own gastroenterologist Rama ma'am, and she has referred me this case, and he is cured for cancer as of now. So what are the emergencies in liver tumor which we can occur? Most of these liver tumors can grow very large, and they are having hypervascularity. They will have sudden rupture and produce massive hemodynamic shock. So this is a case of an 80-year-old male who presented from cortical. He came to us at least 12 hours after bleeding. So he was in severe shock. This was the immediate celiac angiogram. You can see this was the hepatic artery. I'm not sure whether you can see the laser pointer. So this is the celiac artery, this is the hepatic artery, and this is the gastroduodenal artery. In one look, everything looks normal. But actually when you compare with the normal angiogram, you can see the diameter of the vessels. All vessels are small. That means this patient is having severe vasospasm due to shock. And in one look, you cannot see any bleeding point, but comparing to the CT, there was actually a small doubt. So we entered into that artery specifically, and when we did an angiogram, you can see the tumor blush and the bleeding massive bleeding which is happening from the tumor, we embolize that with like the same way. And in addition to TACE, we did something called a glue embolization. Glue is nothing but our normal glue, that pasha. It is a N-butyl cyanoacrylate, and we embolize that artery and close that bleeding branch. Bleeding was stabilized, but sadly, since he was already on mods, he had succumbed after 4 days. Similarly, another 80-year-old patient who came with a similar condition and with a large tumor. So he also had a large tumor. This is actually an entire right lobe of the liver which is filled with tumor. It was a 12 centimeter tumor with multiple points of bleeding. Whatever points I have marked is the point of active bleeding. So we have embolized from the femoral artery, entered into the hepatic artery, and then embolized that branch. He was stabilized. He was discharged from the hospital after 2 weeks, but he will need a definitive therapy for a tumor. He will need a segmentectomy later in life once everything has come down. So these are about malignant tumors of the liver. Coming to benign tumor of the liver, hemangiomas. Not all hemangiomas needs treatment. Only those are which are large and which are symptomatic, like those are which are having contained rupture or active bleeding, or those which are having severe pain. So the indications for hemangioma embolization is if the hemangioma is large, or if there is pain, or if there is any occurrence of bleeding, then only it needs treatment. So this is a case of 2 cases, of both are females. One is having severe pain due to hemangiomas. You can see 3 hemangiomas which are abutting the subcapsular surface. Due to capsular irritation, it was having severe pain. And another patient with severe pain, it was actually due to contained rupture of the hemangioma within itself, and it has not caused any capsular rupture. So luckily she did not have any hemoperitoneum. Both were embolized, and in this case we use a special drug called bleomycin. And this is how the angiogram will look. And 1 year later, you can see the hemangiomas have completely disappeared without any loss of liver parenchyma. Only the hemangiomas have disappeared and liver parenchyma is preserved. Both these procedures are done under local anesthesia. There is no need for an open surgery. And even 10 centimeter hemangiomas or even 15 centimeter hemangiomas can be easily embolized. They will regress in time in due course. So coming to a newer treatment of bariatric embolization. Bariatric, you will be very well knowing about bariatric surgery. So bariatric embolization is another treatment which have been added into our spectrum of therapeutics. And what we actually do is we embolize the left gastric artery and gastroepiploic artery. We target the ghrelin production cells. So once the ghrelin production comes down, your insulin resistance will come down, your fasting glucose will come down, your obesity will come down. So our target is left gastric artery. We will enter the left gastric artery from the radial artery or from the femoral artery under local anesthesia. There is no need for general anesthesia in this case. So this is a case of bariatric embolization. This is not my case, taken from the internet. And results are like ghrelin production will decrease by next 6 months, and there will be an insulin resistance decrease of around 48.8% in the next 6 months, weight loss of 6 to 22% by around 6 months. So post procedure they will need an endoscopy at 1 week and 1 month, because some of them tend to develop ulcers. These ulcers tend to heal within the 1 month, and usually there will be no severe issues because stomach is an extremely difficult organ to create an ischemia. So what are the pros of bariatric embolization? Short hospital stay, less cost, less risky, it is minimally invasive. It can be done under local anesthesia. But what are the cons? Currently there are no randomized controlled trials for bariatric embolization. All are prospective trials. A randomized controlled trial is currently going on in Europe and North America. It will be released in the next 3 to 4 years. So adding to other treatments of embolization, enthesopathies like severe osteoarthritis and mild to moderate osteoarthritis can also be treated with embolization. Pain reduction will occur when we embolize these hypervascular beds. When we go into the genicular artery and embolize, what will happen is they will actually attack the neovascularity of the inflamed tissue. So once the neovascularity has come down, the inflammatory cytokines release will come down, and then inflammation will come down, and there will be pain reduction. This can also be done for plantar fasciitis and also for periarthritis shoulder. Coming to other emergency embolization, it is almost always done for GI bleed. So this is a case of a traumatic pseudoaneurysm of the liver. You can see large subcapsular hematoma. This is a case of a trauma in a young 38-year-old male. So when we entered the hepatic artery and put coils and blocked that bleeder, patient was stabilized. He was in severe profound shock. So this is a case, he is actually, this is another renal embolization. He is actually our own staff. I have seen him yesterday also. This case was done in January of 2021. This was a massive bleed. He was actually a case of aortic valve replacement. He was on warfarin. He needed PCNL because he had a large symptomatic calculus, and after PCNL he had severe retroperitoneal hematoma. The retroperitoneal hematoma was around 21 centimeter size. He was in severe hemodynamic compromise, and we entered the renal artery and identified that bleeder and put coils there. So this is his 6 months follow-up. There is absolutely no loss of renal parenchyma. He is stable. His life is saved. His kidney is saved. And this was a case of congenital intrarenal arteriovenous fistula, which we have done last week. This is a 25-year-old male with a large arteriovenous fistula in the right kidney with macroscopic hematuria. So this is actually a large fistula from the inferior polar branch. You can see the blue thing which I have marked is a large venous pouch which has with very high flow, and you can see the renal vein and inferior vena cava in the same arterial phase. So what we did is we put devices like this called a vascular plug and embolized it. And coming to GI bleeds, GI bleeds are extremely common, especially in ICU settings. But what if we cannot find the source of the bleed, especially if the scopies are negative, if the colonoscopy is negative, the upper GI scopy is negative, CECT is negative, and if the DSA angiogram is negative, what will we do? So what will we do is something called a provocative mesenteric angiogram. We enter the mesenteric artery and then give either heparin or thrombolytic agent directly into the mesenteric artery and provocate that bleeding. So that bleeding point will be revealed after giving this thrombolytic agent or heparin. So this is such a case which we have done last December. Actually, that bleeding point is covered by my thumbnail. Yeah. So that was a jejunal branch bleeder which was not initially seen in any of the scopies or the CECT or the routine DSA angiogram. So this is a provocative mesenteric angiogram. Then we entered that and put coils there and blocked, and patient's melena has stopped. So bleeding in chronic liver disease is an extremely common condition which we get routine calls. So this is a case of hemorrhoidal vein embolization, and this is a patient with chronic liver disease with portal hypertension. It is a 50-year-old male. He came with massive bleeding PR. So he had a rupture of the hemorrhoidal veins due to portal hypertension. So so how do we enter the portal vein? So we enter the portal vein by directly puncturing the liver. From there we enter the portal vein. From there we enter the inferior mesenteric vein and then going into the hemorrhoidal vein and put coils and glue there and then stop the bleeding. So sometimes we do get isolated gastric varices with bleeding. Gastric varices is little difficult to control in endoscopic methods. So we do have a procedure called a BRTO. It's little complex, so I'm not going into details of that. So this is a case of a gastric varices with gastrorenal shunt. So we entered from the femoral vein and from the renal vein, entered the renal vein, and there we entered into a gastrorenal shunt. And then we embolized. You can see the pre and post procedure. You can see the complete thrombosis of time is a limiting factor. Do you want me to stop, or I think I'll take another 15 more minutes? No, 10 minutes? Yeah, 2 minutes, fine. I'll not anyway complete, but I'll just go on. So this is a case of a BRTO. So this another case of a gastric varices which we did some similar procedure called CRTO. You can see the pre and post procedure where the varices is completely thrombosed. And this is another patient, 60-year-old female, currently in follow-up with Dr. Emma ma'am. She came in severe hemodynamic shock. She had large varices which has ruptured into the stomach and into the esophagus. So we did a procedure called TIPS, transjugular intrahepatic portosystemic shunt, where we connect the hepatic vein and portal vein directly, and decompression of the portal system has happened and patient's life is saved. So bronchial artery embolization, as I already told, is a relatively underutilized procedure. It is done for massive hemoptysis, very easy to do, but it should be very careful. You should send it to a trained person only, because bronchial arteries can give rise to this recurrent artery of Adam Kevick's or your radical spinal arteries. So if you embolize, if the doctor does not know about this, he can embolize that artery and patient will go into paraparesis. So this is a case of a massive hemoptysis. Bronchial arteries were embolized and also internal mammary arteries were embolized. So this is a case of a juvenile nasopharyngeal angiofibroma. This was case referred to me by Sidi sir, and this was a young 13-year-old male who needed surgery. So before surgery, we embolized the internal maxillary artery and the ascending pharyngeal artery selectively and then stopped the bleeding, and patient was sent for surgery. So during surgery, it was seen to have less bleeding. So coming to aorta, I think I will stop. I will not go into neurovascular territory. I just want you to remember three numbers. What is 5.5? One is 5.5 centimeter. So the normal diameter of aorta, abdominal aorta, is 2.5 centimeter. So if the diameter of the abdominal aorta is, or aortic aneurysm, is more than 5.5 centimeter, it is an indication for treatment even if the patient is asymptomatic. So more than 5.5 centimeter, the treatment is, it should be given. And if the treatment, if the patient is having a 3.5 centimeter aorta, say it's more than 2.5 but not up to 5.5, what you should do is you should follow up the patient in 6 months, and if there is a growth of the aortic diameter by at least 0.5 mm in 6 months, then also it should be treated. So any aortic aneurysm more than 5 centimeter, and if there is a growth of aneurysm of 0.5 mm in 6 months, it should be treated. So I think I will stop because anyway I will not be able to complete.
Anyway, ഒരു ഓവറോൾ ഐഡിയ ഇൻ്റർവെൻഷൻ റേഡിയോളജിയെ പറ്റി പറഞ്ഞതിൽ വെരി താങ്ക്ഫുൾ. ദ ഹിസ്റ്ററി ഓഫ് ഇൻ്റർവെൻഷൻ റേഡിയോളജി ഇൻ പെരിന്തൽമണ്ണ ഒരു 2002 മുതൽ വരുന്നൊരു കാര്യമാണ്. ഞാൻ റീനോടത്തൊക്കെ പറഞ്ഞിട്ടുണ്ട്. അന്ന് ഞാനൊക്കെ ചെറുപ്പമായിട്ടിരിക്കുന്ന കാലത്ത് എനിക്കിവിടെ ഈ പെരിന്തൽമണ്ണ ഇൻ്റർവെൻഷൻ റേഡിയോളജി വേണമെന്നുള്ള വലിയ ആഗ്രഹം ഉണ്ടായിരുന്നു. അന്ന് എന്തെങ്കിലും ആവശ്യം വരികയാണെങ്കിൽ നമ്മൾ ഒന്നിൽ കോയമ്പത്തൂർ പോകണം, ചെന്നൈ പോകണം, ബാംഗ്ലൂർ പോകണം. പിന്നെ മിംസിൽ രാമകൃഷ്ണൻ ചെയ്ത് തുടങ്ങിയിട്ടുണ്ട്. ഹീസ് ഡൂയിങ് നൈസ് വർക്ക്. ആ ഒരു കാലഘട്ടത്തിൽ നമ്മൾ ഇതിൻ്റെ ട്രെയിനിങ്ങിന് അപ്രോച്ച് ചെയ്ത ഈ ലെജൻസിൻ്റെ ഒക്കെ ഒരു സ്വഭാവമുണ്ട്. അത് പഠിപ്പിച്ച് കഴിഞ്ഞാൽ അവർക്ക് അത് ചെയ്യാൻ പറ്റുകയുള്ളൂ, നമ്മളെക്കൊണ്ട് പറ്റൂല എന്നൊരു രീതിയിലാക്കി കളയും. മാത്രമല്ല പഠിപ്പിച്ചു തരാൻ വലിയ ബുദ്ധിമുട്ടുള്ള ആൾക്കാരും ഉണ്ടായിരുന്നു. മാത്യു ചെറിയാൻ മുതലുള്ളവരും ശ്രീനിവാസ് ദേശായി, ഉദയലിയുമായി, ഇവരെ ബോംബെ വരെയൊക്കെ നമ്മൾ പോയിരുന്നു. പിന്നെ അത് ഞാനന്നങ്ങ് വിട്ടു. പിന്നെ എൻ്റെ ഫ്രണ്ട് ഉണ്ടായിരുന്നു KEM ഹോസ്പിറ്റൽ ബോംബെ, റൂബി ഹാൾ ഹോസ്പിറ്റലിൽ വരയ്ക്കുന്നത്. പുള്ളിയുടെ അടുത്ത് സംസാരിച്ചിട്ടാണ് ഓൺ ദ വേ ഫ്രം പൂന പുള്ളി കാലിക്കട്ടിൽ വന്നിട്ട് കാലിക്കറ്റ് ടവറിൽ ഇരുന്നിട്ട് അവിടുന്ന് BVML ഹോസ്പിറ്റലിൽ നിന്ന് തലേ ദിവസം പോയിട്ടൊരു 3-4 കേസ് ചെയ്ത് മോർണിംഗിൽ അലശിവ വന്നിട്ട് പിന്നെ അവിടെ നമ്മൾ കേസ് ചെയ്യായിരുന്നു. 2002 മുതൽ ഇപ്പോൾ ചെയ്തുകൊണ്ടിരിക്കുന്ന ഈ മാതിരി ഉള്ള എല്ലാ പ്രൊസീജിയേഴ്സും അന്ന് മുതൽ അവൈലബിൾ ആയിരുന്നു. ഒരുപക്ഷെ അന്ന് അപ്ഡേഷൻ ക്ലിനിക്കൽ സൈഡിൽ നിന്ന് റെഫറൻസ് വരാനുള്ളൊരു ബുദ്ധിമുട്ടുണ്ടായിരുന്നിരിക്കാം. കാരണം യൂട്രൈൻ ഫൈബർ എംപ്ലൈസേഷൻ നമ്മളത് 50-52 കേസ് ചെയ്തിരുന്നു, നല്ല റിസൾട്ടുകൾ ഉണ്ടായിരുന്നു. അല്ലെങ്കിൽ ഈ പറയുന്ന ഇന്നത്തെ ലേസർ അബ്ലേഷൻ, വേരിക്കോസ് വെയിൻ എന്ന് പറയുന്ന സാധനം റേഡിയോ ഫ്രീക്വൻസി അബ്ലേഷൻ വെച്ചിട്ട് അന്ന് ചെയ്യാനുണ്ടായിരുന്നു. പക്ഷേ അന്ന് പലപ്പോഴും OP ബേസിൽ ചെയ്യാൻ കേസുകൾ തരാൻ ബുദ്ധിമുട്ടുള്ള ചില വേറെ ഇഷ്യൂസൊക്കെ ഉണ്ടായിരുന്നു. പക്ഷേ അത് അപ്ഡേറ്റഡ് വെർഷനിൽ വന്ന് നല്ലപോലെ ആകുന്നത് എ കപ്പിൾ ഓഫ് ഇൻ്റർവെൻഷൻ റേഡിയോളജി പെരിന്തൽമണ്ണയിൽ വന്നു കഴിഞ്ഞപ്പോൾ ഐ ആം വെരി ഹാപ്പി. കാരണം ഇന്നിപ്പോൾ ഹോസ്പിറ്റൽ സർജന്മാർക്കോ ആർക്കോ വേണേ ആയിക്കൊള്ളട്ടെ ഒരു ഇഷ്യൂസ് വന്നു കഴിഞ്ഞാൽ ഹെൽപ്പ് ചെയ്യേണ്ട രീതിയിലേക്ക് നമുക്ക് ഈ യങ്സ്റ്റേഴ്സ് അവിടെ ഉണ്ട്. ഇപ്പോൾ ഉദാഹരണത്തിന് പ്രോസ്റ്റേറ്റിക് ബയോപ്സി ഞാൻ ചെയ്ത് കഴിഞ്ഞതിന് ശേഷം ബ്ലീഡിങ് ഇൻട്രാക്റ്റബിൾ ആണെങ്കിൽ എനിക്ക് ധൈര്യമായിട്ട് ചെയ്യാം. കാരണം എന്ന് വെച്ച് കഴിഞ്ഞാൽ ഹെൽപ്പ് ചെയ്യാൻ ഒരാളുണ്ട്. ഹിസ്റ്റക്ടമി കഴിഞ്ഞിട്ടൊരു ഇഷ്യൂസ് വരുന്നു, ബ്ലീഡിങ് വരുന്നു, ഈസ് ദെയർ. അല്ലെങ്കിൽ ഹെപ്പാറ്റിക് ഇഞ്ചുറി വന്നൊരു പേഷ്യൻസ് സർജിക്കലി ആനബിൾ അല്ലാത്തൊരു കേസ് വരുമ്പോഴത്തേക്ക് ഇൻ്റർവെൻഷൻ റേഡിയോളജി ഈസ് ദെയർ. സോ ഇവർ ചെയ്യുന്ന വർക്കുകൾ തീർച്ചയായിട്ടും ഈ ഒരു ഓവറാൾ ഇത് തന്നതിലും ധൈര്യമായിട്ട് ഓരോ കാര്യങ്ങൾ ചെയ്യാൻ നിങ്ങളുടെ കൂടെ ഒരാൾ ഉണ്ടാകുന്നുള്ള ആ ഒരു അഡ്വാൻറ്റേജ് പെരിന്തൽമണ്ണയ്ക്ക് ഇപ്പോൾ ഉണ്ട്. താങ്ക് യു വെരി മച്ച്.
താങ്ക് യു സർ.
Thank you, Rinoy, for giving such a fascinating talk. Congratulations.
Any doubts?
Yes. If there are no doubts or any questions, there is one question will be allowed. After that, we have to break for lunch because we are.
Prostate embolization, prostate artery embolization. Thing is, one question is, who is an ideal candidate with respect to the prostate size and postward residual urine?
So So if the greater the prostate size, then he is a better one. So normal prostate size, we take up to 30 cc. So if the prostate size is more than 50 cc, then it's very easy. If it's more than 100 cc, then it's more easier. Then the results will be better. So greater the prostate size, better the results.
Okay, thank you. Second question is, you mentioned one case where the patient was asymptomatic after 1 week. He had relief post prostate artery embolization.
Yes,
so usually, on an average, from your experience, how much does it take for a patient who has too much of bladder outlet obstruction? That is, he has too much of post-forward residual urine, and after the procedure, how much time does it take for his relief?
So the improvement actually happens from 48 hours onwards, and it will go up to 3 months. So why usually it will take 1 week for almost everyone, because when we embolize, the prostate will have initial ischemia and edema. So ischemic edema will actually cause a little narrowing than the previous. So after 1 week, this edema will subside, and then the prostate will come into a decreased size. Prostate will become softened, and then they will have improvements. So most of my cases, they will have improvement after 1 week.
Thank you.
Thank you.
We'll
Thank you
wind
so
up the
much.
session. Further questions can be cleared with Dr. Inoy over lunch. I request Dr. Santosh Kumar sir to kindly hand over a memento to Dr. Inoy. Ladies and gentlemen, immediately after lunch at 12, you have to assemble back in the hall at 2:15 sharp, and 2:20 we'll be starting the quiz session, which is online. It is fixed online and it cannot be delayed anymore. 2:20 we'll be starting the quiz session. There are fabulous prizes waiting for you. I request Dr. Alex to hand over the certificate. Thank you, Dr. Alex. I request Dr. Muhammad Ali sir from Valarancheri branch to hand over a memento to our chairpersons. To Dr. Santosh Kumar sir. And to Dr. Alex Baby. Dr. Alex Baby is a neurologist from Maulana Hospital. Thank you, Muhammad Ali sir. We'll break for lunch, and we'll immediately after lunch at 2:15 we have to assemble back in the hall. 2:20 the quiz session will be starting sharp. Thank you. Quick lunch.
leading to inhibition and loss of function, which leads to more injury, resulting in further inflammation and pain, thus becoming a never-ending loop. According to reports currently available, pharmacological options are effective in less than 50% of cases and provide relief partially. They treat the symptom alone with substantial side effects. The need of the hour is to modify the disease rather than the symptom alone. Introducing breakthrough therapeutic combination for the management of chronic pain. PENOC XL with palmitoyl ethanol amide 400 mg and astaxanthin 1 mg. PENOC XL modifies the disease rather than the symptom alone. Palmitoyl ethanol amide acts as an autocoid local inflammation antagonist ALIA. It is an endogenous fatty acid amide produced by the cells to relieve inflammation, protect nerves, and to promote cell recovery. Palmitoyl ethanol amide has multiple mode of action to control pain and inflammation. Anti-inflammatory action of palmitoyl ethanol amide is through activation of PPAR-alpha receptor. Palmitoyl ethanol amide attaches to the host defense cell and activates PPAR-alpha receptors, thereby removing heat shock protein. Then it combines with RXR and PGC1 receptors and resets the overactive genes that are responsible for inflammation, thereby controls the inflammatory cascade. Palmitoyl ethanolamide inhibits mast cell degranulation by activating cannabinoid 2 receptors, thereby providing analgesic and anti-inflammatory therapeutic strategy specifically targeted to mast cells. Astaxanthins hydroxyl OH and ketone RCOR oxygen-containing groups are responsible for its high antioxidant activity and ability to span and stabilize cell membranes. Unique molecular structure enables astaxanthin to act as lipid-soluble and water-soluble antioxidants. Astaxanthin's multiple conjugated double bonds allows it to act as a strong antioxidant by electron donation and by reacting with free radicals. Astaxanthin's ROS scavenging capacity has been shown to be 6,000 times more than vitamin C, 800 times more than coenzyme Q10, 550 times more than vitamin E, 200 times more than polyphenols, 150 times more than anthocyanins, and 75 times more than alpha-lipoic acid, according to ORAC value, which stands for oxygen radical absorbance capacity. Why is palmitoyl ethanol amide supplementation required for chronic pain? During chronic pain, palmitoyl ethanol amide is disintegrated to palmitic acid and ethanolamide by enzymes, fatty acid amide hydrolase and N-acyl ethanol amine acid amide hydrolase very fast, which results in insufficient levels of PEA in the body, leading to the need of external supplement. Age-related oxidative stress also plays an important role in chronic pain. Astaxanthin, the king of antioxidant, provides superior antioxidant property and also enhances the absorption of palmitoyl ethanol amide. During chronic pain, PENOC XL provides the following benefits: treats the root cause of the pain, controls mast cell degranulation, corrects the pain gene expression, protects the nerve from damages, protects from age-related oxidative stress, safest alternative to manage chronic pain, even in patients with comorbidity, and polypharmacy. In chronic pain conditions like osteoarthritis, rheumatoid arthritis, carpal tunnel syndrome, sciatica, diabetic neuropathic pain, trigeminal neuralgia, migraine, the recommended dose of PENOC XL is 1 tablet twice daily. PENOC XL, the breakthrough therapeutic combination to manage chronic pain.
Delegates are requested to come into the hall. The quiz session is starting. Please come into the hall. We are starting with the quiz session. Dr. Emma Krishnakumar, kindly take over.
ഓഡിയോ വിഷ്വൽ അനൗൺസ് ചെയ്യുന്നത് പുറത്ത് കേൾക്കില്ലേ? എല്ലായിടത്തും കേൾക്കുമല്ലോ. All the delegates are requested to please assemble inside the conference hall. A very interesting quiz program is starting. All please come inside.
There are fabulous prizes awaiting the winners.
This quiz session, good afternoon ladies and gentlemen. This quiz session is basically a collection of questions that have been set by our faculty themselves, most of them. So it will also in a way check the attentiveness of the sessions, your attentiveness of the sessions. Thank you very much Dr. Ashish Nair. He was the person behind it who collated everything and liaised with the online platform. And this session is being sponsored by Icon Pharma. We'll have a set of 26 questions. The display will come on to the display will come on, and then I'll just read out. It's obviously visible on the stage. You will have to mark your answers. There's something called Kahoot. Other than the display, yeah. In the Google search bar, please type www.kahoot, and then you do not need to download an app or anything. Just go to the Google search bar and type www.kahoot, and then there will be a quiz pin, and the game pin is that 623609. So please enter that quiz pin, and please write your nickname using 15 characters. And then after submitting your this is the game pin 91747 91747. Now after submitting that, the questions will start appearing one by one. Another 3 talks lined up. So marks will be allotted to each right answer on the basis of fastest fingers. We aren't doing anything. It's all being uploaded. Your responses will be uploaded, and it will be done. There will be no negative marking, so attempt all questions. Marks will be allotted to each right answer on the basis. I do not have control over this. Actually, they are the ones who are putting it. ഒരു പിന്നുണ്ട്. ആ പിന്ന് ആശിഷ് we'll need 91747. 91747. ഈ kahoot.in പോവാ. www.kahoot.in. Kahoot.it. KAHOOT.IT. Ada. Net. I think we all need to depend on our own data. Otherwise, there's no other go. Kahoot.it പോയിട്ട് 91747 എന്ന കോഡ് ടൈപ്പ് ചെയ്യുക. ആ ടൈപ്പ് ചെയ്ത് കഴിഞ്ഞാൽ ക്വസ്റ്റ്യൻസ് ഓരോന്നായി വന്നു തുടങ്ങും. I'm actually as ignorant as you, because we just collated the questions and gave them, and they are they are the ones who are managing the show online. വരട്ടെ. ഇല്ല, 20 സെക്കൻഡ് ഉണ്ട്. ഗൂഗിൾ ചെയ്യാൻ തുടങ്ങുമ്പോഴത്തേക്കും ക്വസ്റ്റ്യൻ പോവും. നെഗറ്റീവ് മാർക്കിംഗ് ഇല്ല. എന്തെങ്കിലും ABCD അടിച്ച് അടുത്തേക്ക് കിടക്കുക. അല്ല okay, shall we start? Yeah. Requesting the platform to please give us the first question. Yeah. First question, please, ma'am. Can we start? It's an initial teething trouble. So Kahoot and yeah. I hope all of you are prepared with your codes. First question, please. Yeah. Which of the statements given below is false? Abdominal aortic aneurysm above the diameter of 5.5 centimeter requires treatment. Only ruptured aortic aneurysms and with signs of impending rupture require treatment. Infrarenal aorta is the most common site of aortic aneurysms. Open surgery is the best for type A aortic dissection. So which of the given statements below is false? We just have 4 more seconds. False ana, false ana. 37 answer I. Good going. Please, fast. We are done. Okay. As our chairman is in a superlative mood. Okay. The fastest answer is the പേരൊക്കെ വന്നു. നമ്മുടെ സെക്രട്ടറി ഡോക്ടർ ഭവിത വിജയൻ WDW സെക്രട്ടറി ആണ്. ഇല്ല കൊടുത്തിട്ടില്ല. നോ ഇല്ല എന്നാണ് വിശ്വാസം. Okay, shall we have the answer? We go with the answer, le? Yeah. Shall we have the answer, please? Yeah, okay, that's done. Next question, please. Next, please. Yeah. Which of the statements regarding stroke is false? Mechanical thrombectomy should usually be done within 6 hours. No significant difference seen in patients at 3 months irrespective of thrombectomy status. Thrombolysis should be given in less than 4.5 hours. All of the above is true. ടൈം എല്ലാവർക്കും വായിക്കാമല്ലോ, ഞാൻ വെറുതെ പറയുന്നേ. ശരി, ആയിക്കോട്ടെ, വായിക്കണ്ടല്ലോ. അപ്പം പിന്നെ ഞാൻ ഇറങ്ങാം, എല്ലാവരും കണ്ട് എഴുതിക്കോളൂ. ശരി. No significant difference seen in patient at 3 months irrespective of thrombectomy status. Now next question please. Third question please. Oh, VV Devan doctor. He is the fastest. Scoreboard 1521. Yeah. Okay. Now window period for IV thrombolysis for acute ischemic stroke is 3 hours, 4.5 hours, 6 hours, 24 hours. Window period of IV thrombolysis 3 hours, 4.5 hours, 6 hours, 24 hours. We have 9 more seconds to go. I've been fast enough. Please record your answers. 42 answers. We are definitely improving. 4.5 hours is the right answer. Can we have the next question, please? Good. The fourth question, window period for mechanical thrombectomy for acute ischemic stroke is 6 to 8 hours, 18 hours, 4 hours and 24 hours. 6 to 8 hours, 18 hours, 4 hours, 24 hours. 32 answers. Please make it fast. Yeah, the answer is 6 to 8 hours. 20 have got it right. We've been having a few people who are listening. Hashim has a streak with 4 correct answers in a row. Hashim, I'm personally very proud of Hashim because he used to be with me in gastroenterology department a long while back. Okay. അത് പറയില്ല. Next question, please. The fifth question, perfusion scan allows to do mechanical thrombectomy up to 24 hours, 48 hours, 36 hours, 72 hours. Perfusion scan allows to do mechanical thrombectomy up to 24, 36, 48, 72 hours. the questions are a little skewed because a few of the faculty have very diligently given us the questions. So there might be a predominance of a certain topic that we can't help. Answer 24 hours. 13 have got it right. Next question, please. Okay. Sixth question. Uterine artery embolization can be done for which of the following? That was the last session here, pre-lunch session, which was sparsely attended but nevertheless an excellent one. Fibroid, adenomyosis, AV fistulas, all of the above. Adenomyosis and invasive moles. 34 answers, good. It's one of the better answered questions. 42 answers. Okay, all of the above. Next, please. Okay, seventh question. Most common site of aortic injury in a blunt trauma. Ascending aorta, descending aorta, aortic arch, aortic isthmus. The most common site of aortic injury in a blunt trauma. Faster, 30 almost. We've been consistently having something in the range of 40 to 42 answers. Maybe we should. Isthmus is the right answer. Next question, please. The eighth question regarding pseudoaneurysms. Which of the following is false? All pseudoaneurysms need treatment as early as possible. They do not have a true wall. They can only be found in the abdomen. None of the above. 30, 32. We should break that 40 barrier and go and have more responses. 16. They can only be found in the abdomen is the right answer. Next. Interpret the following thyroid function test. The values, do you need me to read out? Okay. Primary hyperthyroidism, hypothyroidism, subclinical hyperthyroidism, subclinical hypothyroidism. Primary hyperthyroidism is the answer. Next. Next, please. We're slowly nearing 10 questions. Patient presents with tachycardia and heat intolerance. Suspected Graves. What is not a feature of Graves? Increased total and free T4, exophthalmos, suppressed plasma TSH, decreased thyroid radioactive iodine uptake. Answers: decreased radioactive, thyroid radioactive iodine uptake. That fairly well answered. 31 have got it right. Next, please. We have a set of 4 people always on the top. Anyways. Next, advantages of robotic surgical system over lap surgery include all except greater tactile feedback, less blood loss and less post-op pain, greater degrees of freedom, camera control by the surgeon. This time, okay, greater tactile feedback is the answer. 16 have got it right. Next, please. Which amongst the following is not part of the Versius robotic system? Surgeon console, automatic camera, robotic arm and 3D monitor. This was discussed in detail in the talk. Yeah, time is up. Automatic camera is the answer. 17 have got it right. Next, please. We've Deepthi in the lead now. Next, robotic surgery can be used to perform all the following except radical prostatectomy, anterior resection, esophageal varices, excision, hysterectomy. Fairly easy question. Okay. Esophageal varices excision is the answer. Next question. Good. Robert Barany explored the functions of the dash, which led to multiple discoveries, including caloric reaction. Vestibular apparatus, thyroid gland, inner ear, tongue, and gustation. Vestibular apparatus is the answer. Next, please. Famous image known as photograph 51 led to a path-breaking discovery called a secret of life. The person involved is James Watson and Francis Crick, Hargovic Corana, Linus Pauling, Rosalind Franklin. I see Ashish's hand in this question. This is not part of our syllabus. Out of syllabus, that's a discretion. ഇല്ല അത് ക്വിസ് മാസ്റ്ററുടെ ഡിസ്ക്രിപ്ഷനാണ്. അപ്പോൾ ആശിഷ് എന്നൊക്കെ ടൈ ആയിപ്പോയ ഔട്ട് ഓഫ് സിലബസ് നിന്ന് വല്ലതും വന്നിട്ട് വേണം അത് റെഡിയാക്കാൻ. നെക്സ്റ്റ് പ്ലീസ്. Deepthi still maintaining the lead. The main hormone secreted by thyroid gland. The next question. T4, T3, T4 and T3, TSH. ഇത് ആൾക്കാർ അടിച്ച് തകർത്ത് ആൻസർ ചെയ്യുന്നുണ്ട്. 37, 38. Okay. T4. 16 answers. But if you have also answered the third option, 14. Okay. Next. Interpret the following thyroid function test. Our endocrinologists are having a role. Various TFTs appearing. Central hypothyroidism is the answer. We have a new leader now. Interpret another thyroid function test. അല്ല, ഓരോരുത്തർക്ക് 5 ക്വസ്റ്റ്യനൊക്കെ അലോട്ട് ചെയ്ത് കൊടുത്തിരുന്നു. അതിൽ ചിലവരൊന്നും ആൻസർ ക്വസ്റ്റ്യൻസേ തന്നിട്ടില്ല. തന്നവരൊക്കെ ഇതിലിട്ടിട്ടുണ്ട്. അത് എൻട്രൻസിൽ നമ്മൾ കുത്തുന്ന പോലെ ആയിപ്പോയി. TSH ഓമ. നെക്സ്റ്റ്. നെക്സ്റ്റ് 19th question. Transvaginal sonography ഒന്ന് മാറ്റി പിടിച്ചിട്ടുണ്ട്. Documents pregnancy by which day after missing periods? 32 to 35 days, 45 to 50 days, 40 to 45, more than 50. എല്ലാവരും സാവകാശം ഉത്തരം നൽകുക. കമൻസ് ചെയ്യാതിരിക്കുക. ഓക്കെ. നെക്സ്റ്റ്. We're almost. First structure to be seen in the gestational sac in USG. Oh, ഇത് സന്തോഷ് സർ പറഞ്ഞതാ. Fetal pole, cardiac activity, yolk sac, chorion. ഇന്ന് സന്തോഷ് സർ പറഞ്ഞു. 36 answers. അല്ല, ഇത് സിലബസ് ആണ്. യോഗ് സാക്ക്. കുറേ അധികം പേര് ആൻസർ ചെയ്തിട്ടുണ്ട്. 19 പേര്. ഓക്കെ. നെക്സ്റ്റ്. ദീപ്തി പിന്നെ മുന്നിൽ കയറി. നെക്സ്റ്റ്. We are slowly nearing an end. All are true except CRL in millimeter is equal to gestational age in days. MSD in millimeter plus 30 is equal to gestational age in days. EDD is calculated by Nigel formula. Amniotic fluid is produced by fetal urine. Fairly easy. Good. അപ്പോൾ അതൊന്നും ആരും ശ്രദ്ധിച്ച് കേട്ടിട്ടില്ല. CRL in millimeters equal to gestational age in days. Next. Which among the following implantable hearing aid is used in the treatment of bilateral microtia? ഇത് ഷർഫുദ്ദീൻ സർ വളരെ ഡീറ്റെയിൽ ആയി സംസാരിച്ച് പിക്ചേഴ്സ് ഒക്കെ കാണിച്ചതാണ്. മിഡിൽ ഇയർ ഇംപ്ലാന്റ്, കോക്ലിയർ ഇംപ്ലാന്റ്, ബോൺ ആങ്കറിംഗ് ഹിയറിംഗ് എയ്ഡ്, ഓഡിറ്ററി ബ്രെയിൻ സ്റ്റെം ഇംപ്ലാന്റ്. അതിൻ്റെ പിക്ചേഴ്സും വീഡിയോ ഒക്കെ കാണിച്ചിരുന്നു. ബോൺ ആങ്കറിംഗ് ഹിയറിംഗ് എയ്ഡ്. നെക്സ്റ്റ്. Which is the most common cause of vertigo which we encounter in our day-to-day OPD? This is the easiest question. Meniere's disease, BPPV, vestibular neuronitis, labyrinthitis. ഇതിലായിരിക്കും ഏറ്റവും അധികം ആൾക്കാർ ആൻസർ ചെയ്യായിരിക്കും അല്ലേ? ENT കൂട്ടങ്ങൾ ശരിയായി പറയണത് ശരിയല്ല, ബാക്കിയുള്ളവർ പറയണം. നെക്സ്റ്റ്. ഐഡന്റിഫൈ ദ ബിലോ ഗിവൺ ന്യൂവസ്റ്റ് ഇമേജിംഗ് മൊഡാലിറ്റി. ഇതും സാർ പിക്ചർ കാണിച്ചിരുന്നു. OPG, മൊബൈൽ MRI, കോൺ ബീം CT, ഇമേജ് ഗൈഡഡ് നാവിഗേഷൻ സിസ്റ്റം. Cone beam CT is the answer. I'm really feeling so happy that everybody is so enjoying this quiz so much. That is actually the basic aim of the quiz. These two famous researchers were awarded Nobel Prize for their contributions in the development of. ഇത് നമ്മുടെ ആശിഷിൻ്റെ കോൺട്രിബ്യൂഷനാണ്. കാസ്പർ ജീൻ, ക്രിസ്പർ, റിവേഴ്സ് ട്രാൻസ്ക്രിപ്റ്റേസ്, PCR. ഇതിൽ കുറച്ച് കുറഞ്ഞു റെസ്പോൺസ്. ക്രിസ്പർ ഇസ് ദ ആൻസർ. It is getting closely fought. We just have 3 more questions and we have 2 people മാറി മാറി ലീഡ് എടുത്തുകൊണ്ടിരിക്കുന്നുണ്ട്. Which are the properties of insulin digludec? അതിനി വരാൻ പോകുന്നതാണ്, എന്നാലും അറ്റംപ്റ്റ് ചെയ്യൂ. ലോവർ ഗ്ലൈസീമിക് വേരിയബിലിറ്റി, ഫ്ലെക്സിബിൾ ഡോസ് ടൈമിംഗ്, ലോവർ റിസ്ക് ഓഫ് ഹൈപ്പോഗ്ലൈസീമിയ, all of the above. ഇത് ആൻസർ ചെയ്യാൻ പറ്റിയില്ലെങ്കിൽ അടുത്ത സെഷൻ ഒന്നും കൂടി നന്നായിരുന്നു കേൾക്കുക. വിഷ്ണു വാസുദേവൻ്റെ all of the above is the answer. Last question ആയോ? ഇല്ല, 2 എണ്ണം കൂടി ഉണ്ട്. What is the recommended daily starting dose of insulin digludec in insulin naive patients? 5 units, 10 units, 15 units, 20 units. ഇല്ല, ഒന്നുകൂടി ഉണ്ട്. Ten units. Good. Next. We are going to the last question. What is the recommended method for the titration of insulin digludec? Once weekly, based on the mean of 2 SMBG tests. Twice weekly, based on the mean of 2 SMBGs. Daily, based on SMBG, and SMBG is not required to titrate. Yes. We are closing now. Once weekly based on mean of 2 SMBG tests. Dr. Salam. Dr. Deepthi. And first, VV Devan Dr. Vishnu Vasan. Good. Hearty congratulations to all participants and the winners.
We request Dr. Sri Kumar Vasudevan sir to kindly come over the days to distribute the prizes. The first prize goes to Dr. Vishnu. Congrats, Vishnu. Second prize to Dr. Deepthi Mohandas. Congrats, Dr. Deepthi. And third prize goes to Dr. Salam. Thank you, Dr. Salam. We'll quickly move on to the next session. We start with the next session. The speaker is Dr. Reema Bashir, who is a consultant gynecologist at Kraft Hospital, PERINTHALMANNA. Topic is evaluation of an infertile couple. To chair the session, I call upon Dr. Najibuddin V and Dr. Gayatri, both from Kraft Hospital, onto the stage. Thank you.
Hello. Good afternoon. Welcome to the next session. It is about by our dear Dr. Reema.
Now let's welcome the speaker for the session, Dr. Reema Bashir, who is in the field of infertility and artificial reproductive technology for the last 10 years. And Madam is working in the reputed and well-known institution in Kerala, Kraft Hospital, Kodungalur, and Kraft Hospital, Perinthalmanna. Over to you, Madam.
Thank you for the kind welcome. Good afternoon, respected seniors and dear friends. At the outset, let me thank IMA and the office bearers of IMA Perinthalmanna for giving me this opportunity. The topic for my presentation today is evaluation of female infertility.
We acknowledge the presence of Dr. Mohammed Hassan, President of IMA Malappuram, in the hall.
Okay. Let me start with the definition of infertility. Infertility, it is the failure to achieve a successful pregnancy after 12 months of regular unprotected sexual intercourse. Approximately 85 to 90% of healthy young couple, they conceive within 1 year and most within 6 months. So it approximately accounts for about in 10 to 15% of couples, and it represents an important part of clinical practice. The natural cycle fecundity, or the chance of a couple to conceive in a given month, is approximately 20% in a healthy couple. So a few terms which I would like to define: primary and secondary infertility, depending on whether there has been a pregnancy or not. Cycle fecundability is the probability that a cycle will result in pregnancy, and fecundity is the probability that a cycle will result in live birth. And subfertility is a term which is usually interchangeably used with infertility. Now coming to the epidemiology of infertility around the world, like in the developed countries, 1 in 7 couples suffer from infertility. In developing countries, 1 in 4. Overall, worldwide, around 8 to 12% of reproductive age couple they suffer from infertility. And secondary infertility is the most common form of female infertility around the globe, and in most common regions of the world where the rates of unsafe abortion and poor maternity care which lead to post-abortive and postpartum infections. Now coming to the causes of infertility, in couples, the female factor accounts for around 40 to 55%. The male factor accounts for around 25 to 40%. The problem may lie in both in around 10% of cases, and it is unexplained in 15%. Now coming to the topic, which is the female cause of infertility and evaluation today. The causes for female factor for infertility, the major, it is because of ovulatory dysfunction. Decreasing ovarian reserve, endometriosis, uterine factor, and tubal factor can also be a cause for infertility. In more detail, ovulatory disorders, it can be because of PCOS, hyperprolactinemia, hypothalamic hypogonadism, a premature ovarian insufficiency, hypothyroidism, and in cases of congenital adrenal hyperplasia. Fallopian tube diseases, proximal or distal tubal obstruction can result in female infertility. Pelvic adhesive diseases can contribute to fallopian tube disease. Now, uterine causes can be because of fibroids, endometrial polyps, Mullerian anomalies, adenomyosis, and intrauterine adhesions. Age-related aneuploidy can alter the oocyte quality, which can result in infertility. Now, whom and when to evaluate? Any patient who by definition has infertility needs to be evaluated. Usually, as I said earlier in the definition, at 12 months in women less than 35 years. Above 35 years, the duration is given a cutoff of 6 months. And more immediate evaluation and treatment is warranted in women who are older than 40 years. And if a woman has a condition which is known to cause infertility, like oligomenorrhea or amenorrhea, any known or suspected uterine tubal or peritoneal disease, stage 3 or 4 endometriosis, known or suspected male fertility, sexual dysfunctions, any genetic or acquired conditions that predispose to decreased ovarian reserve, then they need to be evaluated immediately. A basic infertility evaluation consists of taking a history, a physical examination, a pre-pregnancy evaluation, and additional evaluation for etiology of infertility, which, as I said earlier, can be either because of decreased ovarian reserve, ovulatory dysfunction, tubal factor, or uterine factor. This is a chart just to move the focus onto that age and fertility are related. As you can see in the graph, follicles, they are depleting from the age of around like 35 onwards. The depletion is faster after 40. The number of abnormal oocytes are increasing more after the age of 40. So a peak fertility is usually seen between the ages of 20 to 32. It declines after that, and the ending fertility is nearly after 42 to 44. Coming to the history, what all we need to elicit when we are seeing an infertile female. The duration of infertility, how long the couple have been trying, and we need to elicit how frequent the intercourse is and has the intercourse been timed to ovulation. So a few words on the optimal frequency of intercourse. It is a widely held misconception that frequent ejaculation will decrease male fertility, but studies have shown that in men with normal semen quality, daily ejaculation does not change any of the parameters, and surprisingly in men with oligozoospermia also, sperm concentration and motility may be highest with daily ejaculation. And abstinence interval of more than 5 days can adversely affect the sperm counts. So an ideal, how do you say it? The highest fecundability is associated with daily intercourse, like 37% per cycle, and intercourse on alternate days can yield a comparable pregnancy rate. And the likelihood for the success, it decreases to 15% per cycle when the intercourse occurred only once weekly. So the couples, they should be informed that the reproductive efficiency, it increases with the frequency of intercourse and is highest when the intercourse occurs every 1 to 2 days. Now, this is a picture of the fertile window. It is best defined as a 6-day interval which ends on the day of ovulation. As you can see in the chart, actually the yellow graph is that of age between 19 to 26 years, and the blue one is between 35 to 39 years. As you can see, the day 0 is the day relative to ovulation, and the best fertile period is the maximum when it is in the 3-day interval before that. Now coming back to the history, we have to elicit also about the obstetric history, whether the patient has been priority of the menstrual cycle, any history which is suggestive of having menorrhagia or dysmenorrhea, any past history which is suggestive of pelvic infections or any pelvic surgery, dyspareunia. Coming to the medical history which needs to be elicited in case of the evaluation is any condition that can affect the reproductive success. Endocrine disorders, autoimmune, genetic, psychiatric or malignant diseases, that history has to be elicited. Chronic medical conditions such as arterial exposure of concern to pesticides or radiation exposure. The family history also needs to be elicited for thyroid disease, any history of PCO in the family, any recurrent pregnancy losses, any family history of breast or ovarian cancer, birth defects, mental retardation or developmental delay, early menopause or infertility. Contraceptive history to see for the previous methods of contraception, any allergy history as in any medical specialty, and any previous abnormal cervical cancer screening test and any subsequent treatment. Coming to the physical examination, in case of a lady approaching for infertility evaluation, general like height and weight, because both obesity and anorexia, the pulse to see for tachycardia or bradycardia, which may be present with thyroid disease. The head and neck have to be examined for thyroid and lymphadenopathies. The breast to be examined for Tanner staging, the presence of any masses, skin changes, galactorrhea. The skin to see for any signs of hirsutism. So you have to check for the face, chest, midline, abdomen for hair growth. Acanthosis nigricans, which typically presents at the nape of the neck or in the skin fold, which is a suggestive of insulin resistance seen in PCOS. The abdomen for any tenderness or masses, any surgical scars. The pelvis, for the external genitalia, we check for the Tanner staging, a speculum examination of the vagina and the cervix to assess for infections and anatomic abnormalities. A bimanual examination in this era of ultrasound is not very mandatory. Rectovaginal examination to palpate for uterosacral nodularity or to further examine that exam. A word about the pre-pregnancy evaluation and counseling. The role is to reduce the risk of adverse health effect for the woman, fetus and neonate, so that we can modify the risk factors and provide education about a healthy pregnancy. So the couple, we suggest them to go for serology testing for HIV, HBsAg, HCV, a cervical cancer screening, complete blood counts, sugar levels, thyroid function tests and blood group. This table just focuses on lifestyle factors that can affect infertility. As you can see, a BMI more than 35, the time to conception is increased twofold. In underweight, where the BMI is less than 90, test to see for ovulation. Ovulatory dysfunction is defined as a history of oligoprogesterone levels repeatedly less than 3 nanogram per ml or both, and it accounts for nearly 15% of the cause for infertile couples and up to 40% of infertility in women. The investigations from history itself, by asking about the menstrual cycle regularity, we can get an idea about the ovulatory status of the lady. Objectively, by doing the mid-luteal serum progesterone, ultrasound, and there are other methods like using LH kits, checking for the basal body temperature, endometrial biopsy, and histological dating. I'll be coming into detail about each now. The menstrual history, for many women, the menstrual history may be enough to assess ovulatory function. Ovulatory women, they have regular menstrual cycles, 25 to 35 days, and women with irregular infrequent menses, they may ovulate, but not very consistently. The committee opinions in both the American College of OG and also by the NICE guidelines, it is recommended that confirmation of ovulation by test should be considered, because up to 1/3 of women with normal menstrual cycles, they may be anovulatory, especially in women who have hirsutism. Mid-luteal serum progesterone, this test is done approximately 1 week before the expected onset of the next menstruation, that is approximately day 21 of a day 28-day cycle. Prior to ovulation, the values are between 1.5 to 3. The concentration becomes more than 3 once ovulated, and the value, it may be suggestive of the luteal function, like a value more than 10 to 20 may be suggestive of a good luteal function. The disadvantage is it is fluctuating levels because of the pulsatile secretion from the corpus luteum. Now coming to the ultrasonography, by doing serial transvaginal ultrasound, we can have a detailed information about the size and number of the preovulatory follicles, and it is the most accurate estimate of when ovulation occurs. The evidence of ovulation in an ultrasound is when the dominant follicle suddenly disappears or regresses in size, it gets irregular margins, the follicle is filled with echoes, it's the presence of free fluid in the pouch of Douglas, there is increased perifollicular blood flow velocities on Doppler. Now a word about the LH kits. LH kits, they are used to detect the urine LH level, which is equivalent to serum LH concentration of 20 to 25 milli international units, which is equal to the mid-cycle LH surge that precedes ovulation by 24 to 36 hours. They are an indirect evidence of ovulation. The midday or the evening sample of urine is used. A false positive case of approximately 7% of cases are seen. It can be persistently positive in women with elevated LH, like in case of PCOS and in premenopausal women. Serial basal body temperature, it is easy to measure body temperature. This test, it works on the principle of the thermogenic effect of progesterone. The follicular phase, the usual temperature is between 97 to 98, and after ovulation, the luteal phase, it rises by around 0.4 to 0.8. It is biphasic in ovulatory women. That the chart, you can see that the violet line, it drops before it rises after ovulation. a monophasic pattern is seen in anovulatory women. And we calculate the highest, the fertility interval as 7 days before the mid-rise in BBT. The disadvantage is it does not reliably define the time of ovulation, and it is tedious nature of the test. Endometrial biopsy, actually it is of historical importance only. Nowadays, most of us don't do endometrial biopsy. It is to determine the presence of adequate progesterone production, and it is usually performed 4 days before the expected menstruation. The endometrium is dated using noise criteria, and a delay in maturation of longer than 2 days is recognized diagnostic criteria for a luteal phase defect. And nowadays it is abandoned because of its lack of accuracy and precision. Now, once we have evaluated the lady and found that she has, in the scenario where she has irregular cycles suggestive of anovulation, it is up to find out what could be the reason behind the anovulation. So further hormone tests are warranted. So we have to check for FSH, estrogen, thyroid, TSH, prolactin, androgens, and the ovarian reserve test, which consists of FSH, E2, antral follicular count, and AMH. Hyperprolactinemia and thyroid disorders, by checking prolactin and thyroid, we can find out. Coming to where we have to check for anovulation, we are doing the FSH and the E2. A low FSH and a low E2, the anovulation is classified into the WHO group 1 ovulation disorder, which accounts for around like 10% of anovulation. It is basically a hypothalamic pituitary failure. A normal FSH and a normal E2, which goes into the WHO group 2 ovulation disorder, which is around 85% of cases. It is mainly, we find it in cases of PCOS. High FSH and low E2, it is seen in WHO group 3 ovulation disorder, which accounts for around 5%. Basically, it is in a case where it is an endocrine failure, like an ovarian failure. If signs and symptoms of hyperandrogenism are there, then further testing for serum testosterone, androstenedione, DHEAs, 17-hydroxyprogesterone, they have to be done to rule out the presence of a late onset congenital adrenal hyperplasia, Cushing syndrome, or an androgen producing tumor. A word about the ovarian reserve test. Ovarian reserve, it is the number of oocytes which are remaining in the ovary. It is the oocyte quantity, not the quality. Actually, quality will relate to the potential of a fertilized oocyte to result in a live-born infant. And the ovarian reserve, it will correlate inversely with age. That is, as the age goes high, the reserve comes down. But there is considerable variation in ovarian reserve even among women of the same chronological age. Now, the investigations for ovarian reserve, the main tests are AMH, AFC, day 3 FSH, and estradiol. There are other tests, but which are not recommended. Anti-Mullerian hormone, AMH, it is a glycoprotein which belongs to the family of transforming growth factor beta, and it is produced by the granulosa cells of the primary, preantral, smaller antral follicles. They are a direct ovarian reserve marker because they correlate very well with the primordial pool, and they are gonadotropin independent, so we can check them at any time of the cycle. And AMH will decline years before a rise in FSH, so it seems to be a more sensitive biomarker of ovarian reserve. It is found decreased when you are taking ocipils for long, in case of obesity, when you are on gonadotropin injections. It is increased in PCOS. AMH, which is more than a 3.5 nanogram per ml, has a sensitivity of 90% and a specificity of 81% to predict a hyper response. And AMH of low, like we take a 0.2 to 0.7, it has a sensitivity of up to 40 to 97% and a specificity of 78 to 92% to see for a poor ovarian reserve. Antral follicle counts, we check in transvaginal scans where count less than 3 to 4, it predicts a poor ovarian response. Basal FSH and estradiol concentrations, they are also measured between days 2 to 5. These tests were done before the era of AMH actually. Serum FSH, women with depleting oocyte pool and decreased ovarian reserve, they will present with elevated basal FSH. And the FSH values, they can vary widely between cycles and within cycle also. And basal FSH, when combined with estradiol, has a better predicting response. Sensitivity of FSH to predict a poor ovarian response, it is better at very high threshold levels. A word about serum estradiol. Follicular estradiol levels, they are better used with basal FSH to assess ovarian reserve, and basal E2 has poor inter and intracycle reliability. In combination with FSH, it is better to predict responses. Decreased ovarian reserve is seen when the AMH is less than 1, AFC between 5 to 7, FSH more than 10. Just a word that ovarian reserve tests, they do not actually predict reproductive potential in women with infertility. They are the best, they only show excellent promise to predict ovarian response in IVF. Tubal patency test. Tubal disease also is an important cause of infertility, and these are the following tests which can be done to evaluate the tubal patency: HSG, saline infusion sonography, HycoC, laparoscopy, falloposcopy, salpingoscopy, chlamydial antibody test. A few words about each in detail. HSG is a radiographic evaluation of uterus and fallopian tube, ideally done between 7 to 12 days of cycle. And it is a valuable tool in the assessment and the detection of congenital anomalies, fibroids, synechia, polyp, tubal occlusion, peritubal adhesions and all. The contraindications: when there is an active pelvic infection, when there is a prior hypersensitivity to iodinated agents, we should not be doing an HSG. These are a few slides showing the various Mullerian anomalies picked up in HSG. The limitations of HSG is that the exact nature of the uterine lesion is not delineated. Because of condyle spasm, false positivities can be there. False negative can be there when there is a large hydrosalpinx and intravasation of dye is there. The sensitivity and specificity is like 65 and 83%. The clinical implications are that when an HSG reveals an obstruction, there is still a relative high chance that the tubes may be patent. But when the HSG demonstrates a patency, there is little chance that the tube is actually occluded.
Excuse me, our time is...
Yeah, I'll just point it up. The best test for tubal patency would be laparoscopy and a dye test. And coming to the uterine cavity, when we look at it, the best modality would be to do a 3D ultrasound on an MRI. The other test which we can do is 2D TVS, we can do HSG, SIS, hysteroscopy and all. And peritoneal factors are also evaluated with laparoscopy. Infertility tests that should not be routinely ordered. Like we should not be doing a laparoscopy for an unexplained infertility. PCT is no longer recommended. Thrombophilia testing, immunological testing are not recommended. Doing DNA fragmentation index in the first visit is not recommended. Karyotyping, endometrial biopsy and prolactin. To conclude, I would just try to highlight that when you're evaluating for infertility, both the couple should be evaluated. It's not just that the lady should be taken up for further tests and the male should not be evaluated. So thank you for your patient listening and happy Onam everyone.
Thank you, Dr. Rima. Over to the chair, please, for the comments. Chair.
Thank you, madam, for that elaborate talk on the evaluation of female infertility. I think madam had covered all the aspects of the female factor in the infertility issue. And any questions from the audience?
Dr. Gayatri, any chairperson comments? Dr. Gayatri?
It was a very nice presentation, madam. Actually, it is a social stigma also that the couple is facing when I wanted to ask you, when a woman is coming, when a couple is coming for this evaluation, will you directly start the patients on treatment like ovulation induction? What is your protocol? Like how long how should you first start on the evaluation?
As I said in the presentation, first we have to anyway see a detailed history. Like if their coitus is not correct, then they have to be counseled regarding that. If they are not aware about the ovulation period, about the fertile window, they have to be counseled regarding that first. If they have been trying the right way, then the next step would be to evaluate for each of what I said earlier. Like if ovulation, for the tubes, for the uterus and all. An ultrasound actually would cover most of the things. So after that, also if we are not able to find a particular cause only, we'll go for invasive investigations also.
Okay, thank you, ma'am.
Any questions from the audience? If there are no questions, we'll move on to the to end this session by I request Dr. Najmuddin to kindly hand over a memento to the speaker, Dr. Rima. And Dr. Gayatri, kindly hand over the certificate to Rima. I request Dr. Jayakrishnan B from Tirur branch to kindly come onto the stage and give a small memento to our chairpersons.
Thank you, sir.
And to Dr. Gayatri.
Next, we will have a session by Dr. Vishnu Vasudevan, Consultant Endocrinologist, Maulana Hospital, PERINTHALMANNA. The topic is Achieving Glycemic Symmetry with Newer Basal Insulin Analogs. And I kindly request Dr. Abdul Jalil sir and Dr. Deepthi Sunil to chair the session.
Good afternoon, everybody. So we are in the last but session of the day, and we are all familiar with the insulin and the glycemic control. We have newer insulin which are much better, and which are, without going much into the topic introduction, we have Vishnu Vasudevan here to talk to us regarding the glycemic control with the newer insulins.
We'll have just one more session, one more talk after this, which is a very relevant topic, nutrition in the elderly people, immediately coming after Dr. Vishnu's talk.
Over to you, Vishnu.
Thank you, sir, for the introduction. So I am the penultimate batsman, and today's talk, though the previous talks were all very interesting and I learned very much from the previous talks, many of the talks were very much specialized to the particular branch, and the general practitioner or the other specialty person might be much less interested in the finer details, though it will be nice to know what is happening in the other arenas. But we can never, as a doctor, even if you have only MBBS, though I should not say that, but still, even after you complete your MBBS and whatever specialty you, whether you specialize or not, whatever you do, you cannot escape from seeing a diabetic patient. So diabetes is always important for anyone who has completed his medical education. So my talk is, though it is a sponsored talk, still it is very useful to know about the details. This is regarding achieving glycemic symmetry with the newer basal insulin, that is insulin degludec. So that's my disclosure for this talk. We are talking about a 45-year-old professional who is having diabetes for 6 years, and he is poorly controlled on oral anti-diabetic agents. He is having a busy and erratic life schedule. He is an engineer professional. He has to travel a lot. He has complications of microalbuminuria. He is, just by having microalbuminuria, he is at very high risk for atherosclerotic cardiovascular events. He has a history of previous hypoglycemia, and that itself puts him into a graver danger. So in detail, I have highlighted the important points here, that his HbA1c is not well controlled, 8.8%. Both his fasting and postprandial are high. His blood pressure is not controlled. His LDL cholesterol is high, so probably he is not taking his medications properly. His urinary albumin excretion is high, 200 milligram, that is very high actually. And he has too much of limitations with his lifestyle. Finally, we'll come back to this case. Once again, talking about his treatment, he is on 3 oral antidiabetic agents, including metformin, glimepiride, and empagliflozin, which is an SGLT2 inhibitor, the latest one, which has been proven to have benefits in atherosclerotic cardiovascular disease. Still, blood glucose control is very much important. Whatever drug you use in the medical management, finally, blood glucose control is always important. And the uncontrolled hyperglycemia and the subject's hectic life schedule is the most important points to note in this case. He travels often and he is unsure about his schedule. So what next in his patient? We'll just forget about whether the patient can afford and these things, because those things will come into the picture when you actually are in practice. But still, if those things are not is addressed by something else, probably the patient is insured or something, then what should be the best option for the patient? That is what we are considering here. So these all factors should be considered when we are choosing the next agent. Efficacy, what is the risk for hypoglycemia, what is the effect on glycemic variability, which is coming up like a big thing now, and simplicity of use. So regarding his, so we'll touch upon these points one by one. Regarding the efficacy, there is no question that insulin offers the maximum efficacy. Considering all the anti-hyperglycemic agents, you take it all together, insulin offers the maximum glycemic efficacy. So all these trials have been conducted on degludec insulin specifically, and they have all remarkably shown an HbA1c reduction of more than 1.5%. Now the second point is hypoglycemia. So what about the risk of hypoglycemia? If I should say one thing about this insulin, the newer insulins, that is the second generation basal insulins which we are talking about, there are two second generation basal insulins. One is insulin degludec and other is 300 units of or concentrated insulin glargine. So these are the two insulins which are available to us, second generation basal analogs. So if we specifically talk about these two molecules, the most important thing is reduced chance of hypoglycemia. So the risk of hypoglycemia is markedly lower if you use these insulins. So these are all developmental programs which are happening in degludec, the BEGIN trial, SWITCH trial, DEVOTE trial, EU treat. We will not go into the details. They have all compared insulin degludec versus U100 glargine, and they have all found that overall nocturnal and severe hypoglycemia risks were significantly lower with degludec as compared to U100 insulin. So this picture, I think you can clearly see the U-shaped curve here, where the risk of hypoglycemia is much higher once you reach the ends of the HbA1c control. The HbA1c is poor, there also the hypoglycemia risk increases. And if the HbA1c, if you are trying for a tighter control, that is bringing the HbA1c lower down, then also the risk of hypoglycemia increases. So you can see the two graphs. The gray colored graph is for U100 glargine and the blue colored graph is for degludec insulin. You can see that even at lower levels of HbA1c, the hypoglycemia risk is not markedly increasing. The symptomatic hypoglycemia risk is not markedly increasing. So you can try for a better control with, if the patient is at high risk of hypoglycemia, actually we will keep the HbA1c between 7 to 8. But even if you want to titrate it below 7 or 6.5, still the hypoglycemia risk is not higher if you are using degludec. Another trial have also clearly shown that this is regarding degludec versus U100 glargine, where very high risk for hypoglycemia. Those patients, the risk for major adverse cardiovascular events were significantly lower if you use degludec. So the major adverse cardiovascular events, that is MI, stroke and all, happen when the hypoglycemia events happen. So the patients who are at very high risk for hypoglycemia, if you take out that population, subpopulation specifically, the risk for major adverse cardiovascular events are lower if you use degludec. This is another study where you are comparing the two giants, that is degludec and U300 glargine. So these two, because the previous comparisons were all not fair, because degludec is a highly advanced insulin. So once you compare a degludec with U300 glargine, then it becomes a fair comparison. The same conclusion that there was almost 30% lower risk of hypoglycemia with degludec. So we have completed 2 points. The third one is regarding glycemic variability. So unless we do HbA1c, we are not knowing anything. Just by doing any blood glucose value, if you are managing blood glucose, the diabetic patient, then we are not getting any picture at all. If you are hypos and hypers, some people will be having remarkably good control even at HbA1c of 6 and 6.5. So after HbA1c are similar with degludec. So this comparison has also been done with U300 glargine, where also they have found that degludec insulin gives a remarkably good control or stable control. This is also similar picture where IDEG and U100 glargine. So this picture actually shows a dramatic effect that there is a 4 times lower glycemic variability with insulin degludec as compared to U100 and U300 glargine. This lower GV, the glycemic variability is taken from continuous glucose monitoring metrics or CGM metrics. So there are various metrics called time in range, time below range, time above range. So these are all the short forms. Time in range is, you have to keep the values between 70 to 180. So that is the range which we are looking for. And 70% of the time we have to keep the blood glucose values in between this. So that is called time in range. So time in range is much better and with insulin degludec, and time below range or TBR, that is the risk for hypoglycemia. So you have to keep the time below range as low as possible. The target goal would be to keep it less than 4%. So 4% of the times. So this treatment difference is maybe not that significant. You can see that once you compare insulin degludec with U100 glargine, there is a 20 minutes of the day where there is a treatment difference for time in range. That is only 20 minutes, but still, if it is in the hypoglycemia point, presented in the ATTD conference in Barcelona, Spain, where adult patients 18 to 70 years with type 1 diabetes, having an A1C between 7 to 10% on multi-drug insulin regimen, they did not have any exposure to U300 or insulin degludec in the previous 30 days. So they were randomized into 2 equal groups, where a part received U300 glargine and another part received insulin degludec 100. The primary endpoint was assessed at the end of week 12. Here the screening, after the screening part and a run-in period, an open label treatment period was given, and finally a continuous glucose monitoring was done to look at the time in range, time below range and everything. So you can see that the difference in time in range is 52 and 55. So there is only 3 minutes of difference between U300, because these are almost similar insulins, U300 glargine and degludec. HbA1c is slightly better, and time above range is a little bit lesser, or 45 minutes lesser. So these are mean values. If you have no problem with choosing an insulin, if you are not thinking about the monetary aspect, and if you are free to choose any insulin, then the best insulin would be always insulin degludec. So finally, we will talk about the dosing and the simplicity of regimen. It is very simple to initiate degludec. You have to just start at 10 units, recommended daily starting dose. It can also be switched from the other regimen of basal insulin like NPH or glargine. The most important picture here is that there is no exact time where you can give degludec. The patient, whenever he remembers, once he is out of bed till he goes into bed, whenever he remembers to take the insulin, he can do it. If he is injecting in the morning and next day he forgets in the morning and injects in the evening or afternoon, then also it is fine. You just have to inject once daily. So you can see that these phase 3 clinical trials have shown that it was used once in the morning, next day evening, next day morning with a small dose. So minimum of 8 hours gap should be there, and a maximum of 40 hours gap can be there between 2 injections. Now this has clearly translated into better adherence also. This is a comparison between U300 glargine, and it's also important. Once you finally, the cost is calculated when how much of units of insulin is going into the body. So total daily insulin requirement is also lesser if you use degludec, so that that cost factor can be taken care of. A1C has come down to 7.4%. So this is a typical case where we can get similar results with a similar patient. His other medication adjustments which were done was, his glimepiride dose was reduced from 2 milligram to 1 milligram. So he is into a high risk for hypoglycemia. So hypoglycemic agent should be reduced. Insulin degludec was started at 10 units and slowly titrated up to 16 units. And at the end of 12 weeks, those were the results which we got. So that is the end of my presentation. I thank you for your patience. I'll be happy to answer any questions.
Thank you, sir, for this wonderful talk. The forum is now open for questions.
What is the price difference between Mixtard and degludec? How many times?
It is almost 4 times. 4 to 5 times.
So can you go back to slide number 23? I mean, I think I misunderstood the slide, but it shows that the events of hypoglycemia were slightly more with degludec as compared to glargine 300.
23, 21.
Yeah. Time under 70 milligram per DL.
Which one?
The time under, below the HbA1c, it shows time under 70 milligram per DL. It was more with degludec as compared to glargine,
that was,
no?
See, this is actually a non-inferiority result. This trial did not show any superiority for degludec. These are all numerical values. You can see the hashtag there. it is written below that it is all numerical, this thing, no statistical significance. So those hashtags which you can see here, below, that is already written as non-significant there, time less than 70. So these numbers which are all better, showing something better for degludec are all numerical. They are all non-statistically significant. So I think in my practice also, if you ask me, if you don't consider this talk at all, you just ask me which insulin you prefer. So I will say that there is no preference difference between U300 glargine, except for the cost, if you don't have the cost concern. Degludec is costlier than U300 glargine. Thank you, sir.
Any more doubts from the audience? If there are no more audience, we'll wind up this session. I call upon Dr. Abdul Jalil to kindly hand over a memento to Dr. Vishnu. Thank you, sir. And I request Dr. Deepthi to kindly hand over the certificate to Dr. Vishnu.
Now I request Dr. Shaji sir to hand over the mementos to the chairpersons. Now we are moving on to the last session for the day, that is nutrition in elderly people. I request Dr. S. Ramdas, the speaker, to come to the stage. And I request Dr. Jayakrishnan B. sir and Dr. Shaji Abdul Ghafoor to chair the session.
So I thought in the next few minutes we'll talk on a topic which has been very close to my heart, that is nutrition in the elderly. Now, when you talk about longevity, certain questions that come to our mind. One is, can lifespan be increased? If not lifespan, at least can the health span be increased? And what is contributing to it? Is it nature or nurture or both? And if we cannot increase the lifespan, can we make the old age more pleasant? So in this topic, I would like to consider initially something on the scientific rationale for special nutritional requirements of the elderly, then talk something about dietary nutrients, and lastly, prevention of muscle loss in the elderly. Now, we know that aging, there's two things, the chronological age and the biological age. Every year we celebrate our birthday, that is, you become 1 year older, and that is your chronological age. But what is the biological age? If at 60 you feel and behave that you are almost only 40, then that is your biological age. Now, so a living example of that would be Dr. V.U. Sethi, who has just completed 80 years now. His biological age will be only about 55 years now. So now, what are the factors which affect the biology of aging? It is found that only about 35% of the aging is dependent on your genes. So that means if you have lucky genes, you have only 35% chance that way of living. The remaining 65% depends on the environment. Now, that is, if you have got an unhealthy diet, diabetes, hypertension, smoking, all the comorbidities, alcohol, toxins, you're going to have a premature aging. In contrast to that, you've got a healthy lifestyle, physical exercise, healthy diet, you're going to have a more healthy living, and thus your biological age will be lesser. Now, let us talk about the rationale for the specific foods in the elderly. We know that even now, in spite of all the work that's being done in nutrition, the nutritional requirements are not entirely properly defined, but some things are known. That is, many chronic, non-communicable diseases are related to diet, and these can be reversed even in old age. Secondly, aging changes requirements for nutrients. That means one important factor is that as age advances, your lean body mass reduces and your fat compartment increases. So naturally, that's what happens as age advances. And secondly, the basal metabolic rate decreases in the elderly. And we also know that cancers of the prostate, breast, and colon have a dietary etiology, and also degenerative diseases like CAD, coronary artery disease, cardiovascular disease, osteoporosis are also related to diet. And lastly, micronutrient deficiency is also common in the elderly. Now, every organ is affected by aging. Now, let's have a bird's eye view on the various organs, right from the hair to the skin and to every one of the internal organs. Age does affect. Now, skin, the ultraviolet light, decades of ultraviolet exposure, you can cause damage to skin. To some extent can be ameliorated by giving vitamin A, E, and some polyunsaturated fatty acids. In the cardiovascular system, we know that atherosclerosis and hypertension to some extent can be mitigated by reducing your salt and fat content. The musculoskeletal system, we know that osteoporosis, sarcopenia, that is muscle loss, osteoarthritis, can be benefited by calcium, vitamin D, and protein. Say the central system, we've got cognitive changes, allergy, and more important also in the gastrointestinal gastrointestinal system. We get constipation, cancer. They are very much affected by, in fact, fiber. High fiber diet can really be very useful in the treatment or preventing diseases like colonic cancer. Now, what are the nutritional needs imposed by the aging? We know that one is to prevent malnutrition. Second, you know that as age advances, the tissues need replenishment. The bones, the muscle, the immune system, bones are in dynamic equilibrium. As age advances, on one side there is bone resorption, on the other side there's bone formation. But bone resorption keeps continuing, but bone formation becomes lesser, and so that leads to osteoporosis. Same way, muscle loss causes sarcopenia, and the immune system also reduces. And we know that there is a role of diet in both prevention of atherosclerosis, malignant disease, and obesity. Now, when we talk of malnutrition in the elderly, we can think of two things. Either you got overweight or underweight. Overweight, as age advances, we know that our basal metabolic rate reduces, your caloric intake increases, exercise tends to go down, and ultimately that causes weight gain. As opposed to that, underweight can occur due to many causes. And one important condition is frailty. Now, frailty is nothing but unintended weight loss and weakness without any definite disease. This is an enigma. But they say that this is a condition where probably chronic inflammation may be leading to this condition. Apart from frailty, other causes for underweight, maybe physiological changes to the aging, reducing the taste and smell as the age advances, reduces changes in the gastrointestinal tract, maybe pathological changes like medical disease that you have. Many drugs which you are treating, which you are under treatment might cause anorexia of aging. There will be psychological cause, decreased exercise. All of this cause anorexia of aging and contribute to underweight. Now let us talk about something about dietary nutritions. What are the nutrients we are using in the diet? We have got the carbohydrates, proteins, fats, and fiber. And the micronutrients, the vitamins, minerals, and phytochemicals. Years ago, and when we are all passed through medical college, we never heard of phytochemicals. We think of vitamins and minerals. But these days, phytochemicals have come into forefront because a lot of work has been done on phytochemicals, and this is an important part of a micronutrient. Now, let us think about the macronutrients first of all. Carbohydrates, we know that we have got complex and simple. The complex carbohydrates, regarding simple simple sugars we'd like to avoid because that's the one which increases the glycemic index, leads to obesity, causes diabetes, etc. Whereas the whole grain cereals means the cereals where the bran is preserved, where the outer covering of the thing is preserved. They are the better ones for the old people. Then about fats, we know the cholesterol is found in meat, and fatty acids, saturated, monounsaturated, polyunsaturated, and then we have that most useless group of trans fatty acids, which comes in reuse of oils, all of bakeries which proliferate all around the country, which can cause highly atherogenic, the trans fatty acids. And then we have the proteins. We have the animal proteins, which have all essential amino acids, plants which lacks essential amino acids, but if you have a combination of plants, you can make up for it. And then we have a very important thing which we also neglected in diet is the fiber content. Now this fiber can be soluble or insoluble, and this has done something great to the intestinal diverticulitis, cancer, cold, etc. To very extent, they say that high fiber content may be useful to prevent it. Now, about fatty acids, I said, apart from the polyunsaturated, mono and polyunsaturated fatty acids I mentioned, there are two different important entities, the omega-3 and omega-6 fatty acids. Now, the ratio between the omega-6 and omega-3, they say should be preferably 1:1. With the present diet that we have now, it goes also as much as 50 to 20:1. Why that is so? Because the omega-6 fatty acids, gradually when you break down, tends to produce ultimately prostaglandins, all this sort of causes where thromboxane, E2, etc., which because of inflammation, thrombosis, and vasoconstriction, whereas omega-3 fatty acids ultimately end up in vasodilatation and reduced inflammation. So we would like to have more of omega-3 fatty acids than omega-6 fatty acids. And lastly, I said about the trans fatty acids, which are highly atherogenic due to our bakery items. Now, these are some of the common source of the omega-6 and omega-3 fatty acids. And you know that more of what we take is essentially the omega-6 fatty acids. Now, what are the protein requirements? We have talked something about carbohydrates and fats and all, something about proteins. Now, protein, the usual requirement was thought to be as much as 0.8 gram per kg per day. Now, newer evidence that says that much of protein is not enough because to make the muscle mass. So newer evidence says that something like 1.2 to 2 grams per kg per day is required, which comes to about 80 to 140 grams for a 70 kg person. Now, what are the benefits of this protein being given? It increases muscle health, it prevents muscle loss or sarcopenia, it maintains energy balance, it maintains optimal weight, decreases obesity, it improves cardiovascular health, and improves and prevents diabetes. Now, what is the outcome of altered protein metabolism in the elderly? One side, you have decreased response in muscle protein synthesis to amino acids, which leads to sarcopenia. That is 3 to 5% muscle mass for every decade after 30 years of age. We already mentioned that decreased BMR of 1 to 2% per decade after 20 years leads to obesity and increased fat composition. Then we also know that when the liver is not synthesizing any of albumin, you've got decreased albumin levels, and this changes the drug pharmacokinetics, because you know that most of the drugs are combined with albumin, and so their level, the dosage has to be altered, and low albumin leads to decreased wound healing, etc. Now, something about whey protein. What is whey protein? Whey protein is nothing but the protein which remains in the liquid after the milk is split to form cheese. That is the paneer. Now, it is found that this contains a lot of leucine, which is important for muscle mass building. Having said that, this has become very popular in the youngsters who are trying to pick up muscle building and body building. They are using a lot of this, and it's available in the stray market. But one has to be a little careful when you pick up these whey protein food that you from the nutraceuticals, because they have found that there is some action, that added sugar, fats, some toxins like bisphenols, heavy metals, etc., can contaminate them. So unlike the pharmaceutical industry where they are under close supervision, the nutraceuticals are not under close supervision. So you want to be cautious what preparation you take. Now, too much of it can cause indigestion and lactose intolerance. Having said that, they have found that many studies that there is definitely improvement of muscle performance, protecting sarcopenia, reducing risk of falls, improving recovery from diseases, preventing cardiovascular and metabolic diseases, and to some small extent, even improving hepatic steatosis. This whey protein is useful. Now, next, this is something about very important side about healthy cereals. You just see the fiber content of the matta rice, the Kerala rice which we use is so much more than the maida, which is so little. And that is why our parotas which we make and which we have every day, tend to, in every function, has a lot of, we do lose the bran. The polished rice knocks the bran. And that is actually, unfortunately, one of the reasons why there is a lot of atherosclerosis. Now, regarding legumes, this is actually meant more for the vegetarians who believe, who know that someone has classified into cluster 1, 2, and 3. 1 means the usual green grams, the kidney beans, green beans, black beans, all those black grams which are there. They are the small thing which you routinely use in the things. The cluster 2 is mainly soya bean. Soya beans now very much available in India, but they have been more popular in China and West Asia. That contains also a lot of protein. And the cluster 3, we have groundnut, which is a poor man's protein. It contains a lot of fat also. The only problem with taking too much of legumes is that they contain some oligosaccharides, which can cause some gas formation. Otherwise, they're excellent. Now, let us think something about micronutrients. Now, we know that the A, D, E, K, the fat-soluble, water-soluble P and C vitamins, and the whole minerals and trace elements, which are always mentioned. But I'm talking something more about phytochemicals, which have now, I said, has been of great interest to everyone. The tomatoes, the carrots, actually the curcumins. Actually, our Nadan Nellika is actually the Indian gooseberry. Many of, the curcumins is the manjal that comes at it, the carotenoid. The tomatoes, which bring a lot of lycopenes. These are all, why these have become important is because they are basically antioxidants. They mop up the free acids, and they act as free radical scavengers. And that is their importance in the nutrition. Now, regarding the vitamins and minerals, we have talked, everything is important. Vitamin D3, calcium, potassium, vitamin D3, B12, magnesium, potassium. Already talked about phytochemicals. Two important things in vitamins, which are so very important in the elderly, are the vitamin D and B12, which we'll consider in detail. Now, vitamin D, the elderly skin has reduced ability to convert the D precursors to D3. And food, is not a good source of vitamin. It's sunlight, which is a better thing. But D3 supplementation, about 800 units per day, has been found to prevent falls, can be reduced by 14%, fractures, hip fractures, reduction by 26%, non-vertebral by 23% reduction. This has been found. So that is the importance of vitamin D being supplemented. So every take a supplement of vitamin D. This is very common in the elderly, especially in vegetarians, about 20% for more than 60 years. Now, what is so important about, but one should remember is that it is not only the vegetarians who are deficient in B12, also the non-vegetarians. The reason why? Because gastric acid, the acid in the stomach is very important to cleave the B12 from the food and bind to the intrinsic factor. So once you have low acid, you cannot do that. And this is made more difficult and more complicated because the large number of proton pump inhibitors we use. Interestingly, I should tell you one thing about this point. A month ago, prescriptions they take. So when we asked one patient to bring all the collection of what he's been regularly taking, a very systematic person, he showed in his box that he was taking omeprazole, which he was taking from the counter, from the pharmacist, which was good for gas. Then he went to two other consultants that rightly prescribed esomeprazole and pantoprazole, but ultimately, without doing to anyone else, he was taking all the three prazoles, omeprazole, pantoprazole, and esomeprazole at the same time. Now, what I want to say is that this B12 supplementation is recommended for all elderly patients. So I think, personally speaking, they say that the level of B12 level, sometimes even if you find the B12 level, patients who have clinical symptoms, for example, pigmentation, you got early cognitive changes, neuropathy. These are all small changes, anemia, macrocytic anemia. If you take off the folate and the alcoholic people who also have. But predominantly, we should think of B12 deficiency. And I think they say that ideally, we should even to be accurate about thing, one can check up the methylmalonic acid level. This is supposed to be a precursor of B12, but checking that is very expensive, so that is not practical. But I think, but checking that is very expensive, so that is not practical. But I think, as you don't tend to produce hypervitaminosis like A, D, E, or K, you can always give it on clinical grounds. And this, I thought, is a very important message which I want to tell about this B12. And this is about a slide about all which I mentioned last year about the phytochemicals. I'm showing it again and again because the importance of this, and some of them which are not neglected, because I said about turmeric, even pumpkin seeds are good. Amla is all the cranberry, these berries are quite expensive, but our Indian gooseberry, the Nellica, is a wonderful source of protein. Now, among these antioxidants, this picture is just showing some of the things, the carrots, the garlic, the lemon, tomatoes, walnuts, grapes, etc., broccoli, protein as supplements. And as they move, when we take off the mutton rice, we remove and the endosperm that contains the starch, also very low content of protein, and all the good things goes away. The germ has high in proteins, lipids, vitamins, etc. It's a bran that we it's a bran that we remove when we do the bran is something which we actually remove when we do our cooking, and that I think is a very important factor. Just to highlight this, I've just shown this slide. Now, what are the challenges in the eating in the elderly? Although many of them will have loss of taste sensation, there's hence craving of highly salted, sweetened food, etc. You can't give them too much of salt or sugar. What you can do is to give something like pudina, cinnamon, all sorts of herbs, etc. Added to that, we have lack of teeth, dry mouth, constipation. Then you may have comorbid diseases like, for example, renal failure, etc. Their health may be affected. Then, of course, economic reasons, they may not be all but are good. They may not be able to buy because of financial burden. Now, let us talk something about calorie restriction. We know that one way to reduce weight is to reduce calorie. But when you reduce calorie, how do you know whether it is getting proper nutrition? That is where the concept of nutrient-dense food comes. What are the nutrient-dense foods? They are foods that contain a lot of nutrients but are low in calories. The examples of these are the fruits, vegetables, whole grains, seafood, lean meat, eggs, legumes, nuts, and low-fat milk. Now, this is a chart which has been made for the Indian guidelines, a lot of cereals that you can take in plenty, the fruits and vegetables you can take liberally, of course the fats moderately, and of course the bakery, other items which are there, which are at a much lesser extent. But if you think of just a sort of, not a full roughly a non-vegetarian and vegetarian average diet, it includes egg, some curds, nuts, 200 cc of milk, lentils, chicken. As opposed to that, for a vegetarian person, lentils and paneer or legumes and curds sort of make up. But you know that just to show that how difficult it is for a vegetarian to have adequate number of proteins. No one actually, we cannot measure all these things. Just to give an idea about what you can take. Lastly, next part, I would like to talk about, I said in both that of so much importance about sarcopenia, muscle loss, and consequences of muscle mass loss. Intensive care unit, we know that the mortality increases, the infection rate increases, the length of admission days increases, the intubation time increases. We know that all the mortality, complications, length of hospital stay increases, but as a long-term program actually gets worse. In addition to that, we have depression, diabetes. We also mentioned about falls and malnutrition. So altogether, muscle loss can cause a lot of disaster. So to compensate that, you've got nutrition for muscle strength. We said exercise is the most important. To that, to add protein, vitamin D, calcium. And one thing which has been found out recently is that there is something called beta-hydroxy-metamethylbutyrate, or HMB, which has been shown as to support muscle health. There's an active metabolite of what I said, what we said about when we said about this thing, said about leucine, that is an important metabolite which is in muscle mass. So this is an active metabolite of leucine. It occurs naturally in the body and found in small quantities in foods. It's clinically shown to support muscle mass in healthy adults, preserve muscle mass during extended bed rest, and enhance recovery during rehabilitation. They say that increases lean mass, increases hand grip strength, reduces protein catabolism, enhances recovery during exercise, prevention of muscle atrophy, preservation of muscle mass in older adults, prevent muscle loss in ICU patients, greater muscle mass gain, and improving muscle strength. All of that is said to be of an advantage. So, on one side, you have exercise. On one side, the nutrition. Nutrition, high protein diet with essential amino acids and branch-chain amino acids, which contribute to muscle accretion, and this leucine metabolite, HMB, which may help to stimulate the protein synthesis. So what is an attribute of an ideal oral nutritional supplement? It should be clinically proven. It should have meeting dietary guidelines for Asian Indians recommended for healthy diet. It should have high quality protein, should include fibers and prebiotic, should have a desirable electrolyte content, and should have a blend of micronutrients and vitamins. So to summarize what I said, whole grain cereals have higher micronutrients and fiber content, many of which are not consumed. 2, the fresh fruits and vegetables contain a lot of vitamins and phytochemicals. Whole grains, fruits, vegetables, and polyunsaturated fats are key to healthy eating. Maximizing the musculoskeletal peak through adequate nutrition and physical activity at a young age and maintaining the peak in adulthood is a strategy to counteract the consequent rate of decline seen in older life. Supplementation can help aging in the optimal way. High protein diet, including essential amino acids and branch-chain amino acids, may contribute to muscle accretion, while the leucine metabolite is a potent stimulator, HMB is a potent stimulator of protein synthesis in muscle. So Vash, I should thank you for the patient listening, and I would like to take this, I'm the advantage of being the last speaker. I just want to take this as an opportunity to congratulate the entire team of who have organized the AMSCON this time. I think it was a tremendous effort, right from the president, secretary, the senior stalwarts, the organizing chairman, secretary, all up, and the entire team have done a great part. But I think it's only right that I make a special mention about souvenir. What Dr. Rama has achieved is something fantastic, because I happen to be many in the past, very often when you connect souvenirs, we put it in bag and we hardly see it again because it contains a lot of advertisements. But she has taken the pains, in spite of the busy work schedule, burning the midnight oil, preparing the souvenir, and making it a real big thing. I think she requires all kudos, and I would like to congratulate in particular, but everyone of the team has done a wonderful job. So I just take it an occasion to congratulate them, and also to tolerating me for the last half an hour on this busy day.
Thank you. Thank you, sir. Any questions?
Sir, regarding this PPI, it's a very rampant, multiple PPIs, because patients take medicine from different hospitals.
No, what I have found in practical is that when a person goes to any specialist, naturally we give a prescription to the patient. They also don't want you to show the prescription to other people because they don't want you to know that they've gone to other doctors. So they keep it a secret. So what happens is when you prescribe something, they regularly take it. So now the cardiologist prescribes something, the gastroenterologist prescribes something. They all, because many of them contain, sometimes you have to give an antacid along with that. So they give it, but they religiously continue all what the prescriptions take without disclosing to anyone. So that's how you get this sort of, drug, this thing. So I think it is...
നമുക്ക് അതിനൊരു ചോദ്യം ചോദിക്കാം സാറേ. രാവിലെ PPI എഴുതുന്നതിന് മുമ്പ് നിങ്ങൾ വെറും വയറ്റിൽ എന്തെങ്കിലും ഗുളിക കഴിക്കുന്നുണ്ടോ എന്ന് ചോദിച്ചാൽ മിക്കവാറും അത് കിട്ടും. വെറും വയറ്റിൽ എംപ്റ്റി സ്റ്റൊമക്കിൽ എന്തെങ്കിലും ഗുളിക കഴിക്കുന്നുണ്ടോ എന്ന് ചോദിച്ചാൽ മിക്കവാറും നമുക്ക് അവർ PPIയിലാണോ അല്ലേന്ന് മനസ്സിലാവും. അപ്പോൾ ആ ചോദ്യം നമ്മൾ PPI എഴുതുന്നതിന് മുമ്പ് ചോദിക്കണം.
Pantoprazole can be taken at any time.
പിന്നെ സാറിന് ബുദ്ധിമുട്ടില്ലെങ്കിൽ ഒരു ചോദ്യം കൂടെ. സാറിൻ്റെ ഫിസിയോളജിക്കൽ ഏജ് എത്ര?
No, sir, the secret of your longevity, he is asking.
Sir, even though you were the...
persons.
Thank you, Shashidharan sir. And we thank sincerely on behalf of IMA-IMS and Perinthalmanna IMA for having stayed till the end of this session. We were planning actually to close the section at 4 p.m., but we have been successful in finishing it off at 4:10 p.m. Thank you so much. Now I hand over the mic to the organizing chairperson, Dr. Shanawaz, to close the.
Respected seniors, dear friends, delegates, faculty members and all. Indeed, it is a very pride moment for us to conduct the IMA-IMS state conference here. In Perinthalmanna, it is not very difficult to have host a conference because we have got a well-oiled mechanism here. Even though if I am the chair or Sharafuddin is the chair, Shaji sir is the chair, nothing will matters. The bus will go on because it's already set like that. If anyone is the driving seat, anybody is the checker or the conductor, it will go on like that. Because there are a lot of stalwarts here, they can they can sail the bus or the ship to the right shore. No problem. That's the same thing happened here. This is a well-organized conference, I think, because not much pitfalls has been there. We were a little bit ambitious in the beginning due to some hiccups in between us itself regarding the scientific programs and all. But anyway, we toiled it in the right manner and tackled it in a good way, I think. Thanks to all the organizing team, the delegates, the stalwarts of IMA, the senior leaders, state president, MC team, and especially the MES students and Maulana students who were here from the beginning, and the audiovisual, Murali and Amanu, they were the workhorse behind these conferences, and the audiovisual, pharma and trade companies, the delegates, faculties, because without all the trade delegates, this conference won't be a big success. You all knows that. So I'm from my heart, if any fault happens, that is because of my leadership only. If all credit goes to this organizing team, and we all shares it, I think. And especially great teamwork you have done from the editorial board, Rama madam and team. And thank you all for your guidance and all support. Qasim is here. He's always a silent worker. He always calls me in the midnight and all. He will be thinking of this conference, thinking of these things. I always tell him, don't worry, it will happen because it is Perinthalmanna. We all have this a great mechanism to have a good conference. And he was ambitious regarding the presence of delegates in the morning and in the afternoon and all. I told I have some tricks there which is kept secretly here. Because in the morning we mobilize the students, in the afternoon we put the sessions from our own team. Because Vishnu, Reema and Ramdas sir. Then these hospital peoples will definitely come and we will have a good participation. These are all our secrets behind to make this conference a big success. So thank you all faculties, delegates, trade teams, and thank you. Thank you all. These are our big secrets, don't make it public. Now we stand up for national anthem.
विनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
All please assemble for a group photo. After the group photo, we can disperse. Thank you. Please come to the stage.
We acknowledge the presence of Dr. Sajay Kumar, Malappuram district convener, who has made it at least at the last hour, coming from his rush theatre practice.